Okay, ladies and gentlemen, welcome to these public hearings, which is the first set, but the fourth public hearing in day 3. Today, we are going to hear oral submissions from Life Group, Healthcare, and Mediclinic. We were hoping to hear Nedcare also as well, to the extent that we were able to finish earlier today, so that we can have sufficient time tomorrow, but I gather that they are now not available for today. Anyway, are you ready to proceed?
Chair, I think we are just, waiting for a PowerPoint version.
Oh, okay, very well.
Just for the streaming, we sent a PDF version through, which apparently has a problem with the streaming.
Oh, yeah.
Apologies for that. We didn't realize.
Okay. Well, once that's been sorted out, you will indicate, and then we can start.
Yes, may I introduce us to who is here, just in the interim?
Please go ahead. I think if it would be helpful if you place everyone on record. Thank you.
Yes. So, good morning. So, my name is Adam Pyle. I'm an executive of Life Healthcare. I look after a number of portfolios, including strategy, health policy, and business analytics. We have taken into account some of the sessions that have happened over the last few weeks, and the questions have been asked. So I brought some of my colleagues along to help with the questions. And on my left, I have Matthew Pryor. He is intricately involved in the negotiations with the funders. And just for the record, we use the term funder because sometimes we're negotiating with the medical scheme, sometimes an administrator, sometimes a managed care organization. And as a hospital, we just generally refer to them as funders for ease.
I understand.
That's Matthew Pryor. On my right, I have Dr. Steve Taylor, and he is our clinical director, and then Dr. Sharon Vasudhavan, who is our executive for nursing and quality.
Yes, thank you. We are ready when you are. It's the same.
Not this one.
No, it's the same thing. It's just that the smallest one is smaller. You only submitted one presentation, as I understand it, which is this one. Because we have a set which is printed different, but there's just one oral submission that you made.
Correct.
Yeah, very well. Thank you.
Sorry, Chair. So, may I suggest that we're happy to start. We're sorry we didn't realize that there had to be a PowerPoint version for the actual streaming. And we'd only sent a PDF, so I think there's a PowerPoint version being sent through. So, we can start, and then maybe in terms of streaming it catches up in terms of slides, or do you want to wait?
Yes. As long as that's going to be convenient for you, that's okay with us, because we do have, your presentation here.
Then I think we should start.
Yes, very well. Thank you. Go ahead.
So just so briefly in terms of this presentation we sent through, we have that was a short. Oh, there we go. So in terms of do not make changes. No. So do we have a few problems just changing these slides? Is there a
Could someone just assist us here and just make sure that this thing runs smoothly?
There we go. So we have taken cognizance of your schedule and the purpose of this particular set of hearings, and we've tried to do a sort of broad presentation covering how we interact in the healthcare sector, and we have noted there are separate hearings going forward, which will cover issues like market concentration, profitability, returns, the regulatory environment, Section 27 in far more detail. So we've touched on these issues, but we haven't gone into them in great detail. Just in terms of the agenda, we give a brief overview of our business. We then look at the revenue drivers in terms of life healthcare from a hospital side, the price, the utilization. We touch on some of our cost drivers, some of the competitive dynamics that we have in this industry, what our relationships are with the doctors, our hospital quality, and then we briefly touch on some recommendations. The appendix we won't go through. That was just some slides showing just some of the quality measures that we have in our hospitals. Primarily, our business is an acute hospital care business. We have 50 acute hospitals with nearly 8,000 beds. In addition to that, we have a complementary services business covering primarily acute rehabilitation, mental health, renal dialysis, and a little bit of oncology, which is growing. In addition to that, which we don't really go too much into, we have some healthcare services businesses. It's an occupational health business and a wellness business. In addition to that, we have a public-private partnership. It's a company called Life Esidimeni, which has 3,500 beds, give or take. And then we have an education business through our Life College of Learning, which has 7 learning centers. And just to point that these are numbers as of our year end of 30 September last year. Just some key metrics. We admit nearly 600,000 people into hospitals every year. Our hospital days we refer to as PPDs. It's paid patient days. So if you have an admission of a person comes in for admission of 3 days, that would count as 3 PPDs. Our average length of stay is 3.6 days. We have an average occupancy of nearly 72%. We employ 14,000 people, of which 9,000 are nurses, and we have over 1,100 nurses currently in training. We just put some financial metrics there covering our revenue, the tax we pay, our VAT, and we have a capital expenditure of just over 1.1 billion. Just in terms of our geographic spread of facilities, we are in 7 of the 9 provinces, and we cover a range of facilities from multidisciplinary acute care hospitals to small and medium-sized community hospitals, and then specific facilities, including mental health, acute physical rehabilitation, and we have 3 or 4 day clinics as well. So that is just a very brief overview of Life Healthcare. I would like to touch on some of the revenue drivers. And the next slide covers the increase in revenue across our hospital division over the last 5 years. And so you'll see in 2011 we grew by 11.7%, and then 11.5% in 2012, and 9.4% in 2015. And that revenue growth is split between the revenue per day increase and a utilization increase. And the dark blue represents the revenue per day, and you can see that's ranged from 6.3% in 2011 all the way to 6.4% in 2015. That revenue per day is made up of two factors. It's made up of a price increase that we get from the funders, and it is also influenced by any potential change in what we refer to as case mix. We measure primarily it's between two areas. There's surgical cases and medical cases. We define medical cases as those cases which don't hit a theatre, and there is a difference. The revenue that a hospital gets from a surgical case is substantially higher than a medical case because there's theatre involved, etc. And so if you have an increase in surgical cases in a particular year, it will result in a higher revenue per day. So that revenue per day number is made up of price and any change in case mix. The utilization number in terms of the light blue blocks is just the increase in, as I referred to, in PPDs. So we have more patients coming into a hospital or an increased length of stay that results in more days. And when you add the two together, you get to an overall increase in our hospital revenue. Just in terms of the price, and with these slides, we'll go into some of the pricing models that Life Healthcare uses, and we'll talk about the bargaining or negotiation process that we have. So I'm not going to spend a lot of time on this slide because it has been spoken for about the consolidation of the medical schemes and the administrators. And we have seen over the years, particularly from the administrator side, because we do spend most of our negotiations are with the administrators. There has been a consolidation, and we do think that as a result of that, it has increased their bargaining power. In addition to that, there has been an increase in the number of DSPs, and that also has an influence in terms of the negotiations which happen on an annual basis. In terms of the bargaining power, our view is that it's fairly dynamic between the funders and the hospitals, and we think that there is a fairly equal balance. I mean, it does vary depending on the administrator who we're negotiating with, but on an overall basis, we think that it is fairly dynamic, and it has certainly changed over the last 10 years. And I say that because a couple of things have happened. With the consolidation and administrators getting bigger, we find that there's been a much greater emphasis on their side in terms of looking at data, analyzing that data, benchmarking, comparing efficiencies across hospital groups. And that puts you in a much better position in terms of negotiation if you at least arrive with a much better set of knowledge. The second factor has been the increase in DSPs, because a DSP is a simple thing where you, in exchange for volume, you're giving a better price. So it does give an administrator or a scheme some leverage in terms of saying we want a better price for increased volumes. We make the point there about Discovery and GEMS. Discovery, and we put them there because Discovery is our biggest client from a Life Healthcare perspective, and certainly from our side, they are the best administrator when it comes to data analysis. They have invested in systems, they have invested in people, and they do have very good analysis in terms of hospital costings and understandings. And as a result, they've got good size, they've been innovative. They have rates where they pay doctors more. They have we call it a Discovery Care Coordination Program, which has resulted in us taking discounted rates in certain areas. And we have a DRG model with Discovery, which has resulted in a lot more risk being put onto Life Healthcare. And in addition to Discovery, some of the other administrators have increased like MedScheme, have increased their analytical abilities over the years. And they're also benchmarking the groups in terms of efficiency. GEMS has increased in size. The model we have with them is still primarily a fee-for-service model, although they are starting to introduce fixed fees for a small range of procedures. Just on the right about DSPs, I mean, I think I've covered that. It's quite a dynamic market in the sense that with certain DSPs, like with Discovery, KeyCare, and Delta, we are a core part of those networks, but it's competitive. We're not part of the Discovery Smart Plan. That's a competitor of ours. We are a core partner in terms of Momentum DSP, but we are not involved in the BankMed DSP, Transmed DSPs, or MediHelp DSPs. It's we win some and we lose some, and there's a process you go through. And we obviously would like to win all the DSPs, but we don't. And we do see it from a life healthcare perspective that we think it brings sustainability and affordability to the market, and it is from our perspective a certain help to allow us to grow as a business. Just in terms of the hospital tariffs, what's included in our bill is quite simply the wards, the theatre, the equipment, the nursing service we provide, and all the stock, the drugs and consumables. What is excluded is obviously the professional fees, the radiology, pathology, and some of the emergency services, which get billed through the A&E unit, which is run by independent practitioners. Within there, and there are different models in terms of billing. So the fee-for-service billing, so you bill for everything that is charged. And prior to 2003, nearly everything was in fee-for-service. Not quite everything. We did have certain contracts which fell into an ARM, but primarily most of the billing was done through fee-for-service. So it does get a little bit complicated in terms of the process. But before, the Competition Commission had a consent order in 2002 because there was centralized bargaining between the hospitals through the association HASA, I think it had a different name in those days, and the old BHF, which was in RAMS, and there was a fee-for-service model and tariffs. And what's happened from our side is that our current fee-for-service tariff schedule is based on the old fee-for-service, but it has been updated and adjusted compared to different schemes and as the negotiations have gone on. Within the fee-for-service tariff schedule, you have different components. You've got your ward, your theatre and equipment tariffs. You have the drugs, which are governed by the single exit price. There's no dispensing fee charged, and there's no margin made. And you have the surgical component of the bill, where there's also no margin made on the surgicals. Just in terms of our tariff strategy. So going back to the late 1990s and early 2000s, the view within the Life Healthcare Group was that fee-for-service in itself was a payment methodology which was not sustainable. It created the wrong incentives. And our view was that if we wanted the industry to be sustainable, we'd have to switch away to a different pricing model where we focus more on cost containment. I mean, we also had a view that if the market was going to grow, it was going to grow into, we felt that the people who could afford private healthcare were being covered, and so it was going to grow into middle and lower income groups. Then the plans being offered by the insurers or the medical aids or medical schemes would have to be more affordable. And we saw that one of the ways for this to happen was through the increase of DSPs. You know, we haven't been wrong about the DSP growth, but what we did get wrong was the timing of it. We thought it would happen a lot earlier and be a lot more aggressive than it actually has happened. But what that resulted, though, was a move away within Life Healthcare from fee-for-service into what we call an alternative reimbursement model, an ARM. And simplistically, that's just where we take more risk, particularly on the drugs and surgicals, and it comprises two types of billing. A fixed fee, where you are typically there's a fixed fee for a particular procedure, or a per diem, which is a day rate, depending on whether the person's in ICU, general ward, high care. And within that, we would take the risk on the drugs and surgicals utilized. Just a very simple, I won't spend long on the slide, in terms of risk continuum. So within a per diem, we take risk on the price and utilization of the surgicals used. We take risk on the utilization of the drugs. The price is governed by the SCP price. Within a fixed fee, not only do you have the drugs and surgicals covered like that, but we take risk on, obviously, on the length of stay and the level of care of that patient. And then the continuum moves up. You have a hospital DRG, which is all linked into a GRG basket coding. And then you have a global DRG, which also incorporates the doctor billing, which we don't do yet. And then you have capitation risk. Just in terms of our negotiation process. And this happens every year between the months of September and, I'll say December, but sometimes December 31. And what happens is that we would look at as a group in terms of our costs that we're experiencing, the cost increases. We forecast what the increases in terms of our labor costs going to be next year, what's happening with the rand, and the rand is problematic at the moment in terms of how does it impact the cost of surgicals. We then look at our cost base, and Matthew and I will get a mandate from the executive in terms of an increase that we'd like to get from the funders. And then we go out and have the negotiations on an individual basis. The factors that influence whether we achieve our mandate or not and what type of increases we get depends on a whole range of factors. And some of this quite simply is what type of model is the administrator or medical scheme on. And there's a price increase, but what extent is that influenced by the savings that come out of our from the previous years? So, for example, we share the savings that we make or just savings that happen. So if there's a certain price level in terms of what we think the surgical cost will be, and it comes underneath that, then we share a portion of that back with the medical scheme, and it's not a money payment; it's a deduction of next year's tariff. We look at the size of the scheme. There is the payment history. Are they paying within 30 days or under 30 days? We look at whether they're DSPs, and then there's certain underlying factors that influence it. The business intelligence, the analytics ability of the administrator, and the negotiation ability. And at the end of it all, we end up in an agreement of some sort. And in terms of that agreement, just 2 important points. That agreement is then applied nationally across the group. We don't have different tariffs for different locations, and there's no differential rate that we apply to PMBs. So there's a tariff price, and it's applied nationally in standardized basis. This is just a slide which taken from CTICC. We send samples through every quarter through to them, and it's updated quarterly. So we take samples of medical, surgical cases, and maternity. We reprice it on a quarterly basis, and then send it through to CTICC. It's just showing that in terms of the price increases, that the hospital price increases have for the last since 2009 have pretty much tracked CPI. We had enough in terms of the debate about price and utilization, but from our side, we do think that there has been our price increases have been within CPI plus a half for the last number of years. In terms of utilization and some of the drivers that we see increasing our utilization, there are a number of factors. Obviously, we've had a growing medical aid population, or increasing medical aid population is now stabilized. But over the last number of years, it has increased substantially, and with that comes more people who end up going to hospital. But in addition to that, we have seen a couple of interesting trends. The one is that the utilization rate of people coming to hospital has increased. There's research done by Connex. I should note, it's a 2015 report which was put out, which measured the total admissions across the 3 main hospital groups, and it showed there was a 4% increase in admissions. It also looked at the length of stay, and it showed that there was actually a 12% increase in length of stay between 2006 and 2013. And we think this is primarily because of 2 reasons. There is a deteriorating healthcare status amongst the population. We have seen an increase in chronic diseases amongst patients admitted to our facilities since 2003. There is an aging impact, which is interesting because when you look at the numbers in terms of the overall medical scheme pool, the aging doesn't seem to be varying that widely, but we have seen quite an impact in terms of aging on our admissions. And the last point is just that we think there's a regulatory environment which potentially leads to an increase in utilization, whether it's through open enrollment or PMBs. Just in terms of aging, this is a figure from the UN Population Division about saying that between 2005 and 2030, we expect the population above 50 in South Africa to increase from 6.7 million to 10.4 million. And with it comes, we know that when patients over 50 visit hospitals, they tend to stay for longer. It's more complex, and the cost per admission is higher. And if you look at the Life Healthcare PPDs for patients in all ages from between 2010 and 2015, what is interesting is that the number of PPDs we have is fairly consistent until you start getting to about 45. And from 50 onwards, you get the increase in the days we've had in our hospital between 2015 and 2010 has been for people over the age of 50. And just in a summary, so that in terms of PPDs, we now have 45% of all PPDs come from people over the age of 50. And that represents 52% of our revenue. So you can show that there is the older you are, the longer you stay, and the more expensive that admission is. And it is something that it's a trend which we have seen, and we're not quite sure the trend going forward is, but we don't think that will change under the current environment. In terms of chronic diseases, lifestyle, which we look at across our patients who are admitted to our hospitals, and you can just see there is a trend pretty much across the board of an increasing disease of lifestyle, and that does have an impact in terms of the cases that come to hospital and the increase, and we think it's one of the drivers of length of stay. The other factor which would lead to an increase in our days is the number of beds we have. And if we increase beds and we increase occupancies or maintain occupancies, then that would obviously have an impact in terms of the number of days. So what we have done between 2010 and 2015, we've added in the region of 1,000 hospital beds, and we have kept our occupancy fairly constant at around 72%. And these two factors are linked. Like any company, we have capex constraints. We look at how we spend our capex. There have to be appropriate returns for that expenditure. And so for us to add beds, we'd only want to add the beds if we're going to get patients into those beds. And so there is a very delicate balance between adding beds and maintaining occupancies. And we think we have got quite a good balance that we've shown over the last few years in terms of the number of beds we add and keeping occupancies at 72%. We also do look very carefully what type of beds we add. So of those 1,000 beds, there's a combination of new hospitals being built, and in that time period, there's only one hospital, a new hospital that we built. Most of the beds are extensions to existing hospitals. And in addition to that, the third category would be in our mental health business. We've added a range of mental health beds. Then just quickly in terms of, we do have a slide where we go through the patient process coming through into a hospital. But there is a very close link between the funder management and a patient in hospital in terms of journey, in terms of the case management, the authorization, potential reauthorizations. And you've got the role, you've got the doctor, you've got the funder, and then you have a hospital role that goes with it. So you do have these three parties all involved in a hospital admission. Just in terms of a flow for a patient admission into hospital, it's a bit of a detailed slide, so I'll just spend a little bit of time going through it. And I'll start on the left in the green block in terms of how do patients come into a hospital. They can go to a GP for consultation, and either the GP resolves the matter, there's no admission, the GP can refer that patient to a specialist, or the GP in some cases admits the patient to hospital. The other way it comes in is the patient goes directly to a specialist, and again the specialist can either resolve that admission, the consultation with no admission, or the specialist can come into the hospital and get admitted. And the third way would be through the emergency room, where the patient goes through a triage process, sees an ER doctor. The ER doctor then can either admit that patient to hospital if necessary, or refer that patient through to a specialist. Once the patients are in hospital and they split between what we classify as a patient belonging to a medical scheme, which in case you go through a whole process regarding the authorization, which we get involved in. Sometimes we don't receive an auth, or there's an exclusion, or there's a pending auth which we try to resolve, in which case the patient may be treated as private. If there's an authorization received and we go through that normal process, then that side continues. If it's a private patient, then it falls into different categories. If it's an emergency, we admit that patient and we treat the patient. If it's not an emergency and the patient does not want to pay or can't afford to pay, then potentially that patient goes to a state hospital for admission. If it's not an emergency and we would assume that and the state has no capacity and he doesn't want to come into a private facility, then there wouldn't be an admission. So you do have these different categories of patients coming through, and it's not you'd look at that and say, well, it's not an efficient system, and there probably are some changes which we can talk about later in terms of how to potentially make this better and easier so that the patient comes in and is dealt with differently at the point of entry. Just some of the cost drivers that we face within our business. And we've broken this down is that, and these are, we've used 2013 numbers because these are the numbers we had as part of our submission. So there's some consistency between what we submitted and with the slide. Because apart from the numbers changing, the percentages don't change between 2013 and 2015. And so we have a cost of sales which make up 28% of our turnover, and there is 3 billion. Our overheads are 4.8 billion, and that is broken down between the labour and other. And labour makes up 65% of our overheads, and of that 65%, nursing makes up 81% of our labour turnover. So the biggest overhead is staffing, and the biggest component of that is nursing. We have.
Could you just go back 2 slides before?
There we go.
The flow of patient admission. Yes. You referred to a cold case. A cold case?
Yes.
Yeah. And then you referred also to an emergency case?
Yes.
Right. Is there a hot case?
No, I'm afraid it's probably an inappropriate term from our side of how we define how we call the cases, but we wouldn't call this a hot case, no.
Okay. Are there cases in between the cold case and the emergency cases?
No, I don't think so. It's just it's simply where is an elective case or is an emergency case.
I understand.
So just in terms of how we look at how we manage our cost of sales, which are drugs and surgicals, we do have a procurement division which looks at negotiating with suppliers. We spend a lot of time in terms of trying to reduce the costs of drugs and surgicals. We look at obviously we look at the product, we look at the quality of the supplier, and we look at the price. In addition to that, we have a process. We have a formulary. And that formally incorporates therapeutic interchange as well as generic substitution. We have initiatives trying to get to encourage conversion by doctors to the formulary. We monitor that across every hospital. We continuously review and trying to improve the formulary. And then the third area we look at is we look at various opportunities in terms of how to reduce costs. And the example we use here is the blood gas testing. I know it has come up in previous hearings. Simply, there was a service that's offered by the path labs in our hospitals. What we have done is we have sanitized that across. We've put our own equipment in. We use a pathologist on a consultant basis when necessary. We incorporate the blood gas tests into our hospital fee, and we think there have been significant savings to the funders because of that process. Just some examples in terms of the impact of formulary conversion. So we took the top 7 drugs by percentage conversion for 2013. And from the originator side, the cost of that in terms of our hospital utilization would be 255 million. If it was 100% switched to generic, the cost would come down to 174 million. So an 80 million rand saving, give or take, and we achieved 55 million, and we didn't achieve the other 25 million. It is a process to getting doctors to convert, and we're not always successful. And we've got 2 examples here. The example one is over a period of time where we wanted to change from an originator to a generic, and over a period of 9 months of talking to doctors and implemented, we finally got conversion, and you can see the change in terms of utilization between the originator drug and the generic. Example 2 is where we didn't get any traction. We sort of a year later, we still stuck at pretty much the same percentage between the 2. So the point I want to make here is that we spend a lot of time talking to doctors to convert, but if doctors don't want to convert, there's nothing we can do to force them to convert. We do try and encourage them, but if they don't want to change, then they don't change. Just 2 slides, and the point we want to make here is that in terms of looking at the cost of drugs versus India, and it's not to say, well, we benchmark ourselves worldwide, because we don't. It's just an opportunity we looked at, and this is to say that what do we pay for drugs here compared to a country like India? And there obviously are differences why prices are cheap in India. But we look at this and say, well, if this is what we're paying for drugs in South Africa, and there's another slide we talk about, we pay for surgical items, then we look at it in terms of what ability do we have to reduce those prices in SA, and use it in a negotiation perspective that if this is what we're paying, so we know it's getting paid in other countries at a cheaper rate, so how can we decrease the prices that we receive in this regard? In terms of nursing, so we have we know we have a shortage of registered nurses in the country. We know that there's a declining trend in registered nurses who are trained, and registered in SA as a percentage of the total nurses registered and trained. We know our nursing population is aging, and in addition to that, we have a situation where the public sector have been giving increases to nurses above CPI for a number of years. The competition between private and public for nursing is intense, and there's very little difference in terms of the salaries that one would receive in terms of public and private. And we think in some cases, actually, the salary received in public sector is higher than private. And because of this, the salary increase that the state have got has put pressure on the private sector in terms of matching that. We can't, I suppose we could just sit back and not try and match those salaries, but when you have a shortage, it results in nurses leaving, and that would be a problem for us in our business. We also see across our business an increase in pharmacy costs, and this is, it's a much smaller portion of our business, but we do see yet again that we have a shortage of pharmacists in the country. There was a period of time we saw actually no increase in terms of number of pharmacists that have been trained. We're glad that since 2012 the government have increased the number of students, but in that process between 2009 and 2014 we have seen salary inflation for pharmacists increasing at an average of 6% above CPI. And so over this period what we actually have seen is that the salary increases we give our nurses and our pharmacists are higher than what we achieve in terms of price increases that we get from the funders. So in terms of just some of very quickly, how we're trying to address the shortage of clinical skills, we have a college of learning. We train over 1,000 students every year. We've trained over 10,000 since we started the college of learning. We also have involved in training of pharmacists and funding bursaries. We're involved in the Public Health Enhancement Fund where we contribute financially. And then we have a partnership with the College of Medicines, which we put money into the training of specialists and subspecialists for the College of Medicine. In terms of some of the competitor dynamics that we have, we compete on numerous fronts. We compete with other hospital groups for specialists. We have a shortage of specialists, and there is intense competition for specialists amongst the groups. We compete on staffing for nursing staff, particularly specialized nursing. We compete on pharmacists. We compete on hospital managers. We compete against our competitors in terms of getting volumes in terms of DSPs, and we compete in overall efficiency and price, because the way we see the negotiations going and Discovery talking about relative efficiency. So what is your efficiency relative to your competitors? And if we are becoming inefficient and uncompetitive, that will have an impact in terms of not just our relationship with the funder, but the ability to win further DSPs. We compete over hospital licenses, where we see gaps in the market and trying to improve your geographic spread. We compete with them in terms of who does the GP refer the patient to. And then I suppose we compete on quality, although I'll talk about quality in a bit more detail now. In terms of relationship with the doctors, so we put up a couple of slides here about the link between hospitals and doctors. And I suppose the question is, so what do we provide? We provide a facility, we provide equipment, we provide nursing, we provide a location, we provide doctors' assistance in terms of marketing to the general practitioners. If we do a DSP, we provide a channel for which they could see their patients. And we provide a structure which allows the doctors to do their job, basically. What do the specialists bring to us? They bring their expertise that allows them to attract patients to the hospital. Referring doctors often refer because they know the specialist and they refer to that particular specialist. The anaesthetists come and work in conjunction with specialists, and then there are other supporting specialists in the hospital, such as pathologists and radiologists. And so you have, I refer to it like an ecosystem. We have a hospital with the specialists, and each party bringing various things to that relationship. In terms of our approach to, this has been raised in terms of the rental agreements. So we do have lease agreements. I think we have submitted some of those through in terms of information. The rentals are generally consistent across the doctors operating within the same hospital, or they may differ between hospitals in different regions depending on the competitive dynamics within that region. Just a couple of points about the doctor rentals. We have a policy that hospitals should not enter into these agreements with doctors that are conditional upon the admission rates of that particular specialist, and that the rentals should be openly available to other doctors of similar qualification across the hospital. There is a debate about linking the rental the doctor pays to a market rate. I suppose the market rate we use, we're trying to standardize that across our group because we'd much rather have a standard rental. But I suppose the market we look at is the market for specialist rentals. And there probably is some debate about why don't we refer to the rentals across what is a market rental for, in general, what do you pay per square meter? I suppose we look at it from what a specialist in the region pay for a square meter in terms of rental. We also have a doctor shareholding model. Around about half our beds have some form of doctor shareholding. We do like the doctor shareholding model. We think it creates a sense of ownership amongst the doctors in that hospital. We think it builds a relationship between the hospital management and the doctors, and it allows us to focus on the hospital efficiency, the hospital quality, and the reputation of the hospital. We think that it allows for a much better relationship between the parties. And we also know that the competition for specialists is intense. And we do think that it allows us to attract doctors and to retain doctors. I mean, it's not... it's part of our... we need doctors as a business to run. And so one of the tools that we have to do this is a doctor shareholding model. We have typically what happens that the Life Healthcare will have a majority stake. The doctors will operate through like a DocCo and have a minority stake. We say they're under 40%. They're typically in the range of 20-odd%. And the doctors have a shareholding within that. There is a limit in terms of what each doctor can own. It's up to 5%. But typically, in terms of the DocCo, it typically sits at around, I guess, on average between 2 and 3%. In addition to that, the doctors would receive dividends, and the dividends are paid out based on their shareholding. So if you have a 1% and we have 2%, your dividend is paid out according to your actual shareholding. It is something which, as I said, we have about 54% of our beds that we see in the group have some form of doctor shareholding. Just in terms of hospital quality, so the quality of care we give is a core value within the business, and we focus on both the clinical quality and the patient experience. And we've developed a quality management system which is based on really consistent monitoring, management, measurement, and then reporting. And we have a quality scorecard we measure across all our hospitals. And really the quality framework we have is split between 3 areas. There's a clinical component, a patient-centricity component, and there's accreditation and certification. So in terms of clinical, there's a focus on the continual improvement of clinical outcomes. And we have a process in terms of what we do, how we benchmark. There's a focus on improving the positive patient experience through our patient centricity, and then there's a combination of internal quality management system. Internal quality management we have a process of internal accreditation and external accreditation. So just in terms of some of the clinical outcomes, in our appendix we show there's a range of clinical quality outcomes we measure. If there are certain incidents, we do a root cause analysis, we do an incident investigation team, and then we look at corrective action across all our hospitals. We measure clinical quality from both a patient experience perspective, or patient experience, and from a patient incident rate, and then also we look at staffing in terms of incidents, such as needle stick injuries, for example. We have... Then in terms of patient centricity, we have, upon discharge, we have a patient experience survey where patients are asked to rate the overall hospital experience. We also have a manual comment card, which has happened throughout the hospital, and we probably get about 23,000 comment cards done every month. And that's very useful in terms of indicating both positive and negative trends. And we've introduced a care program to try and improve the patient experience of the patients in our hospital. And finally, we have an accreditation which looks at, we have internal quality audits. We have, in addition to that, we have certain hospitals go through an ISO certification on an annual basis in terms of the ISO 9001-2008 certification. We also have a number of hospitals moving towards ISO 14001, 2004 environmental accreditation. And then finally, we've been engaged in the Department of Health in terms of the national core standards. We have assessed all of our hospitals in terms of those core standards. Our hospitals all do well in terms of those core standards. And then finally, what we end up with is a scorecard, which we have, which has, well, the top block, the writing's disappeared, is the clinical indicators. So, for example, your ventilator-associated pneumonia, surgical site infections, going through to what your healthcare-associated infection rate is. We look at the patient incident rate, employee incident rate. We then have the patient experience scores. And then we have, at the bottom line, is an overall percentage attained on our quality audits across the hospitals. This scorecard is done on a hospital basis. We look at this on a monthly basis. And what it does is allows us to focus on how can we focus on continuously improving. If there are issues, how do we sort those issues out and make sure that those issues don't occur in other hospitals. Before moving on to recommendations, Amanda, I do want to add that as a group, we look at our quality and we say, well, we do all this clinical quality, we do the patient experience. And so the question comes as to, so who do we tell about our quality outcomes? And I suppose we tell ourselves. We talk to the funders about their particular quality. But what we don't do is we don't tell the patient or the consumer. And that probably is, it is an omission, because as a consumer, you do want to, I'm a consumer for healthcare, and I would want to know in terms of which hospitals have good quality outcomes, which ones don't. And so, I do think that the hospital industry has been remiss in terms of not introducing standardized metrics across the board. It's a competitive environment, and to get your competitors around the table to agree on measures is not that easy. But anyway, I think it's something that should have been done. And I think that as a group, we'd be happy in terms of having a standardized set of metrics which would allow consumers or patients to understand the quality of hospitals. We'd want to understand, obviously, you need to have standard metrics, an agreement in terms of how those metrics are measured. We'd want those metrics audited, and then they should be published so consumers can see which are the good hospitals and which aren't the good hospitals. And that's, our view of quality. We all talk about how good our quality is, but actually no one really knows about how good it is. And so that's just our, in terms of our view going forward in terms of quality. Just in terms of some of the recommendations on the regulatory side. We only touch on these because we do know there's a subsequent hearing in terms of regulations. First of all, on licensing, there is a lot of debate about licensing, and we know that all hospitals require license, and it's done on a provincial basis, and some provinces are different, and we do have challenges. And across different provinces there are different ways of interpreting the R158. Some provinces have made additions to the R158, and they don't tell us what those additions are. So it's a bit of a minefield at the moment. And just our recommendation in terms of, the way what we'd like to see is a uniform licensing model across the country. We'd like to be scientifically based. We'd like it to be transparent, and then consistently applied. Because at the moment, you can apply for a license and you will be rejected. There are no timeframes across the provinces, and sometimes you're given very good reasons why it's declined. Sometimes you're given no reasons why it's declined. Sometimes you will ask for 50 beds and you'll be given 20. And there's no reasons to why you're given 20 rather than the 50. So just in terms of our recommendation, that if we could have some form of licensing system which is more scientific, transparent, and consistent. And the same applies to our comments regarding, I suppose, certificate of need. I know that the certificate of need is seen as coming in as replacing the existing licensing regime. And so our comment is, and this is from a hospital side, and I think the certificate of need from a doctor side it's a whole different issue. But certainly from a hospital side, it just comes back to, if you're going to have a certificate of need, then we'd like that to be done on a basis which is scientific, uniform, efficient, transparent, and consistent. And that needs to also take into account about, let's just agree on what the time frame for licenses and just be sensible about that whole process. In terms of doctor employment, I mean, I know that you hear from the doctor saying they should not be employed by hospitals. We would like to have the approval to employ doctors. That's not to say that we would go out and employ every doctor in our group. But we do think that we would like to have the ability to employ doctors. We do think that have an influence in terms of some of the quality of care we have and the cost effectiveness of that care. As an example, we would like to be able to employ doctors in our accident and emergency units. That's a key part of a hospital in terms of the reputation of the hospital. It's now run by independent doctors. And for us, what we'd like to do as a group is employ the doctors in accident emergency units, agree on a standard set of protocols in terms of treatment, agree on a standard set of pricing for the accident emergency units. So across the country, there's the same process. So we do think we would like to have the right to employ doctors, and we understand that we don't bind there in terms of parameters, in terms of how the employment contracts work. I mean, they mustn't result in incorrect or bad behavior. But we think that to use as an excuse why we shouldn't employ doctors, we don't agree with. The next point about doctor training, the biggest challenge we face in the industry is a shortage of healthcare professionals. And particularly we see it amongst the specialists. We know our ratios of specialists per 1,000 are way lower than they should be. And, as a country with a shortage, I mean, we have a better ratio of specialists per 1,000 in private rather than public. But the fact is, if we don't increase the number of doctors we train and increase the number of specialists we have in this country, then you'll be heading for a real crisis. And the number of doctors we train at the moment needs to be increased substantially. And so I suppose the point we're trying to make here is that we do see this responsibility on the part of private to be more involved in terms of the training of doctors, and we would like to be a lot more collaboration between public and private in terms of training, in terms of how do we actually fundamentally change the number of doctors that we are training in South Africa. And just the last point, also would like to be able to try and make it simpler in terms of the process to bring in foreign doctors and alleviate where we have shortages. And then just the last two quick issues we're raising is Medicaid regulatory reform. I'm not going to, I've made those points here, but there has been enough, I think, a lot of debate in previous sessions about that. And then the comment about coding and quality is that, one of our suggestions is that there should be a standard DRG coding system across the country. And what that would allow for is better benchmarking in terms of price and better benchmarking in terms of quality. And we think that if that was encouraged and allowed to happen, it would have an impact in terms of positive impact in terms of not just the cost but the quality in terms of private healthcare and public health, because it should be the same standard across both of them. To do that is quite a complex process, and it needs resources and people to do it. But we think that is something that is being lacking, and would encourage to be introduced. And then we've got the appendix slides, but I won't go through this. That ends our presentation. Thank you very much.
Yes, thank you. Dr. Pengu.
Thank you for your presentation. I'll just want to start with market power between funders and facilities. Yeah, Life has got a significant presence in the Eastern Cape, if not dominance in the region. Is that the case?
Correct.
Yeah. Does this confer any advantages at all at negotiations when you're talking tariffs or DSPs?
I don't think it gives an advantage in terms of tariffs, in the sense that in the overall scheme of the country, the Eastern Cape is relatively small in terms of medical scheme numbers. And secondly, the other areas of the country, we don't have a strong position. So, and also because we do the tariffs on a national basis. So I don't think it conveys any strength from that side. On a DSP side, it certainly helps that we have a strong position in the Eastern Cape. And so but within a DSP, there'll be other areas we don't have a strong presence. So it's a strength, but it's in the overall scheme of things. We don't see it as a dominant position as such.
When you say it does have its advantages in DSPs, could it be in the context that, well, you can't leave us out of any other province, because then we will not work with you in Eastern Cape, where you actually have no alternatives. Could that be the type of advantage you're referring to?
Look, I suppose if a scheme wants countrywide coverage in terms of DSP, and they would have to look at, so, well, what do we do in the Eastern Cape? But there are DSPs where we are not the anchor of that DSP. But our hospitals in the Eastern Cape are in the network. So we don't go and say, well, if you do not include us in the DSP, you will have none of our hospitals in the Eastern Cape.
Okay. So there is no leverage that's just beyond your presence in the region that you sort of extend in other parts of the country. That's what you're saying, basically.
Well, it certainly, it certainly helps having a position where you have a strong position in a region.
Okay.
Do you want to add something?
Okay. Now, still coming back to the issue of providers and how do hospitals attract specialists to practice from their premises. We've heard references to, is it equipment? Are there other inducements? A lot has been mentioned. Now, I don't know, are you familiar with the case of a mass walkout of, I think, cardiologists from the Westville Hospital to an NHN hospital nearby?
Yes, I think it wasn't only Westville. Steve, it was intervening.
Yes, so when the eThekwini Hospital was built, a number of our doctors, partners left from the Interbeni Hospital and from the Westville Hospital. It was primarily the Interbeni Hospital that suffered, but the Westville Hospital suffered, as did Mediclinic in Pietermaritzburg, if I'm not incorrect.
Now, but if I recall, it still was mostly the Life Group that suffered the most in that regard.
Yeah, I think so, yes.
Yeah. Do you know what, because we're talking about independent practitioners here, it's not like they went for one practice. Do you have an idea of what were the incentives?
I don't know. Steve, do you know?
This is going back in time when I was in my previous role. The doctors had got together and they wanted to have a dedicated heart hospital. They had actually approached us and spoke about a dedicated heart hospital. We were in the planning of one, but it was taking time. We were looking at volumes. We had space constraints. And eThekwini arrived with a model of it. They called it, in fact, initially, I think, the Durban Heart Hospital. And they were able to recruit top caliber doctors from the various hospitals. So they really went so that we would have a big team of doctors and a big team of cardiologists. Yes, they did have the latest and greatest equipment. But I think the thrust there was that it was primarily to have the center of excellence.
But as you say, you think this is really, you didn't try to counter the offer, whatever offer they had, you say?
I mean, we certainly wanted to keep our doctors. Yeah, and so it was, but the fact is we were unsuccessful. They had made the decision to move. They wanted the heart hospital. I don't know what if there were or what the shareholding arrangements were. But obviously it has a big impact when you lose a big portion of your cardiology team from two hospitals.
Okay. So we can just put it down to they were enticed by better equipment, and we're not aware of any other reasons behind it?
I mean, I think there was the concept of the heart hospital and the equipment. There may have been a shareholding, I'm not sure. So there was probably a shareholding model they put in. I mean, I think there's a bunch of factors, and I think maybe as a collective they wanted to work together. You know, it was we tried level best to keep the cardiologists. It's not the first place that we've lost doctors to competitors.
Yes. Were you able to interview those doctors who left just to find out the reason why they were leaving?
May I just confirm? I suppose, look, it wasn't exact. I wouldn't call it a formal interview. I mean, I think there's an ongoing series of negotiations or discussions with the doctors.
Yes.
You know, once we found out the hospital's opening, we found out what the intentions were.
Yeah.
You know, obviously, we were concerned that we would lose some of our doctors. Then once we found out that there were a number of our doctors who were going to go to this hospital, you know, there were discussions as to why are you going, and what discussions come out from the doctor, and you don't really know whether it's the real intentions, but they did speak about the fact that they wanted a dedicated heart hospital.
What you are telling us really is what transpired in the course of those negotiations.
Correct.
Yeah.
Yeah, thank you. Moving on to the group growth, you have a slide here from 2010 about hospital bed growth and occupancy. How has Life really achieved this growth? Is it through organic growth or mainly acquisitions? You're free to refer to earlier period than 2010.
Yes, I think our growth has gone through various stages. So if you go back to the 90s, maybe even the early 2000s, a lot of that growth was through acquisition. But over the last number of years, the acquisitions have really stopped. I think our last acquisition was the Bay Hospital, which was probably in 2011, 2012, around there. Yes, and then you've got, we acquired a small 14-bed maternity unit, last year. Most of the growth of the last 5 years has been organic, in the sense that we built one hospital, the rest have been brownfield expansions, and then mental health.
Okay. Yeah, it was around 2001 when you acquired Amalgamated?
I think it was, yes.
Yeah. And Velgers, when was that?
When Life Health, what the history of the company was that it was a division of Afrox, and then it became a listed company called Afrox Healthcare. When it became Afrox Healthcare, we did a reverse listing into a company that was then called Presmed. And Wilgehevel was a hospital was in the Presmed stable. So we acquired via that reverse listing onto the Johannesburg Stock Exchange.
And then Bayview was subsequent to that. Yeah.
Correct.
Okay. But there may be others. I'm not so much interested in the detail. But at the time of acquisition, were these hospitals profitable in their own right?
I think there would be yes. I think the majority of them were profitable. I mean, I don't know about the profitability of the hospitals within the Presmed group, and the range of hospitals. That's before my time in the late 90s. The Emma hospitals were profitable. Bayview was profitable, yes.
Yeah, among, obviously, when one acquires a company, one expects that there would be changes at some level operationally. But regarding tariffs in particular, how did these acquisitions affect tariff structures of the target companies?
So let me answer from like what I know about it for Bayview. So Bayview, I would assume, would be part of the NHN. would have been on their tariff structure. So when we acquire Bayview, what would happen was that hospital would come onto our tariff structure. And then you have to go through a process in the hospital of changing from primarily what we would think as a fee-for-service model into our ARMs. And then once it's all effective, they come onto our ARM pricing structure.
Which effectively is what? Is higher or lower than the target company's structure?
I suppose my guess is you'd have to ask the funders for a true analysis in terms of procedures. I mean, we spin and say, look, we've got the hospital. We want a particular hospital for a certain reason. We put them onto our tariff structure. We don't look at, what their tariff structures are because we're going to put them onto our model. And our model brings us our own different benefits. I mean, I think the better person to answer would probably be a funder in terms of Discovery or a med scheme.
Now, are you suggesting that it's possible that you could acquire a company and put it on your tariff structure and effectively reduce their tariffs? Are you saying the panel must believe that that is a possibility?
I suppose the process we went through with Bayview was that it went through the Competition Commission, and there was a process in terms of I think they included, I'm pretty sure Discovery were part of that process, in terms of saying, if Bayview goes on to life, is there any fundamental impact in terms of the price that Discovery would be paying? And that answer was no. So you may have a case where an independent hospital comes onto life and there is a difference. Maybe it becomes more expensive, maybe it becomes cheaper. I don't know.
We'll come back to this, but the problem with that is that it seems to suggest that your pricing is haphazard. It doesn't seem to be. There doesn't seem to be a strategy behind it, which I don't know if I can believe at this stage, but I'll take that.
Sorry, Doctor, I'm not quite sure why you would say that.
No, I mean, you're saying you don't know whether those the effect has been to raise or reduce the prices at the target or acquired company. But it's fine. Can we move on to your relationship with Joint Medical Holdings? What is the nature of that relationship? Or what was the nature of that relationship?
So we don't have a relationship with... Sorry.
I do think that if you do want to do so, you please do so. Comment on the proposition that your tariffs are haphazard, if you so wish.
Sorry, I'm getting comments from both sides here.
No, I understand. Please do tell them that they are quite at liberty.
They seem scared.
To speak for themselves. Unless, of course, you want an explanation why there is the suggestion that your prices are haphazard.
Perhaps that would be useful. But in order to understand the potential impacts of the change in the tariff structure and level, we would be usually, in the case of Bayview, they would be in a fee-for-service tariff environment. So when they came onto an alternative reimbursement structure, it might well be that you might be acquiring a company that is significantly more inefficient than the life healthcare average. And so therefore, there might be a decrease in the level of revenue that the target company now has under an alternative reimbursement as opposed to in a fee-for-service model. But
the net result of this is that you are actually not sure, because the issue of what model you're using to pay, whether it's fee-for-service or alternative, they may be different, but ultimately the company will know what the bottom line impact is, whether whichever payment system is used.
So we certainly wouldn't know the real impact of the company we were acquiring, given that we wouldn't have the data in order to be able to take their tariffs through our models in order to know the actual impact of the tariffs on that company.
All right. Going back to Joint Medical Holdings, you were, I think, explaining what business relationship there is or there was in the past.
Yes, so there is no business relationship now with JMH.
Yes.
Beforehand, we had a shareholding within JMH, and there's been a process with the Competition Commission, but we no longer we tried to increase that shareholding. We went through a whole process. It didn't work, and now we have sold our shareholding, and we now have no relationship with JMH.
Okay. Did the business relationship start at the point when you acquired shares or prior to that?
Mike, just hold on for a second. There's
Okay.
sorry, a lot of this happened before my time at Life
I
Healthcare.
understand.
So what happened was that PresMed had a 25% stake in JMH.
Yeah.
So when we acquired PresMed through that reverse takeover, then what we did is we inherited a 25% stake in JMH. And there was a subsequent increase in that shareholding to 49%.
Okay. Still on the issue of tariffs, what was the impact at JMH level when you acquired and subsequently raised the stake?
I don't know, actually. I mean, this goes back to, I think the initial acquisition happened when there was centralized bargaining happening. So, that was in 1999. So I would expect at that point there'd be no change in terms of tariffs.
Yeah. Is there any, okay, no change, as you say, but is there is an acquisition that in Mpumalanga didn't go through?
Correct.
Why didn't it go through?
So this was an acquisition to acquire a single hospital in Nelspruit. The Competition Commission declined it. And they said one of the reasons given was that it would have a negative impact on competition in the area. And I think primarily because they said it would result in an increase in the tariff structures. That's my guess what they said.
Yeah.
We tried to appeal that to take it through the tribunal. The fact is that it just took so long that the seller in the process then changed his mind.
Okay.
And so then we didn't follow through with the transaction.
Yeah, I suppose the point here is the, I think the point specifically about the potential increase in tariffs. You haven't been able to give me a certain answer what happened to Bayview and as well to Joint Medical Holdings. But the one specific example that we've got is where the Competition Commission says you are raising prices. Now, am I unreasonable to sort of wonder, because we can obviously get to this in focused hearings when we look at the tariff structures. Now, if it so happens that we find that tariffs were raised at the acquired companies, should we, okay, maybe let me not preempt it, but I just want to say that there would be a point of interest, because the concern here would be the pricing. Is it really related to the cost of bringing service to the patient, plus obviously a fair return, or you're pricing to the maximum that the market will bear? Because that is the question that I'm asking now, and I want to link it to your slide.
Yeah, I don't think we certainly don't price to the maximum. Look, I'm not quite sure what the maximum in terms of what the market could bear would be. I mean, in the case with Nelspruit, I mean, I suppose we didn't get the opportunity in the tribunal to put our case forward in terms of why we would have been adding, we think, more competition to the Nelspruit market, in the sense that we would have invested some more money into that facility in terms of expanding it. We would have been able to drive, we think, DSPs in the Nelspruit market, which would have resulted in prices coming down. But that's hearsay, because that process never really happened. And I think once we have the session on tariffs, models, returns, etc., I think some of this will come out. I mean, I just want to make the point that it is quite, within an environment we charge a fixed fee. So you have a fixed fee for a particular procedure. It's quite easy then to benchmark what the tariff or what the overall price is for that procedure. In a fee-for-service environment, where you just charge for everything, it becomes quite hard to do analysis in terms of comparison, because then up to what the doctors use and utilize, and you just charge for it. So you have a whole range of variation in terms of what a particular procedure is charged for. So when you have and also there is issues in terms of comparing data. So, our views in terms of when we look at the hospitals, it's, does it add to our geographic network? And does it allow the group to grow? I mean, we certainly look at it as an asset in terms of returns. And then once we acquire that asset, it's how do we put that asset onto our model, not just from a pricing perspective, but in terms of an administrative perspective and HR perspective, and then we go from there.
Okay. No,
I think what would be helpful, Nate, is that if you would bear this question in mind, so that when we come to those sections which will be specifically devoted to probing these issues, you are able to respond in a way that you would like to respond. I do understand what was conveyed to you as being the purpose of this section.
Okay, so
Yes.
Thanks very much for your presentation. At least partly what we're trying to understand in these sessions is how everything works together, and who does what where. And for me, I'm trying to understand how it is that we have these different systems and they all work so collegially and nicely together. And you have these different models, and so there are cost savings, but the price that people have to pay for medical scheme membership just never goes down. So if there are these benefits that you're passing on, where do they get lost? Why are medical scheme memberships continuing to rise, whereas you have these economies of scale and you absorb the prices and you don't pass on costs and you don't do markups and why are medical scheme memberships fees not going down?
I suppose I'd answer in the sense that you've got two components to the expenditure in terms of medical schemes. And so there is I'll put to one side the utilization component in terms of the increased utilization. Then in terms of our pricing models, there are underlying cost drivers which we face. Our biggest costs are nursing, and those costs are increasing at higher than CPI, substantially higher. We have an impact in terms of the rand, in terms of our drugs and surgicals. So we do have underlying drivers which are higher than inflation. In terms of the cost savings, in terms of models, we do look at driving efficiencies, and we do look at trying to keep our prices at a CPI type level, despite underlying costs. And the only way we can do that is by driving efficiencies. So there are savings which we pass back in terms of we hope there are savings. It depends on how well we manage our surgicals during the year. But I think the combination of the utilization and the underlying cost drivers results in medical prices increasing. As a consumer, we experience it substantially above CPI.
So then looking at utilization, there are different ways of interpreting the fact that more beds, constant utilization, either as I think you were suggesting, that you manage this very well, or because there's some supplier-induced demand to keep utilization at the same level in spite of increasing numbers of beds. Because if there's a correlation between increasing beds and same level of utilization, there are various possibilities of what makes that correlation. And so that then, for me, also raises a question around the shareholding of doctors and this alignment of interests. So you say the alignment of interests are about quality control or potentially getting them to use generics or whatever it is. But the alignment of interests could arguably also be around maintaining profit. Is that possible?
It would be possible, certainly. You know, I do think, though, that with the specialists reimbursed on a fee-for-service basis, you know, the model for a specialist, and it is more direct, that the higher your volumes as a specialist, the more you're going to get reimbursed by a funder. So the direct incentive as a specialist, if you wanted to earn more income, would be to do more cases, because straight away you're getting a higher reimbursement for the extra volumes you're doing. And I suppose you could argue that there's an underlying that the shareholding feeds into it, but we think it's far less direct. It has a much smaller impact. And we do think that from our side, that the way the shareholdings are structured, we certainly don't encourage inappropriate admissions. We certainly don't encourage increased length of stay from our doctors. In fact, in certain cases, as an increased length of stay would cost us money in terms of our models.
You don't have to encourage it. They might just be motivated to do it themselves.
Maybe.
So we have information about the benefit of some form of negotiation around fees, and then the negative consequences of not being able to set those fees. But everyone seems to refer to them anyway. So everyone says, oh, well, we use the reference price list and we've just updated it. And so there's some inconsistency in saying that if we could set fees, it would be better, but actually we still use the fees. So in the hospital market, are you saying that in fact it's generally still using that same reference price list plus inflation that guides all the decision making?
No, so what I can talk about from our side. So I think the point we're making is that when there was collective bargaining, you had a fee-for-service tariff structure. But since then, you know, from a life healthcare perspective, we've gone down our different models. I'm just saying that within that fee-for-service, that the underlying structures remained, but things that may have changed in terms of new coding, new technology, different prices, that's changed. So I don't think the fee-for-service underlying model has changed much from before 2002. But from our models, they have substantially changed in terms of fixed fees, per diems, etc.
Thank you for that explanation. In relation to the ARMs, we've also been presented with some information to suggest that the carve-outs are such that the ARMs, in fact, that you've presented us in one of your slides the increasing risk in relation to risk transfer depending on the model. And there has been information that's been put in some of the submissions to suggest that the carve-outs are such that the risk that you bear is in fact minimal because the carve-outs are so significant. Do you have any comment on that?
Yes, I just want to check one figure. It's 97%. Yes. So, I mean, there is certainly a debate on how much risk you take. And as an organization, we would obviously only want to take risk that we think we can manage. But despite that, we in our contracts, 97% of what we build falls part of the area and outside of a fee-for-service. And I mean, there are certain carve-outs, but primarily we cover the vast majority of, it's over 97% in terms of that. The risk transfer within that obviously varies in terms of whether it's a fixed fee or a per diem. Because the per diem, we don't take length of stay risk or level of care risk. So I'm not sure if I would agree with the risk transfer. I mean, we have been on a journey. And when we started, it was, I think, only 70% was per diem, so no fixed fees. that we increase that and we increase the fixed fees. And I think this journey continues. You know, we have a DRG contract with Discovery which places a lot of risk onto us in terms of, so there is a, I mean, it does vary in terms of the negotiations, and the risk obviously does vary within that.
We always hear from the big three that you negotiate prices at a national level. And so therefore the regional dominance doesn't actually matter because you're always negotiating at a national level. Is it the case that in your contracts all prices at all hospitals are the same?
They're the same across an agreement. So so for example, if we agree with Discovery or MedScheme what that rate is, that rate is then applied on a standard basis across all the regions. So the prices would be the same. So you may have, yes, they'd be exactly the same. We don't, and the reason we don't do it on a local level, because I mean it would be, we have we had a conversation earlier about we're in a strong position in the Eastern Cape, so it would be quite tempting to say, well, in the Eastern Cape we want to have a different tariff level. But the fact is that there are far more regions in the country we don't have a strong position, and then the opposite would apply. So it's just been much easier for us, and I think it's a correct approach in terms of saying if a patient comes in for a certain procedure from a certain scheme, whether they come into a hospital in Johannesburg, Cape Town, Durban, East London, is exactly the same tariff.
There couldn't possibly be a situation where you're dominant in the Eastern Cape, another group's dominant in the Western Cape, and all this works very nicely for everyone because then you all have at least a dominance somewhere so that when you negotiate you say, well, you need us because we're in the East. That couldn't happen, could it?
I mean, I think in terms of negotiation, look, there's a negotiation which happens. We'd far rather have a stronger position in the bigger cities rather than the Eastern Cape, just because of the size of the Eastern Cape, despite my colleague coming from East London. So, I mean, it certainly is a strategy amongst the groups to expand their geographic presence around the country, because it does lead us into a position where you can go to a funder and say, look, we can cover this percentage of your members in terms of DSP. So let's do a DSP because that allows you to get a better price and we can increase our volumes. But the fact is there are no groups that can do that. There's no group that covers the country nationally properly. In fact, you would be hard-pressed to get two groups into a network only which could give national coverage.
I suppose that's my point, is that if you can at least have a foothold somewhere, you can then say, you can't leave us out of anywhere else because we'll withdraw from here. So it's very nice if you've got the Eastern Cape and another group's got the Western Cape and another group's got Limpopo.
I mean, I suppose our preference would be we'd like to be in a good position in all regions. But, I mean, your point is that it's certainly with, and I think I covered earlier in terms of, there are DSPs which we are excluded from, but we do offer coverage in the Eastern Cape. And we do it on the basis that we hope that when it comes to the next round of negotiating that DSP, that we have an opportunity to negotiate and get back into that DSP.
I'm changing subject. Okay.
Can I just make a point? Is that I think it's important also to say that if we were excluded in a particular area and we wanted to make that up through charging excessive pricing within a particular region, for example, the level of charging that we would have to apply in order to make that up would be unrealistic. The Eastern Cape, for example, is quite a small portion of our total beds and our total revenue. So if we were excluded on a national basis and we only had the Eastern Cape in which to make up some sort of amount of revenue, we would have to charge exorbitant rates in the Eastern Cape in order to make that up, and we would destroy the relationship with that medical scheme or administrator forever. These are always long-term relationships and partnerships, and so we would suggest that, I mean, I think it would be different if we had complete dominance on, two provinces or three provinces such as Gauteng, and the Western Cape, but I don't think it's like that.
I mean, just to point that Eastern Cape, I mean, I suppose our position is stronger in East London. I mean, in Port Elizabeth, there's very strong competition, between ourselves and Necare and so on.
Do you own an ambulance service?
No.
So the other groups do have ambulance services. One of the submissions, one of the interviews that we did indicated from an independent hospital that it was enormously difficult for them to, they started off opening a casualty and they had to close it because the ambulances drove past their hospital to their parent body hospitals that were close by. Do you have a similar experience? Are you disadvantaged? Do the other hospitals use this in a way that you have a problem?
You know, we had we did have a shareholding in ER24, but we got out of that in, I'm not sure the exact year, but my guess is around 2005, 2006. I mean, we had a business reasons, but also we didn't like the business. We didn't like the ambulance business, and so we haven't. And so we were concerned that our two major competitors have an ambulance business, so we don't. But we don't. We hear the stories that the ambulances drive past. You know, I'd be a little disappointed if I was picked up by a paramedic, and the paramedic didn't make the decisions based on what is the nearest, most appropriate facility to take me, and drove me past a certain hospital, taken to their hospital. But you know, those are, I mean, I don't know, those are anecdotal. We haven't really seen an impact in terms of our accident emergency units because of that.
The non-pharmaceutical supplies, in their submission to us and also in the public hearing, they told us that they were forced by the hospital groups to place on invoice inflated prices, and then there were rebates that were paid. Do you have any knowledge of this? Have you ever been engaged in such activities?
That certainly wouldn't benefit us now in terms of an ARM. You know, our objective, I thought you were going to ask the question, is do we bully the suppliers into pushing their prices down? You know, because our objective is to get surgicals at the cheapest possible price. So in terms of the ARM, we're not making money in a fee-for-service environment, and I think you have to go back to the pre-2002, where there was a system where, as a hospital, you would buy a product at 100, you'd mark it up, or you have a rebate, and then you make money that way. In terms of our current model, it's all about how can we get surgicals at a cheapest possible cost.
So it's not happening now, but in your knowledge, did it ever happen?
My guess, there was a process going back to before 2003, 2002, in terms of how the hospital tariffs were structured. And so there was a system with a similar system to that with drugs, and there's a process with surgicals. I think with drugs that disappeared with SEP, and there was a process in 2006-07 where no markup or margin we made in terms of surgicals. You know, for us, most of that was already in an ARM anyway, so we're going down a process. So, but then even on a fee-for-service percentage, then you wouldn't have any margin on the surgicals charged. So that certainly happened in the past. I don't know whether hospital groups are doing it now. I mean, it certainly wouldn't be in our interest to do it.
So,
Can I just
what is it that happened? Forcing
Yes, I just wanted to.
pharmacists to inflate prices?
I just wanted to clarify. Certainly, we've never engaged in activity where we would force suppliers to up their invoice prices, their list prices.
So at the point that there were no markups on drugs, and then later when there was no markups on surgicals, shouldn't we have seen a drop in your income concomitant with these no longer markups happening?
Yes, but no. So what happened was there was and for both of them there's a different time in terms of a process. So I'll start with the surgicals and work back to the drugs. So with surgicals, the vast majority of our tariffs were within ARM, our pricing was within ARM. And so how we looked at surgicals, so when they said there's no margin in surgicals, it had no impact in terms of, we still charge the same price for a hip replacement. And when you feed back into the drugs, what happened, actually I should start it the way around. Historically, you have your tariffs, you have your drugs, and your surgicals. And the way the old tariff structure worked was that the hospitals made profits or margins on the drugs and the surgicals, and that subsidized some of the profits made on the wards and theatre. And so what happened was when the pricing was reduced in terms of the drugs, that was transferred into the wards and theatre. That's what the process that happened on a cost-neutral basis to the scheme. So there wasn't a decrease in terms of hospital prices. Do you want to add in?
It's a bit disconcerting from a consumer point of view that no matter how we can decrease costs in terms of input costs, the price for the consumer remains constant. Seems to be counterintuitive.
Well, I suppose we'd look at it in terms of saying, so let's look at that's a snapshot in terms of the hospital, what the hospital bills in terms of there's a component called drugs. So what you should do is let's go down a proper process in terms of what are the returns that hospitals should be making, and take the entire hospital bill. That's everything included, the wards, the theatre, the drugs, the surgicals, and then work out what is an appropriate price, or what is an appropriate methodology to bill, first of all. Then what are appropriate prices within that methodology, and then say, is it appropriate or not? I suppose the issue with SEP with drugs, there was one sliver saying, no, we're going to reduce that, and that's it. But the fact is the margins made from drugs were involved in subsidizing some of the wards and theatres. So my response is that we're quite happy to go on a process in terms of saying, but look at it from a complete process in terms of what hospitals earn, what are returns, then the model and the pricing.
I suppose that's why this market's so complicated, because if I need a hip replacement, I need a hip replacement, and whatever I have to pay, I have to pay. And quite how you make it up is your business.
Can I just add, I suppose one of the places, for example, we have seen reduction in consumer pricing is where DSPs have come into play by the medical schemes. So we do have efficiency discounted options being developed by those medical schemes, the discount ranging between 10 to 20%. And certainly we would suggest that the competition that happens around DSPs has driven those prices down.
So DSPs have driven prices down, but I'm still paying more and more every year for my medical aid membership.
I think if you move onto an efficiency discounted option, you might pay less than last year.
Okay.
You're right about it is a complex market, and I think part of the issue is we probably make it too complicated. It's difficult enough. I look for my personal as a consumer to understand what plan I'm on and the benefits I get from my plan, and I have a knowledge of the industry. And the way hospital pricing is done is also complicated. And so, what we try and look at is saying, so how do you, in terms of going forward, how do you set up a structure which allows funders, and I say the funders because they would, in terms of transparency, allow them to measure the efficiencies of hospitals, which hospitals are good and bad in terms of cost, allows them to measure hospitals across on a quality basis. And that's why we do say there should be some form of standardized DRG coding which would allow that. And so it allows them to, and I say DRG because then that allows you to take into account, it's an apples to apples comparison. So you get away from, I'm seeing sicker patients, or the hospital saying, oh, my patients are older, etc. And within that, then you need a pricing model, which we do think should be more towards an area model, where hospitals are incentivized to manage their cost. And if they do that, they should be rewarded for it. If they don't, they shouldn't be. It's rather than on an environment where you just charge for everything that you consume.
So you're suggesting that if I hang on long enough and DRGs come in, I can look forward to paying less, and your shareholders are going to be happy because they're going to, something's got to give.
Well, I think it would help drive efficiency within the system. Whether that makes our shareholders happy, I don't know. Or whether we both hang on long enough to get price decreases, I don't know. But it would certainly help in terms of that process.
I wanted to go on to the issue about providing attractive and good services so that doctors want to work where in your hospitals. One of the issues that has come to our attention is around the issue of nursing, and there have been a statement that hospitals have decreased the absolute number of nurses per ward, and that it might not be your hospital, I have no idea, that the level of qualification of the nurses has decreased, so we have more staff nurses rather than whatever. That prices, for example, for some products that you use in theatre have gone up because the people who supply it bring in their own nurses because the theatre nurses don't know how to use all these products. And so one of the consequences of that, we've heard from some of the practitioner groups, is that they will, after an operation, send a patient to high care or ICU rather than to the general ward because you cannot trust the nursing in the general ward. Is this a reasonable argument on the doctor's part? And what implication does that have on your bottom line, given that your high care and your ICU are now being more highly utilized?
I'll let my colleague comment on that. I'll talk at the end a little about the utilization of ICUs.
Thank you very much. Just in terms of admitting patients to high care and ICU, that is doctor preference. That they would like their patients to be nursed in those environments in the first 12 to 24 hours. In terms of the quality of staff that we have between our specialist units and the wards, obviously for the specialist units we have specialized nurses who are already in short supply in this country, and our nurse-patient ratios are much lower in specialist units. So I suppose there is an assumption then that your patients will get better care in those units. Our general wards we also have the same categories of staff: general nurses, our registered nurses, enrolled nurses, and nursing auxiliaries. And our staffing of our general units and specialist units are based on a level of care, patient acuity, and the activities. So obviously a sicker patient would need a high level of care. Over the years, I cannot say that we've reduced the number of nurses in our units. We also have to be mindful that nationally we have a shortage of registered nurses in the country, and so you would use your nurses more appropriately, but we would not run general wards without registered nurses. We may have fewer registered nurses, but we do have registered nurses, and then they are supported by enrolled nurses and nursing auxiliaries.
Just to make sure that I understand what your answer is, you see, the questions that we asked were premised on the first proposition, and that is hospitals have decreased the number of nurses deliberately for whatever reason. So what do you say to that question?
I say that the number of nurses have increased year on year. We have statistics to prove that. We do our staffing on an annual basis, and we can show that there is an increase in the number of nurses that come on board annually.
So the short answer is you haven't decreased the number of nurses.
No.
It's simply because of the shortage of nurses. Yes.
So the doctors are wrong. There aren't fewer nurses. You can trust the general wards, and they are admitting to ICU and high care because their patients are sicker, or I don't know, doctor, whatever constitutes doctor preference.
I think there's probably two components here. The one is the number of nurses. And I think we've dealt with that in terms of we haven't We're definitely not deliberately trying to drive down our nurse numbers. And I think within that, you've got a mix in terms of your specialized nurses. And the second component is then in terms of quality. The nurses you have, what is the quality like of those nurses? And so, our view with the specialists would be that they shouldn't just be admitting to ICU or high care because they have a concern about the quality of our nurses. If they do have a concern, they should be addressing it with us as a group. We have no intention of trying to get patients into ICUs. We have hospitals where we have full ICUs. We can't admit patients into the hospital because in case they need to go to ICU. So certainly wouldn't, and in terms of our overall goal of trying to be on a relative efficiency basis, the more the doctors admit patients to ICUs, the more inefficient we become in terms of the eyes of people like Discovery. So we would be concerned that if specialists are doing that, and I think there have been discussions with specialists who at certain hospitals say, look, we are worried about the nursing in these particular wards, we want you to sort it out. I mean, I think it's an ongoing discussion in every single hospital and probably every single day.
In one of the submissions in the last few weeks, we heard that hospital managers, individual hospital managers, have service level agreements with the group. And again, this might not be your hospitals, I don't know, and that part of their service level agreements include a measure on occupancy rates, and that the proposal that was put to us was that the individual hospital managers would promote activities that would keep the occupancy rates as good as they could, because that was part of their service level agreement. Does this make sense to you?
I suppose our hospital managers as employees are reimbursed in a certain way, and there certainly are, in terms of remuneration strategies, that are measured on the performance of that hospital. And there are certain metrics. I mean, I'm not sure whether that agreements have been sent through. If not, we're quite happy to send copies through to have a look at. And they cover financial metrics, they cover quality metrics, and they cover BE metrics within that hospital. So I wouldn't say there are, per se, you will achieve this in terms of occupancy, but occupancy is an important component because it shows the utilization of the hospital. So if you have a lower occupancy, you're not going to hit your financial metrics. So I suppose the issue for us is then, is the hospital manager doing the right things to improve occupancy rather than incorrect things? So the right things for us would be for the hospital manager to say, do I have a sufficient complement of specialists in my hospital? And do I have the right mix of specialists in that hospital? Are the specialists in my hospital full-time? Because you might have specialists there who are doing 80% of their work somewhere else and coming in. So how do I encourage them to say, listen, you hear why, is there a problem with the hospital, why you're only working 1 day a week and not 5 days a week? Is there something that we are doing that's incorrect? We would look at saying, is the accident emergency unit offering a decent service to the community? Are the GPs in the area referring to our doctors? And if not, why not? Is there a problem? Are we not? Is there not enough information going back to them? Do they have service issues? So that's fine. If a hospital manager was saying to the specialist, we want you to inappropriately admit patients into a hospital or inappropriately keep patients in for longer, that is something as a group we would not tolerate. And I think if that happened, I have no recollection of it ever happening in terms of life healthcare. And I suspect that if a hospital manager went into our doctors and said this, they'd be kicked out of that office so quickly, and they'd be reported to us. So it's not. Although it sounds a fine line in terms of driving occupancy, for us it's quite a clear distinction between what is right and what's wrong in terms of business practice.
One of the issues that people have spoken about is the role of the private sector in terms of its responsibility in terms of access to care for as a basic human right, access to health care. And in relation to that, one of the problems you've brought up is the issue of the fact that we don't have enough doctors in the country to service the entire population. To that extent, do you keep any data or any watch on doctors who are in full-time employ in the public sector, but might well have RWAPS agreements and then work in your hospitals? Do you know, or do you have any interest in watching that they are working the hours that they're allowed to work?
I'm going to ask my colleague, Dr. Taylor, to answer that.
Right. Sorry. It's important to understand the context of RWAPs. These doctors are employed by the state, and when a doctor arrives at Life Healthcare and wishes to have admission privileges, how does he arrive? Well, or she. Generally, it'll be the existing doctors who there's somebody retiring, or they see that we've got the capacity, and then they would be recruiting the person. But if a doctor arrived per se, said, look, I would like to have admission privileges, the first thing we'd do is we would check that they had HPCSA registration. And it may sound very simple, but in fact a lot of doctors have, and I don't want to divert too much, but a lot of doctors have registration which will be for the public sector only. And so we've got to first of all check that they're entitled to work in the private sector. If he comes via one of our own doctors and he's done a reference check, we will probably accept that. But if it's somebody who arrives and we don't know this person, we will phone, if he's a new graduate, we will phone his ex-head of department, we'll phone colleagues, we'll ask our own doctors from our medical advisory committees to get a reference check, to check that he is a high-caliber doctor. Then the question comes, a lot of these doctors will arrive and they will be working at multiple hospitals. And sometimes they will work as many as 4 to 5 hospitals. Now, if he is part of a state contract, we're not privy to this contract that he's got with the state. I believe that some of the provinces even have variable types of how they do this. So he may be on a sessional basis, he may be on a 5/8 basis, he may be on a full-time basis. He's got 100 hours that he's allowed to spend. And really we see that as a duty it's for the state to manage that expensive resource, which is under remunerative work outside the public sector. So, no, we don't know always if he has got an RWAPS agreement or not. And we don't have the privilege of seeing those agreements. I think I'd stop there to say that, so we don't know. And it is a private matter between himself and the state. He may also not tell us that he's got an RWAPS agreement.
You could ask.
Yes, we could ask. And generally, I think it would come out.
Thank you.
Thank you. My question is more on your negotiations with funders. In your written submissions as well as today, you talk about one of your key strategies, of course, containments, which is the use of alternative reimbursement models. In your written submission, you make reference to GEMS largely using the fee-for-service model, and you explain that you try to discourage funders for opting for that model through levying a premium if they choose to do that. I'd like to know what are the reasons that GEMS put forward for wanting to continue on using the fee-for-service model.
Yes, I'll start and then Matthew can come in. So I think when GEMS started, we can understand them wanting to stay in a fee-for-service environment because it's about, I suppose they were growing. and they wanted to collect as much data as possible, get an understanding in terms of and get a record in terms of what is utilization like with the membership, etc. So we can understand the starting in that environment. We had hoped that by now they would be able to move across into a different type of model, which an ARM type model. The reason the comment you made about there's a premium is because we don't, within life, we don't differentiate between whether a scheme is on an ARM or fee-for-service. So what happens is that then we go through a whole process in terms of procurement to try and drive down prices in terms of the surgicals and drugs. And we go through a process with the doctors getting to switch product to try and make healthcare more affordable and to try and bring the cost down. In a fee-for-service environment, 100% of that benefit goes back to the scheme. Whereas in an ARM environment, we share those benefits between the scheme and ourselves. And so to discourage everyone going into a fee-for-service environment, we say, look, if you're going to benefit from all this, but we don't think it's fair because your other schemes who are in the model don't get the full benefit. There's a shared operation. So that's why we have a different structure. But I'd like to say that I don't think we were particularly successful in terms of having a premium in terms of the tariff on gems, just the nature of gems and its size.
GEMS has started to develop some ARMs, and we are now introducing some new fixed fees with them. I think the primary reason for them not going on was for them to build up data around understanding the utilization so that they could know that there was cost neutrality in moving across from fee-for-service into an alternative reimbursement model.
In both your written submission and today, you've focused much on the larger schemes, that is on the open side, Discovery and GEMS. And I'd like to know what do you perceive yourself to be, to have power in regards to negotiating with the smaller medical schemes?
I think that would depend on the scheme. Certainly sometimes size helps you, sometimes it doesn't help. So if we have smaller schemes, they have choices. They can go join a bigger administrator and get, if they want to. But sometimes we have small schemes who arrive and say, and it's happened in the last couple of years where they've said, this is the price we want. If you don't give us this price, we're going to introduce the DSP, and we're not going to include you in the DSP. And we will actively drive members away from your hospitals. We will contact the doctors, and that's the process they go through. And so it's a yes and no. If it's small and it hasn't done any analysis, it doesn't have an idea in terms of benchmarking, in terms of whether we are efficient or inefficient, then it's to the scheme's disadvantage. But if they are smaller, they've done that work, then it's less about size. It's more about how they prepare for the negotiations, the information they have. That makes sense? Sorry.
Yes, thank you. My second question is around your discussion of market dynamics influencing utilization on private hospitals. On slide 18, you make reference to, as one of the explanatory factors, longer lengths of stay in hospital. In the very first set of the public hearings, we had the World Health Organization come to present the study benchmarking South African hospitals. And one of the key findings was that they were higher, on average, admissions were higher, and the average length of stay was lower in South Africa compared to the other OECD countries. I'd like to know what your comment is, given that you here are stating that you have longer lengths of stay.
I think our comment here, first of all, is that the length of stay is increasing, and it has increased from 2006 onwards. The OECD report is, we're not economists, but we have asked an economic group just to have a look at the methodologies they've used. We have general comments we don't agree with. The fact that it refers to a GDP per capita and it refers to private here versus public and private in Europe, etc. And there potentially are other ways in terms of looking at affordability. Do you look at actually what does a case cost here versus Europe, and on a case-adjusted basis, and you introduce purchasing power parity, all those issues. So, and I suppose the question then comes into length of stay is, first of all, how do you define length of stay? Because it does differ between countries. And secondly, what is included in your length of stay? Are day cases included or not? And so it would be nice with the OECD, actually would have liked to have a conversation with them during the study to say, what are you measuring? Can we agree on a set of benchmarks in terms of how you define length of stay, what's in, what's out? So we can arrive at a research paper which then says, this is how you compare to the OECD countries in terms of admission rates, length of stay, etc. So that's my comment in terms of length of stay. The second thing about utilization and admission rate, again, it's quite hard to compare admission rate for private here versus public and private in Europe, but that's not something which we drive. It's what the doctors, it's between the doctors and the funders in terms of, is a person admitted to a hospital or not.
Thank you, Jefferson.
Yes. Thank you.
Good morning. And thank you for your presentation. I think you also did what we asked you to do and concentrate on, global an overview of how you encounter the stakeholders, who your stakeholders are, and you left the deeper discussion to the next sessions that we will have on competitive dynamics in our regulatory environment. So thank you very much for doing that. And I'll try also to confine myself to more high-level discussion with you. I'd like to raise one issue that you haven't raised and one issue that you have raised, and then maybe give the journalists some breaking news from your side on that. So they're awake now. On what you haven't mentioned is we in the submission before, we heard that, and that was this association representing day hospitals associated with NHN. They mentioned that actually, in theory, about 75 procedures could be done on a day hospital basis. At the moment, that's 7%, I think, in South Africa. And compared to other continents or other spheres, it's actually very low. How the penetration of day hospitals into your arena has taken place. And one of the explanations that was presented to us was that actually the big groups are not so much favoring day hospitals, because that would represent a lowering of their income, because these techniques are most of the time more cost efficient. People get out of hospital per definition at the end of the day, and less cost means also less turnover for the hospitals. That was one possible explanation, and when we asked, they told us that there is a tendency, or they observed a tendency that the hospital groups buy day hospitals and close them down. My question to you is, have you done that before? Did you buy day hospitals from the areas where you are active and close them down?
We certainly don't go through a process of deliberately buying out day clinics just to shut them down.
So it hasn't been happening in the history of life?
So it's not our intention to do that, and we certainly don't do that.
And my question is, has it happened?
Well, actually, the question, so it came down to when we did the deal with PresMed. With PresMed in 1999, yes. There was the reverse takeover of Afrox Healthcare and PresMed. And within the PresMed stable of hospitals, there were, I think it was 13 day clinics, right, which we took on. So I suppose the question is, what have we done with those day clinics, and do we have them? I think there's probably 2 or 3 left out of the 13. And in terms of what's happened to 13, I did listen to that. I had to go and find out what had happened. And we can send you a schedule per day clinic in terms of what's happened. It's a combination of, we sold some because we didn't get them to work. We closed some down. We have incorporated a couple into our hospitals. And I think there's I suppose a general comment about life healthcare and day clinics. We do have a couple of day clinics, and you are quite right, there is a much lower percentage of cases happening at day clinics in South Africa compared to elsewhere in the world. And I think some is down to some of the licensing, the fact that not a lot of day clinics around, although it is increasing. I think there's also a factor that, doctors work in a hospital. There is a shortage of doctors. So for them to leave the hospital and go treat patients down the road in a day clinic and then come back and treat patients, hospitals is inconvenient. I'm not saying it's a good reason. I'm just saying that's potentially one of the reasons why you don't have these cases happening in day clinics. And I think from a third perspective, from a life healthcare view, I don't think we've been particularly good, actually, at running day clinics. It's not, our day clinics we have in our business don't do that well. And we've still got them. We try very hard to make them work. Maybe we're not good enough at it. Maybe we're missing something. So it's so to answer your questions, if we don't deliberately go out to buy it, we certainly have tight capex constraints in our business. We'd much rather focus it on growing our existing business, and we would certainly like to be able to get to a grip with managing and understanding day clinics, because we do see there's a trend going forward. We do see that as a trend with technology, the way things change, and more cases will be happening in a day setting as such.
Yeah, because I'm from Europe, and what we see in Europe, especially where I come from, you see general hospitals also running day clinics from their hospital, from their own organization, set up the day clinics. They close down locations, for example, concentrate locations, and then use these locations to run day clinics for quite a percentage of their turnover. So they do both. And of course, these techniques, these less invasive techniques of operating people, new techniques operate and incentivize new forms of organization. I was just wondering, why does that not happen? And your explanation that doctors find it hard to move from one to other. There's another more positive element to it. On the nursing side, the people appear to be they like to work in day clinics because they can go home at 4 o'clock and don't have these awkward times and disrupt their families and their social life, etc. So there's a lot to, for me as a lay person, I'm not a doctor, but there's a lot of pro arguments in organizing a lot of and of course cost arguments in organizing day clinics.
Right. Yes, I mean we do within our hospitals have a lot of day wards, yes, which I suppose are treated on the same basis. You come in and you're out. Yeah. And certainly part of our strategies going forward is we are looking at how do we increase the incidence of day clinics on sites next to our hospitals. So you take away the issue of the doctor travel, etc. You do more procedures in those day clinics. That is a process we're going down. I mean, and maybe we've been too slow in terms of that process. I mean, some of it's a pull and push. Technology changes and you can start driving it. I mean, we clearly understand that as you go forward in the role of technology, that a lot of the procedures are going to change, and that you will have a lot more cases happening on a day basis. And as a group, we have to adjust and deal with that.
I think so. So we would appreciate your, what happened to these day clinics, and also your strategic view on life's view on day clinics and prospects of day clinics in South Africa, and its possible contribution in bringing down costs.
Okay.
Thank you very much. Now up to the breaking news. You said that it's on quality, and I appreciate what you said on quality and also the openness and the frankness in which you said. In my words, we actually should have done it. Am I right? That's about what you said.
Correct.
That's right. Now, my question, of course, the starting question is, why haven't you done it?
I suppose there's a couple of factors. I mean, the first is that we have been our own quality journey. I mean, we only really started. I mean, there's certain things we've always measured within our business, but the introduction of things like surgical site infections, ventilator-associated only measurements, only really started doing it effectively, measuring across our hospitals from 2008. So I suppose it's fairly recent in our history we started doing these clinical measures. The second, and you go down a journey. The second thing, I do think it is, I suppose we're asking ourselves to police ourselves, in the sense that as a hospital group, so we're going to put this out publicly, and I suppose we don't do it at the moment because there's a bit of a vacuum.
Yeah.
And so if Life Healthcare said, well, we're going to publish our quality information, there's nothing, still not really a comparative. You can say, well, we can compare life hospitals, but we can't compare life to Necker and so on.
Yeah.
And I don't think there hasn't been a there's no real agreement amongst the groups in terms of, and even the public sector, apart from the core standards coming in
we'll
now
come to
about,
that. Yeah, yeah.
what are those metrics? How should we be measuring them?
Yes.
And how do you communicate those measures? And
I first want to understand. So why, it's not. I don't want to. It's not a matter of blaming you or Mediclinic or Netcare or whoever not publishing this info. I just want to understand how the situation is such in South Africa. Excuse my English. How I hear my English is not not correct, but how does what part of the context explains that you are not sort of obliged or incentivized to publish this information? When I arrived to South Africa, I said to my colleagues, the only explanation is then that consumers don't matter that much. Of course, probably it will be on the first sentence of your strategic documents, the consumers. But in actuality, in fact, during your negotiations with schemes, you negotiate with schemes, you don't negotiate with consumers. My sense is that that will not be the first line during your negotiations, what consumers think of your hospitals.
I mean, we do. I mean, it's interesting because you're raising a sort of conundrum here that because we do take the quality of care seriously, we do take the patient experience seriously, but we don't communicate it to the consumer. So it does seem odd.
You don't communicate. Do you communicate to the scheme? That was actually my.
Oh yes, we have reviews with the schemes, and we say, look, here are our quality scores, and here's our patient satisfaction. With the number of schemes, we actually break it down to their members only. This is what your members.
Are they interested?
The interest varies across.
Is that a diplomatic answer?
Yes. Look, it does vary. Yes, some are very concerned about it, and some they always have an interest. It's a question what you do with that interest. Yeah. And I suppose there are two things I would like to add. It's the first that I suppose one of the reasons why we didn't put it out publicly and agree on it is that we saw at Life, and maybe the other groups saw also, that the quality we would be going through in terms of our group and the measures we were doing would give us a competitive advantage. That would help us get more DSPs.
Yes.
And so therefore sitting with our competitors and say, let's agree on national standards around quality.
Let's come back on that later, yeah. But I first want to sort of explain or try to explain why you haven't been incentivized to publish them earlier. And the breaking news, of course, I'm getting it, I'm after for the journalists, is when are you going to publish them as from now? So you can think about it already. That's going to be my last answer, my last question to you. What you said is that some schemes are interested, but the majority is not interested in our story about our metrics, about what we measure in terms of quality.
I think there's always an interest from the scheme. I mean, I think, and what we've seen recently is certainly a desire to say, listen, this is more, especially with DSPs growing. I think there's now starting to get interest about saying it's not just about price, it's about the quality that you are going to provide our members. I think part of the problem the schemes face is, the challenge we face, is that there isn't standard metrics used by the three groups across measures. So they say, oh, you arrive and we look at your quality stats, they look very nice, but actually, how do we know they're actually better than your competitors, because it isn't a standard process?
Absolutely. So that's a very important. So you want to go back to that point again and again, and you're right. It's very important, of course, that the information and that the competition between hospital groups is not on the metrics. So they don't use all their own metrics and then we compete on the metrics. We should compete on the quality based on standardized, uniform, comparable, and representative measures of quality. You're absolutely right. But now we're entering a minefield, isn't it? Because you measure your own metrics at the moment, and with all respect, I looked at them in the appendix, and they're good. I think there's only one really referring to clinical quality in the sense that it's the cardiac matrices. They are, by the way, internationally comparable. Everybody in the world uses the same metrics here on clinical quality, on cardiac intervention, isn't it? These are the standard. You have taken them from the standard.
Yes.
Yes. And you could actually compare yourself to the United States and Europe on these metrics, isn't it?
Correct.
Do you do that?
We do. We
And are
do
you-
compare it, and I'm trying to remember the last time we compared and what the outcome was.
Yes, sorry, Dr. van Gent. Our acute myocardial infarction bundle is really based on a European Cardiology
Yes.
Society.
Yes.
I don't know if I'm speaking too much, but we compare our mortality rate by hospital with each other, and we send it back to the hospitals on a monthly basis, and it goes to the medical advisory committees on a quarterly basis.
Yes.
And we do compare that to the international rate,
Yes.
and we are below the international rate. We intensively look at the acute myocardial infarction bundle and that cardiac bundle. Now that's the AMI rate, as you'd appreciate, it will vary from area to area depending on if they're diabetics or hypertensives. And
Of course.
funnily enough, sometimes the very best doctors have higher rates because they're dealing with the most complicated cases.
Yeah.
And we really do go into that on intensively.
Yeah.
There are some other measures. You know, we have all these normal bundles, you know, the CORTI bundles, the hospital-acquired infection bundles, which are really nursing-driven and doctor cooperation. We do have other rates that we look at quite carefully, which would be perinatal mortality rates.
Yes.
The Vermont-Oxford network,
Yes.
which is for the panel. This is a international measure of neonatal care.
Yeah.
And we do get outcome measures.
Yes.
It's a very, very positive system where on a quarterly basis, you will get a report back. It's an international, it's an American-based organization, I think with about 800 hospitals. And then you'd go through what went wrong. You know, one of the outcomes, it's not an outcome, but what was the temperature of the baby when the baby arrived in the neonatal ICU?
Yeah.
Wow, your rate is lower than the international average.
Yeah.
So that's where we go back to international. Why was it lower? And then it goes to all kind of micro detail, which I won't bore the panel with. But it does mean that there is so we do that sort of, and then on DVTs and strokes,
Yes.
we have international bundles that we're looking at, and we compare ourselves with international outcomes.
I admire the set that you already have. Of course, you will appreciate it's still a limited set if you compare to some countries in Europe and the United States and England, where per DRG you can have sets of matrix defined, and that's quite an exercise. It might be worth a while, but it's quite an exercise. But this is a good start. Now let's go to the. So I think it's a good start also to publish a part of what you're collecting here already over a number of years. So it must be quite stable and comparable to international standards. So there's nothing wrong, I think, in publishing these in South Africa, Mr. Paul. So
I suppose the point is we publish them in our annual report and they're on our website, but it's on a group basis.
that's right.
Yes, it's not on a.
That's not
on a
what I'm getting at.
hospital- Yes, it's not on a hospital basis.
No.
And look, it is a debate we have about. Do we publish all these scores?
Yes.
And put them out on a per hospital basis?
Okay.
And I suppose it's a question is about there is a concern. How does the consumer deal with that? Is it seen as a good thing or bad thing when it's in a vacuum? And I don't know that we don't know the answer.
Yes, I know, and nobody knows the answer. But we have seen, of course, abroad, countries where this happens and has been happening already for sometimes 7, 8, 9 years, and nothing bad happened. I mean, people are able to understand to an appreciable degree what is being published, especially if you publish it in a way that it is understandable and there's right text around it where you explain what is this. But I agree that it would be much. Because I saw your metrics, and these metrics, of course, Doctor just explained to me as well, are largely around what you as a hospital can influence. It's largely around nurses, medication, etc., etc. needle failures, etc. And it's largely not around what doctors can influence. And of course, quite a bit of the clinical excellence of a hospital depends on your performance, but also the doctor's performance and the way they cooperate during the clinical path. Have you been talking to your doctors on this, on cooperation between yourselves and your doctors, on, first of all, agreeing on matrices which are meaningful, and measuring these, the data and the matrices, and ultimately publishing them?
Right. We have a structure called medical advisory committees, and I could supply the panel with the constitution. But the prime aim, and sorry just to labour on it, but the prime aim of a medical advisory committee is to maximise cooperation within the hospital to ensure quality patient care. And you've made the point. The person has an episode of disease. The doctor does the workup. The doctor does all the diagnostics, a lot of the expense. And then there are a few frames in that picture where we come into the picture, right, and then he goes out of that frame again. Yeah. And so that's quite so to influence them in terms of the earlier frames and the post frames. Now, as was stated earlier, yes, we do have discussions with our doctors, but a lot of them at the moment are revolving around the crisis we have in obstetric insurance. I'm sure the panel is well aware of it, the 650,000 rand a year, and the need for protocols which would start outside the hospital and end after the hospital. And remembering that, if a patient is discharged from our hospital, we don't know what happens to him afterwards. We don't know whether he gets an infection, whether he's got a long-term complication, or in fact, let's be positive, the majority of them, if they've had a fantastic outcome.
That's a different.
So the idea of having a way of rating a doctor, who would we have to involve? We'd have to involve the the regulatory body, whose ultimate responsibility it is, the doctors and their groupings,
yes,
the funders,
yes,
the hospital groups,
yes,
and then most importantly, the patients.
But if you don't do it, Discovery will. So the experience abroad is that there's largely three groups that have initiated these quite complex trajectories of getting to meaningful matrices of quality, clinical quality, involving both the hospital side and the doctor's side. There's three parties can do it. Abroad, the larger healthcare insurers have taken initiative and using their money to do that, leaving both hospitals and doctors not very happy most of the time. The state can do it. I've been responsible for that for 4 years. Leaving all parties not really happy because they take the initiative. And the initiative should, of course, be doctors and hospitals, because they are responsible. Do you feel yourself responsible for clinical quality, also of the quality that is provided within your walls by doctors?
Yes, we feel responsible for the clinical quality within our hospitals, and in fact going further than that. But if I could just go back to in the event that we were able to give doctors the choice to be employed by the private sector, obviously our ability to get together with that doctor as a partner and manage his quality would be enormous. So if we had doctors as, we could then set down these other guidelines and so on, and they'd have to be international guidelines.
I understand that.
That would solve that problem instantly.
I understand.
And we did say initially we don't want to employ all doctors, but let's say the standard of care in A&E units.
Yeah.
There was a complaint earlier in the commission that the doctors are very young and inexperienced, I think. Well, we could handle that problem. In terms of doctors overall, are we worried about that experience? He said, are we worried about them before and afterwards? If we get anecdotal evidence that the doctor's outcomes are poor, even though maybe technically his operation looked great, we will institute an inquiry via our medical advisory committees into the doctor's conduct.
I understand. it's not the area that I want to go into. The area is, do you feel responsible for the quality provided within your walls? And then the idea that doctors can't be employed in South Africa, we're all aware of that factor, and the inquiry will look into that factor as well. But I don't think it's the major influence. I'm from a country where hospitals can employ doctors, either employ doctors or contract them, like you do. And whether they're employed or contracted, the fact remains that you have to convince them to cooperate in providing clinical information on their services. And that's almost irrespective of whether they're employed or not. It's a matter of convincing these people that you are responsible for what is happening within your walls, between your walls, sorry. So it's not, you can't use it, I'm not accusing, but you can't use it as an excuse of not having that conversation and very...
Dr. van Gent, I agree with you. We have a doctor partnership attitude,
Yeah.
and as this starts to evolve, for those doctors to have the best possible outcomes, is going to involve us involving them in discussions around the whole treatment path.
I think we could go on for half an hour here, but I'm actually still, and the journalists are waiting for the breaking news now. Mr. Pyle, then when are you going to publish your data on quality?
Look, I don't know. I mean, it's certainly something which...
That's not a breaking news.
No, it's not breaking news. But, I might give them some breaking news and I might not have a job the next day. But, look, it is...
So that's honest news.
I don't know, but it's certainly something that we're going to have to, I think, rectify as a group. And the first preference would be that you have standards which the whole industry do. But if we can't get to, because I don't know what our competitors think about our position on this.
So you take this, take this back to your board.
Yes.
What will your personal
our personal
point of departure be?
Would be that we should actually, as a group, publicize in a correct way the quality outcomes
next year
of our hospitals. I mean, we could do it next year. I mean, it's probably next year, probably better.
It is a matter that you need to reflect upon, isn't it?
Yes.
Yeah, and then take a decision, right?
Maybe we should reflect during the break then, Judge. Maybe we should reflect during the break and then come back on the issue.
Is there anything that you want to add to this question, to the answer?
No, just the point you made about, and it is a point that in Europe the funders have, or the insurers have been driving it.
Yeah.
And so as a point from us, is that if we don't, as a hospital with the doctors, do it ourselves, it's going to be imposed upon us by the insurers, yes, or the funders.
Okay, the time now is 11 o'clock. Would this be would this be the convenient time to take a break? A tea break?
Yes.
It's been a long morning, isn't it? Yes, indeed. Thank you. Okay. What time are we supposed to come back? We will come back at 11:25 so that we can start at 12:30.
You really got there.
Huh?
I'm saying you really got there.
Yes, I wonder if it would be convenient to resume the proceeding, Mr. Pine.
Certainly.
Yes, very well. I just want to pick up on the conversation that you had with my colleague Van Gand. Now, we were told last week by Discovery that at some point an attempt was made to consider publishing information often concerning the quality of the services that's being performed at facilities, but that the reaction of the hospital groups was that that shouldn't be done. And as a consequence of that, they stopped. Are you aware of that initiative?
I am, yes.
You are?
Yes.
Could you perhaps indicate to us precisely what were the reasons for objecting to that?
Yes, I think the objection was less about the publication of that information. It was more about the accuracy of the data that fed into it. Mm-hmm. And there was, it was quite a complex exercise Discovery undertook because they were taking doctor coding and hospital coding, combining it, and then delivering efficiencies or outcomes. And our view was that there were a number of cases, and I even remember there was a carte blanche example of one of our hospitals given, which was shown as being completely out of line in terms of pricing.
Yes.
But actually what had happened was as incorrect doctor coding had fed into it. So the reaction from the hospitals, I think, was twofold. If you're going to do this, you need to do it properly, and it needs to be accurate.
Yes.
Discovery now have gone down the route. They've started on the patient satisfaction. There was an engagement certainly with us, and I presume with other hospital groups in terms of doing it. And they now publish the patient satisfaction scores. And Dr. Brumberg, at the hearing, he also mentioned they're now looking at doing the clinical outcomes. And I'm pretty sure there'll be a process in terms of talking to us, and then they will, as we discussed earlier, they're going to do it.
Yeah. So there wasn't any objection in principle, but it was really in relation to how you do it. Is that an accurate way of putting it?
Yes,
that is
accurate. I mean, it's
or
also...
Or was it both?
A little bit of both, because it's... because, it's... I suppose it's somebody else telling you this is publicly, this is how we're doing. And it does come back to the point about, well, maybe you should be doing it. We should be doing it ourselves.
Yeah. Okay. Now, what has brought about this change of mind now?
I think there's the quality it's a journey you go on. Mm-hmm. And we really have, as a group since 2008, Isabel, a focus on driving some of the quality outcomes in our group. Yes. And, we've had lots of debate internally about should we release this information. I suppose what really got the debate going within us was when Discovery came back to us last year and said we're going to release this patient satisfaction scores from the hospitals, that we're going to do it publicly. And then there was a discussion was, well, if they're going to do that, then the question, should we be doing that? And then should we also be doing it not for patient satisfaction, but should we be doing it across on clinical basis? So that was probably the vent which got us thinking again about publicizing the quality data.
But I understand that you're going to take the issue to the board. Is that what you said earlier today?
Yes, so we'll take it back to the executive.
Yeah.
But there's a discussion going on at the executive level.
Well, are you saying that there have been ongoing discussion on this particular issue?
Correct.
Yeah. And since when?
I suppose these discussions have happened since 2008 on a haphazard basis, when we at an executive level. And I suppose they've increased in intensity in terms of frequency and intensity since the Discovery ratings.
I think the issue that I'm really focusing on is making the information available to patients. I think that's really the issue that I'm focusing on. That the discussion on whether information pertaining to the services or the quality of the services at the facilities should be published and should be made available to patients. Have you had that debate before?
Yes.
Okay. Is that a discussion that commenced in 2008?
Yes. But
Okay.
yes.
So today you're telling us that you will now take the matter back to the executive.
I think the comment is that I think we made was a couple of things. First of all, I think we are remiss in terms of not publicizing this information earlier. And secondly, there is a process where we're going down and saying, do we actually start releasing our data and how do we do it?
Yeah. Yes. I think what I'm really trying to find out is that when we consider this issue, if it becomes necessary to do so, what are the obstacles that we should keep in mind which prevented hospital, at least your hospital, from publishing this information in the past, so that we can put in place mechanisms that will make sure that that doesn't happen. So that is why I'm trying to find out whether what is the explanation for this change in attitude. And you are aware that since the beginning of these hearings, in particular with the funders, one of the issues that has become somewhat prominent is the issue of information on the quality of the services being made available to the funders. And we were told by all that they don't publish that information. And they all suggested to us that they think they should. At least some of them did say that. Now, I just want to find out whether whatever may have prevented you in the past from publishing this information has since been removed.
Okay. I think there's two components here, so I may answer it. In terms of, so what would be the ideal world?
Yeah.
And the ideal world would be where there is agreement in terms of the quality metrics across the country. I wouldn't just say private, but also public. And there's core standards, but I think what we were recommending is saying more than the core standards. Yeah. You have agreement in terms of the metrics. You have agreement amongst the hospitals and doctors about how you measure those metrics, and it's standardized. Yeah. And then there is a publication or that, and it's done in an appropriate, and there's auditing and it's done appropriately. That would be an ideal world. The world we are now, that doesn't exist. Yeah. And so our challenge, so the question is, how do you get there? Yeah. I suppose you could say, well, we're going to let the private healthcare groups do it themselves, and maybe that, and that hasn't happened in the past. The question, will it happen in the future? I'm not sure. Yeah. Maybe if the groups take the initiative and Life says, well, you know what, we're going to publish our data anyway. Yeah. And maybe that forces or encourages other groups to do so, and then you start going down the road in terms of agreement and metrics.
Yeah. Yes. I think the issue of who has to do it is not so much my concern. The real issue for me is the principle of it. Why has it not been done in the past? Are the factors that prevented it from being done in the past, have those been removed so that the way is now clear for that to be done? It may well be that it's something that never crossed your mind.
Look, I don't think the obstacles have been removed. So Life takes a stake and says, right, we are going to publish our data. We still have concerns that that data goes out and it's really in a vacuum. So when you look at it and you go, that Life Healthcare Hospital, I don't like their quality metrics, so I'm not going there, but you've got no comparison to a competitor hospital. And so maybe it's an advantage, maybe it's a disadvantage. We're quite conservative with this, so maybe we should just take the leap and do it and see what the outcome is. But I might have a hard time persuading my colleagues, the executive, to do that. So I think the obstacles haven't gone away. It's a question whether we are sort of brave enough to do it.
Perhaps it may somewhat help, though, if one focuses for a moment on the consumer. I mean, are consumers entitled to know the kind of quality of service that's performed by different hospitals?
I would say yes.
Yeah. I mean, for obvious reasons, that information is vital for them to make an informed choice as to which hospital, to go to in the event they fall sick.
Correct.
Now, and if that factor is uppermost in the mind of hospital group, then why is it, I think, has that not been done?
So, look, I can't comment on other hospital groups.
Yeah.
I mean, but we do agree with the principle that, a patient or a consumer should have better information about a hospital and about doctors, and should be able to make a more informed choice in terms of their choice of which hospital they go to. So the question of why hasn't been done, I think we've addressed some of those issues in terms of the standards, etc.
It is understandable that there may be a reluctance on the part of a hospital to publish information that, oh, by the way, we had an operation last week and some object was left in the stomach of a person in the course of an operation. Because that would undermine profits, would it not?
It may do. Yes. I think certainly there would be a concern if you said, let's take the 60-odd hospitals in Life Healthcare and we publicize them, we rank them. I mean, there's certainly a concern that if I'm the hospital manager because there has to be ranking them in terms of their performance, there's always a hospital at the bottom. Whereas performance, if you benchmark it, there are hospitals that do better than others. But I think it's sort of part of the process. If you want to improve your quality, you want to improve, then you do need to go down that process.
I can understand the desire on the one hand to want to improve the quality by publishing this information or making it available, but at the same time ensuring that in making this information available, this will not adversely impact on the business.
Yes, and I think that what's important is that the information that goes out is appropriate, correct information, which allows consumers to make an appropriate decision, and if it's all correct and done appropriately, that's fine. I mean, I suppose the real challenge in all this is how do you do it so that consumers don't make an inappropriate decision or hospitals or businesses aren't unfairly influenced or rated because of a score which is interpreted wrongly.
There is a shortage of nurses. You've alluded to that fact. Is that right?
Shortage of nurses?
Of nurses.
Yes.
Yeah.
Yes.
And there's also a shortage of specialists.
Correct.
And you have to compete to attract those to your facility.
Correct.
Yes. Now, in relation to specialists, do you offer them any incentive to come to your facility?
I think there's, in the documentation we've submitted, I think there's a process in terms of maybe a reallocation allowance if they're coming from a different area. There may be...
shareholding?
Sorry?
Shareholding?
Yes, there could be, there could be shareholding which they buy into. Yeah. There could be...
subsidizing rooms?
There's a rental, and which would... It depends whether, you can say, well, is it a subsidized rental because it's not truly market related, or whether it's...
What's your real interest in specialists?
Well, I suppose without the specialist, you don't have a hospital business.
Yes. And there is an expectation that if you have these specialists with you, people would follow those specialists
Correct.
for treatment.
Correct.
So there is an expectation that they will bring patients here. They will attract patients.
Yes.
Yes. Now, do specialists have a say in who are the additional specialists who might be offered admission facilities?
They generally would have a say. The process would be that the hospital manager would say discussion, so there's wanting an orthopedic surgeon, and there'll be discussion with existing orthopedic surgeons about bringing additional doctor, and then also discussions about the particular doctor coming.
So you would expect, at least for example, orthopedic surgeons to decide whether or not an additional orthopedic surgeon is necessary?
I mean, we do involve them in the discussion. I think the end of the day, the decision is ours, because you do have different dynamics. You might have an orthopedic surgeon saying, we don't want you to bring in more surgeons because it's going to take business away from us. You do have a dynamic where it could be, we do want you need to bring in another surgeon because we're doing all the cover work at the accident emergency unit. We're not going to do it every weekend now. Yeah. So you do have a different dynamic.
Yes. We were told earlier on in these proceedings that a psychiatrist was offered admission rights at one of the facilities, but that one of his colleagues objected to this psychiatrist being granted admitting rights to this particular facility. As a result of that objection, management changed its mind. Does that happen? It could happen.
It could happen. It may happen. Sometimes it probably does happen.
And the effect of that is that a specialist is now prevented from enjoying admission rights at the hospital, at the facility.
I think the admission rights, it could be about having rooms at the facility.
Yeah, that's right.
So you may have a situation where a doctor is prevented from having rooms at the hospital, and it could be because the hospital is full. It could be because there's a lack of demand. But you're right. There could be a position where a specialist doesn't get rooms at a particular hospital. But sorry, just yes, the clarity is, as Matthew said, that you may not have rooms, but you still have admission rights. I mean, sometimes it's a bit. Yeah.
The nurses. There is a shortage of nurses. You've told us about that. Is that right?
Correct.
Yeah. How do you cope with that?
I'll ask my colleague, Sharon, to answer this charge of nursing.
Thank you. So we train our own nurses as a group. So we have the Life College of Learning, and we train both pre-registration and post-basic nurses. We also are currently, for our specialist nurses, we train a number of them at the university, so we sponsor their training. And also, furthermore, we've also embarked on foreign recruitment, where we
those that are being trained and who qualify, those are recent trainees or graduate nurses. They don't have the kind of skill that you would require at an intensive care unit, is it?
The newly qualified ones, not they won't have it.
Okay. I'm concerned at the moment with the skills that you require at this. I think the term that they've used here is high care facility, high care unit, is it? Is that the term?
Yes.
Okay. Is that the intensive care unit?
Well, we have intensive care units and high care units.
Oh, what's the difference between the two?
The more critically ill patients go to intensive care units, and they could be ventilated and non-ventilated. And then those that are critical but just need observation, we could keep in a high care unit.
Now, do you have sufficient skilled nurses to look after the patient at intensive care units, high care facilities?
We do not.
You don't know. Now, how do you cope?
We use a number of approaches. One, through training more.
Yeah.
Secondly, through foreign recruitment. We are recruiting specialist nurses from India as a group. It is a very long process, but we continue to persevere on that. And then we also use agency staff to also staff both our specialist units and the wards.
But when you say you are experiencing shortage of nurses at these high care units and the intensive care unit, I just want to know that how do you cope with that? Do you put in people who are less skilled because you want to cope with the shortage whilst you're training others or recruiting? How do you manage the situation, the need?
So with the agency staff, so we staff our units up to for 75% occupancy, and we have a flexible component of 25%, and that's the 25%. If our units progress beyond 75% occupancy, we will draw in from the agency.
Yes. I mean,
and that is how we would staff.
Does it happen, perhaps, that you have less skilled nurses working at these units?
I wouldn't say that they are less skilled. We would have a balance between qualified nurses, those that have actually done the speciality, and perhaps experienced nurses who would work in conjunction with the qualified nurses.
Yes.
So, and they would operate at that level.
Yes. There is a term that one sometimes hears about called moonlighting. What does that mean?
Moonlighting is something that, nurses do as part of earning more income. They would seek, employment, temporary employment in other facilities outside of their permanent employment.
Yeah. So they would work for 2 facilities, or maybe 3.
Yes.
How does that impact on the quality of care?
I think that, it does have influence the quality of care.
Yeah.
The quality of nursing care has been an issue in the country, and I think both the public and private sectors. And I think a number of initiatives have been pursued in terms of addressing the quality of care.
Yes.
And I think the whole issue of moonlighting is an age-old problem in nursing, where we don't seem to have sufficient mechanisms in place to ensure that we have this continual movement of nurses from the public sector into the private, and private nurses work in public through the agency agreement.
I mean, does it happen, for instance, that a nurse would work at one facility during the day and then in the evening work at another facility?
Well, not to our knowledge where we had to deal with it directly, but there's a lot of, anecdotal evidence to that effect, that nurses try to keep 2 jobs to augment their salaries. They could work in 2 facilities. I have to say, from my point of view and Life Healthcare point of view, if we identified something like that, we would deal with it directly. The challenge we have is that most of the time, the nurses, we do not contract with those nurses who work overtime. We only contract with our own staff who work overtime in our units. The rest of the nurses come through an agency. And so we have service level agreements with our agencies. And so we would depend on them to kind of do that contracting.
Yeah. Are there any mechanisms that you've put in place to ensure that you don't have a situation where a nurse work in one facility during the day and then in the evening goes to another facility to work?
Not directly with the nurses, but through the agencies, we have a service level agreement. We expect them to be registered. They register the nurses on their system. We also inquire from them that, expect from them to know whether these people are in full-time employ in the public sector or with any other group, and they should keep a record of that.
So, but other than the service level agreement with the agency, is there any other mechanism?
No, not necessarily.
Have you considered that?
Well, it becomes more and more necessary as we hear about the moonlighting and as it influences the quality of care. And so sometimes, for me, it seems like it's a national problem. It needs both, the public and private sector to put their heads together to come up with an intervention that will resolve this, so that we can actually get to a point where we can manage this. And also in terms of our nursing resources, are we training sufficient nurses? Because as long as we're in this demand and supply mode, we're going to have nurses rotating through the different sectors. And this needs to become a national priority that we drive jointly to address the issue.
Is there any limit, on the nurses that you can train per year?
Yes, there is.
Is it what, 1,000, 1,000? How much? How many?
Our college is accredited by the South African Nursing Council.
Right.
And they will put a limit in terms of the number of students you can take per program, per clinical facility.
I understand.
And that is based on the clinical learning opportunities in those facilities.
Right. But does that work? Does that work out?
It works for us. We are permanently requesting additional training positions from the Nursing Council if we want to increase any particular program.
Yes. What has been the impact of the closure of nursing colleges?
I think that the closure of some of the public nursing colleges definitely did impact the shortage of nursing in the country, because prior to the 1990s, even the private sector was dependent on the public sector to supply nurses. Right up to now, the nursing colleges, the public nursing colleges, supply at least 75% of the nurses for this country. So you would see a number of the private groups then embarked on getting their own training institutions in place. There is a lot of bureaucracy surrounding the accreditation of the facilities, but I think that they persevered. So today we have all of the hospital groups, most of them participating in the training of nurses, as well as there's a number of independent private nursing colleges also in place.
And the nurses that you train, they're not obliged to work at your facilities, are they?
We train our own staff as part of their own career development, and they're obliged to stay with us for post-training. We also have external students that train with us, and they are offered positions on completion, and some of them choose to stay with us, others would like to continue with other programs or work through an agency. It's really up to them, but we do make employment available to them.
Yeah. Pyle, you make the point in your presentation that the certificate of need is not the answer. What's the difference, as you understand it, between a certificate of need and a license that are being issued at the moment?
Yes, I think the point was just about civil need for doctors, not necessarily being right in terms of how you allocate doctors around the country. I'm not sure whether we would agree with that, but in terms, I think the point you're trying to make in terms of licensing was that if they do bring in a certificate of need, in terms of how you determine licensing, can they just have a system that sits behind it, which is scientific, transparent, uniformly applied, and has proper measures which we understand and can apply to? Those are comments in terms of the certificate of need.
But you are aware, though, that the National Health Act does set out some of the factors that should be taken into consideration in determining whether or not a certificate of need should be issued.
Yes, we are aware of that. There are, I suppose, it's how it's applied.
Yes,
across the provinces is different.
And of course, the problem is that there is no regulatory infrastructure for the application of the provisions of the Act at the moment.
Correct.
Yeah. Okay. In relation to the negotiations with the funders, one of the factors that you mentioned which influence the price is the size of the scheme. How does that influence the size, the price?
Yes, I suppose it's some of it is subtle in the sense that the bigger the administrator in terms of the number of members, the more resources they've got to invest in analysis, reporting, systems, people. And so they generally tend to be more prepared or better prepared when it comes to negotiation. They've done better analysis in terms of the efficiencies of hospital groups. They have a better understanding in terms of the contracts and where they want to go. So from that perspective, there is we think that the bigger they are, the size tends to help the negotiation process because it allows them to invest more in the underlying systems and people. Sometimes if there is size and they use their size to say, look, we're going to introduce a DSP and here's the component that you're potentially going to lose, obviously gives them some negotiating power.
Does the size that you have in mind include numbers of members?
Yes.
Okay. So if a scheme has more members, does it have more power of influence?
I suppose it comes down to how they use
that power.
The potential. Yes.
But the power is there.
Potentially, and I say potentially because we have smaller schemes who are, but they have more potential.
Yeah. Okay. The negotiation ability, what does that mean? The extent to which one can outwit the other team?
Yes, there is an element of that in every negotiation.
Yeah, okay. The employment of doctors. I think I've just forgotten the name of the gentleman next to you. What's his name? Dr. Taylor.
Dr. Taylor.
Yeah. You mentioned that if you were empowered to employ doctors, that would give you more power in terms of the quality. I can't recall the content, but I made a note here. The note that I have made here is how does it impact on the quality of care, the employment of doctors by a facility?
Judge, if we could employ doctors in certain areas, let's say accident and emergency areas, the units, we could determine that the qualifications that those doctors should have, and we could also determine the protocols, the clinical protocols that they would have to use. Now, clearly, if we employed doctors, they would be reporting to other doctors. I'm not suggesting they'd be reporting to a businessman. They'd be reporting to a doctor who would be using the best-based, evidence-based medicine to ensure that these protocols were complied with. And I think not only would they improve the quality, it could also improve the efficiency.
I think this was in the context of having a say on how, on the quality of the services, on the quality of the output. I suppose the question really that I have is, why should your control over the quality of healthcare services be dependent upon whether or not a doctor is employed by you? I would have thought that as a person who owns the facility, you will lay down the rules. If you work here, if you have admission rights here, if you use our facilities, these are the rules. Just like you tell us when we go to hospital, switch off your phones.
Judge, I agree with you. In terms of the small period of time that those doctors are in our facilities, we can enforce standards of care, ethical standards, and so on. The context that I was really put in was the overall quality of care of doctors, of indexing doctors. Now, if you looked at a hospital where, let's say, there's a dermatologist and a pediatrician on one side, and on the other side is a cardiothoracic surgeon and an orthopedic surgeon. The pediatrician and a dermatologist may see a lot of patients, but only admit few of them. And they'll be using different disease protocols or guidelines. And obviously, we don't see any of that. When we get onto the surgeons and say the cardiothoracic surgeon, obviously we'll be seeing a lot more of him because he's admitting a higher proportion of patients.
If I can just go back to the issue of information to patients, one of the other aspects to it is if you have this information that's made available, to the public and to the patient, the other aspect is how does one ensure that they make use of that information? Because invariably, the tendency is to have these on the website, but not everyone has access to website. Or sometimes there is a brochure that's just next to your bed, but depending on your condition when you get into hospital, you may never read that brochure, and someone never draws your attention to it sometimes. But how does one make sure that once the information is available, the public is able to use that information?
Sorry, Judge, could we clarify the question? Are we talking about educating the patient around his episode?
Quality.
Okay, we're talking about his quality. I think, I'd mentioned earlier on the conditions that would be required to have quality metrics that were comparable between groups and the state. I think there should be a single group of metrics. In my experience, it's the most advanced countries, economically advanced countries, the USA and the UK, that are able to rate doctors. And okay, the doctors do have a way of where they are being rated and ranked. And I know that within departments in, say, the UK, in the National Health Service, a doctor would be told if his results are continually poor, he would be removed from being allowed to operate, or some remedial action would be taken place. So it's very easy for the doctors to use that data amongst themselves, and clearly if we were allied to them, we could do that as well. In terms of getting that information out to the public, at the moment there are only websites, and obviously in the UK there's a tabloid press, but it'd be a challenge in our society to get this information out to all users, and I'm talking about public and private sectors.
I suppose the greatest challenge that you will face as you consider this is how much of information should be disclosed without undermining the good name of the particular hospital. Because I have no doubt that you are in this business not as charitable organizations, but to make profit. And to what extent do you disclose information that would undermine your ability to earn more profits by telling the public and everyone that you've got bad doctors and that your services are of a poor quality?
I'd like to say from the life healthcare perspective, if we've got what you would call a bad doctor, and he comes to our attention, either through our alert system, our patient incident system, or his colleagues write to us, or his patients write to us, or more generally the nursing staff who are the advocates of the patient, would say this doctor is starting to show some poor outcomes. That we would peer review that doctor, and we have peer reviewed doctors. We did supply the commission with a list of doctors that we have taken action against, and the bad doctor, I would like to think that we would I wouldn't like to think, I know we will terminate his admission privileges. We will report him to the HBSSA, and hopefully they will have an inquiry and they'll put it on their public website.
Yeah. The last question, hopefully, depending on the answer. What impact, I mean, if any, does the prevailing situation for the issuing of the licenses have on your ability to expand? At the moment, you don't have a national body that deals with these licenses. You have to apply to each province under Regulation 158, I think it is. And you've told us about the lack of uniformity. And we were told this week also, that there were problems with the criteria. Some of the provinces are still working out on what is the criteria. What impact, if any, has that have on your ability to expand?
The current situation certainly does have a negative impact on our ability to expand. We have a number of applications whereby, where we haven't received feedback or they have been declined. We go and appeal. It just takes a long time to get feedback. So it's, without a uniform standardized system, it does have an impact in terms of how we want to grow, in terms of our ability to grow. And it's not just about just going to go build hospitals everywhere we can, but the ability to expand hospitals which are full, the ability to add, for example, mental health units where we can see a demand. So the process and the timing does negatively impact our ability to grow.
Thank you. Is there anything that you had set out to tell us about, but which you have not had the opportunity to tell us about?
No.
I can understand you're anxious to leave. Yes, yeah.
I just wanted to understand something about this shortage of doctors and the relationship between new facilities and doctors and having to attract. So are we not just rearranging the deck chairs? So, I mean, where are all these new doctors coming from for all these new facilities that you're being stopped from, that you might want to expand? Where are they coming from?
I mean, it is a problem in terms of some of it is rearranging the deck chairs. You take specialists from other hospitals to pull them in. The majority of growth that we look at is expansion to existing facilities. And sometimes within that, you don't need additional doctors. The doctors are saying your hospital is full. We don't have enough beds in terms of our patients, and yet we can't grow the hospital. So it is a combination of the brownfield expansion, some of the mental health expansion. But I mean, you're quite right. That's one of the reasons why we look very carefully about building new hospitals, because where exactly are we going to get the specialists? Where are we going to get the nurses? And so it's probably one of the reasons why our growth going forward has moved more towards expansion existing facilities rather than building new facilities.
And particularly in KwaZulu-Natal, they told us that there were a number of hospitals that were approved but not being developed. Are any of these yours?
Not that I'm aware of, no.
See, unless you stand up and go, I can no longer protect you.
Sorry, Judge, could I raise one issue which came up earlier?
You can stay here.
Can I stay? It was the issue.
Yes, I understand. Yes, thank you.
Thank you, Judge. It was the issue around the doctor who was refused admission privileges in Rustenburg. Now, I don't know the details of that. What I'd like to say there is, where we have capacity, the doctor applies for admission privileges. Now, in the one side, it's comfortable. There's a surgical practice. The old guy's retiring. They're bringing in somebody else. They've got their practice management, and that's generally how it's working. But and they're doing they're making sure that he fits in and so on. But where a new surgeon or a new orthopedic surgeon applies to get admission privileges, and we have the capacity.
Yes.
And let's put it at, I don't want to be not generous, but let's say there are some elderly doctors there who are trying to protect their turf. So they would then refuse us permission to grant this man or lady admission rights. And we have it very carefully written out that they may not unreasonably refuse admission. And certainly in the last year, I think you'd find in life healthcare more unhappy doctors where we've given doctors admission rights over the objections of the existing doctors than doctors that are unhappy because they weren't given admission rights.
But if all of the orthopedic surgeons at one of your facility say to you, if you bring in another one, we will go, what would you do?
This hasn't happened.
I know.
But there was an example quite recently where that did happen, and we brought in the new doctors, and they had to stomach it, and we've been giving them the monthly figures to show, because we knew that was underutilization. So we then do take our chances that they may leave. But generally the reasons why they are not granted rights would be that we either don't have capacity, or there'll be an individual doctor who will have looked at this doctor's track record and advise us, we only want a highest caliber doctor. Thank you, Judge.
I want to come back to quality, my favorite subject. In your replies to me and to the judge, you actually explained quite clearly that you'd prefer to publish, but you refer to what I briefly note down as a prisoner's dilemma. If we publish and the competitors don't publish, then in certain regions, on individual hospitals, we might look like we provide inferior quality, whilst the other colleagues do not publish and sort of benefit from that. It's a prisoner's dilemma, isn't it?
Correct.
That's correct. And then you mentioned, but we might still do it, provided we're brave enough. That's the words that you used, or self-confident enough. Yes, that's right. I understand. I fully understand. It is more complex than my initial trying to lure you into giving us a commitment. It's more complex than that. I understand that. But a prisoner's dilemma needs to be broken, isn't it? It needs to be broken by a collective action. That's what the solution to a prisoner's dilemma is. My question to you is, what is your own role as a group in breaking that prisoner's dilemma, in getting to collective action? What will your actions be to break that prisoner's dilemma? And what is the possible role of your associations, or the HASA association I'm thinking of?
Yes, let me answer this way. I think that our role going forward should be, my guess would be a proactive one in terms of putting out quality data. But I do think the role of our association is a key one. And I think the association should be actually playing a more proactive role in terms of quality, in terms of saying, this is the hospital association, we're going to agree to quality metrics, and this is what we think you should do, and if you're either in or out. And I think what we have to do as a member of that association, I think we should be forcing it more proactively and aggressively within that association.
Yes, because you're an important player in this organization.
Yes.
So you'll put it on the agenda.
Yes, I think there's certainly discussions at a HASA level that it has been raised on the agenda.
Yes.
But I think it's a question of how hard you push it.
That's right.
Yeah.
That's right. And you'll push hard.
Myself and Dr. Taylor.
Thank you very much. Thank you very much.
Thank you.
Well, this is it. It's either now or never. Thank you.
Thank you.
Well, thank you very much indeed for the presentation and for sharing with us Life Healthcare's, experience in these matters. I think in particular for being so candid with us in terms of where you failed and what steps you're going to take in order to correct that. We appreciate that. And we're looking forward to a further engagement with you when we begin to deal with these issues, more deeply. But thank you very much indeed.
Thank you very much.
Thank you.
The next group is Mediclinic, is it? Gentlemen, good afternoon.
Good afternoon, Chairman.
Just indicate to me when you're ready. Very well. Yes. Would you please indicate to us who's going to lead the discussion and then perhaps place your names on record? Thank you.
Thank you, Chairman. Good afternoon, and good afternoon also to the distinguished members of the panel. My name is Kurt Pretorius. I'm the Chief Executive Officer of Mediclinic Southern Africa. With your permission, Chair, I would like to take the panel through the presentation that we prepared, and I will be supported by my colleagues, and I would like to introduce my colleagues to the panel. I must just find the right button. There we are. On my right, we have Bram Joubert. He's our Chief Financial Officer. On my left is Rowley Buys. He's our Strategy Development Executive. And then we are also joined by Skalk Burger, who's a Senior Counsel from Cape Town. So that is our team.
Thank you.
Chair, with your guidance, our understanding of the purpose of the presentation is firstly to use this first round of public hearings to inform the public about the business model of Mediclinic and to explain how our model works. This will provide insight on the interaction between Mediclinic and various stakeholders in the private healthcare sector. I think that was a specific brief for this first round. And then we will also use this opportunity to provide some regulatory context, which was also specifically asked for during this round. Chair, the scope of the presentation will therefore firstly cover and provide a broad outline of Mediclinic's business. We will be using this opportunity to set the scene for further engagements, and we understand that there might be 3 or 4 further rounds of engagement where we will delve deeper into specific issues. It's also worth pointing out, Chair, that at this point in time, we still await the outcome of the data, information, and profitability analyses. So we cannot deal with the outcome of those issues in detail at this round of discussions. The specific outline that we want to use for our presentation is as follows. We firstly want to start with a brief introduction to Mediclinic. We will then cover the business environment by providing some regulatory context. Then we will discuss the Mediclinic business model. And in the next section, we will then specifically highlight our interactions and relationships with, firstly, the most important stakeholder in our world, namely our patients. From patients, we will move to our important partners, the healthcare professionals, whereafter we will deal with medical schemes, administrators, and managed care organizations. We will also briefly touch on our relationships with suppliers and support services. Once we've covered all the interactions with the other players in the industry, we will focus on 2 very pertinent issues regarding this inquiry, namely expenditure on private hospital services, and then also, from our own perspective, price and input cost increases at Mediclinic's hospitals. After all of this, Chair, with your permission, we would like to wrap up with some concluding remarks. I will then move on to the first section, namely an introduction to Mediclinic. As you can see from this slide, Mediclinic started way back in 1986 when the company was listed on the Johannesburg Stock Exchange in South Africa. The company was actually started in 1983 in the Western Cape in the town of Stellenbosch, but we only listed 3 years later in 86. Over many years, we were able to grow the business in South Africa by developing new hospitals, but also, as you can see from the slide, acquiring other hospital groups. Way back in 2005, we decided to expand geographically into other markets. The reason for the international expansion was basically that growth opportunities in the South African context were limited. We were still able to grow incrementally over time, but we were not able to make a quantum leap in terms of growth. We prefer to stick to our knitting, and what we do is provide acute care hospital services, and we decided that we would look for other opportunities to manage acute care hospitals in other countries. In 2006, we bought a minority stake in a group in Dubai in the United Arab Emirates. In 2007, we increased our shareholding to a majority stake, and recently we concluded a transaction to acquire the Al Noor Group with a strong presence in Abu Dhabi. The Al Noor Group was listed on the London Stock Exchange, and the transaction was structured as a reverse takeover, which means that our primary listing is now in London. We still, however, have secondary listings on the Johannesburg Stock Exchange and also on the Namibian Stock Exchange. In 2007, we also acquired the biggest group in Switzerland, namely the Hirslanden Group. At that stage, they had 13 hospitals. Today, they have 16 hospitals. We also made a minority investment earlier in 2015 in the Spire Group in the UK, where we own 29.9%. All these international expansion opportunities were funded by raising additional capital from our shareholders and by incurring debt in those different countries. The assets in South Africa are ring-fenced, and there is no recourse to assets in Southern Africa. We funded all those overseas opportunities by incurring additional debt in those specific countries. We have a very supportive major shareholder, the Remgro Group, who facilitated these transactions and who supported us to do this international expansion. Today, we operate 73 hospitals, 35 clinics, and we have a presence in 5 countries. Moving back closer to home, in Southern Africa, we have 3 listed private hospital groups. You can see the number of beds on the slide. Mediclinic is the smallest of the 3 listed groups, but we are all very committed players in the South African context. Looking to the right of the slide, you can see the market share of the different players, and you can also see that NHN and independent hospitals still have a sizable market share. I think NHN at the moment actually has more beds than both Mediclinic and Life Healthcare. If we look at our geographic footprint, we currently own and operate 52 hospitals in Southern Africa. That is now South Africa and Namibia. In South Africa, we have 49 hospitals, and in Namibia, we have 3 hospitals. We have a very good cover in terms of our geographic footprint, but unfortunately, we were never able to really develop hospitals in the Eastern Cape. We have applied for licenses, but we were not successful. This provides an operational overview of Mediclinic Southern Africa. As mentioned, we own and operate 52 hospitals. We have close to 8,000 beds. We have the support of 2,451 admitting doctors, and we employ approximately 16,500 full-time employees. We recently opened 2 new day clinics, one on the same premises as Mediclinic Durbanville, and then also another day clinic 350 meters from Mediclinic Limpopo in Polokwane. We believe in the future of day surgery, and we have a strategy to develop further day clinics on a co-located basis. We believe the co-location model will be the most efficient in the South African context because there are many advantages to having the day clinic preferably on the same premises as the hospital or just across the street. It is a safer option and it's more convenient for both doctors and patients. On the right-hand side of the slide, we give an overview of our main disciplines that we offer. I think it's quite significant to note that our biggest discipline at the moment is internal medicine, which is a reflection of the burden of disease and the type of patients that we admit in our hospitals in South Africa. The way we describe our core business, this is now what we do. We manage acute care, specialist-orientated, multidisciplinary hospitals, and we also provide some related service offerings. We have 3 subsidiary companies. The one is ER24. ER24 was initially formed as a joint venture by Mediclinic and Afrox Healthcare, which today is Life Healthcare. Secondly, we have a nursing agency called Medical Human Resources. They provide 90% of the agency staff that work at our hospitals. We started this business approximately 20 years ago because of the shortage of nurses and to enable us to recruit nurses to work through an agency. We also have a very small equipment manufacturing company called Medical Innovations. They import certain medical equipment and certain consumable items. We also invest heavily into nurse training. We have 6 training schools throughout South Africa, and they are all higher education accredited facilities. Chair, that covers the brief introduction to Mediclinic. Moving on to the regulatory context, from our understanding, there will be a separate session in the oral hearings where this will be discussed in more detail. But just to make some initial contributions on this subject, we want to refer you to slide 13. Firstly, Chair, it's important to note that we operate in a highly regulated sector, and on this slide, we mention various pieces of legislation and regulation that impact on our business. Firstly, the most important, the Constitution. In this regard, Mediclinic accepts that the constitutional right of access to healthcare is at the heart of this inquiry. Mediclinic recognizes its constitutional and statutory obligations. The precise nature of those obligations will be addressed in a separate submission that we would like to file with the panel, and our advocate, Skalk Burger, has prepared a document in this regard. So with your permission, Chair, we would like to submit the document.
When?
Skalk? Chair, by Friday.
Oh, okay. All right.
Which is tomorrow. Yeah, this week, Friday. Secondly, the National Health Act, obviously a very important piece of legislation. The National Health Act provides the framework for the newly established Office of Health Standards Compliance. This office will, in broad terms, monitor clinical quality of all facilities, both public and private, and as we understand the intention, will accredit facilities for inclusion as service providers in the envisaged national health insurance. The Competition Act is obviously also very important for us, and also the Medical Schemes Act. The development of the legislation in this regard has led to unintended consequences for the private medical industry. This is now specifically referring to the Medical Schemes Act. A proposed 5-pronged reform stops short of introducing compulsory membership for the employed as well as a risk equalization fund. This has led to anti-selection and a deteriorating risk profile of the medical scheme population. Then, as far as regulatory authorities are concerned, the HPCSA's ethical rules inhibit the development of fully integrated delivery models. In this regard, we are not only referring to the employment of doctors, but also to global fees and fee structures where fees can be shared between healthcare professionals and hospital groups. The South African Nursing Council has been slow in developing the scope of practice for nurses, and thus the implementation of training curricula has been hampered, also slowing down the training of much needed new nurses. We suggest that the work of the Nursing Council also receives attention from this panel, and that the training needs of the country be addressed. We were not able to do a new intake of nurses at our 6 nursing schools this year because the new dispensation has not been finalized, formalized, and implemented. As far as provincial departments of health are concerned, each provincial department follows its own approach, using different criteria to evaluate applications to establish a new hospital or to expand or change existing hospitals. It's not only about new facilities, it's also about expanding and changing existing facilities. The criteria that are used are not transparent and not consistent. Chair, I'm sure during the next couple of months we will debate these issues a lot further. Then, moving on to our Mediclinic business model. We think for this round it is very important to stick to the fundamentals and to try and explain and inform how our Mediclinic model, business model works.
Perhaps before you go there, I was hoping to interrupt you at some point. The document that will be submitted later, can we just mark it so that we don't lose track of additional document that will be submitted in? Shall we mark that BJ1, the document that deals with the
constitutional issues,
with the legal framework?
Yes.
Yeah, which is going to be here by tomorrow morning.
By tomorrow morning, yes.
Tomorrow morning, 8:30.
By tomorrow. My learned friend.
Mr. Skalpecker, please do not allow him to push you into a corner. Yes, very well, thank you. So we will mark that document BJ1. Thank you.
Thank you, Chair. If we may then, Chair, with your permission, move on to the next section. We now want to talk about the Mediclinic business model and specifically the provider environment. Now, the way the current model works is that our hospitals provide certain facilities and services. We provide infrastructure, land, buildings, and equipment, the capital component of our investment. We also provide clinical services which are focused around nursing and pharmacy. We have support services, we have technical, administration, financial and other support services. And for all of this, we render a separate account. Then we have our admitting doctors. They admit patients. They are in charge of the management of the clinical process, and they also submit separate accounts for the services that they deliver. Then we also have radiologists, pathologists, and allied healthcare professionals. They act on instruction from referring doctors, and they also submit separate accounts. So the key takeaway from this slide is that we have a fragmented delivery model in the private sector in South Africa, and we can understand why patients find it difficult to understand the system, which is very complex, and to navigate this system is not easy for any patient. How do we as Mediclinic make a living? I referred to the separate account that we send to patients. The composition of a typical Mediclinic hospital account will look as follows. This is just an illustrative example. The first important component on the account is the fee income. Under fee income, we can have various types of accommodation charges. For instance, for a general ward or an ICU, we will have a specific tariff code and price for that item, and we will multiply that tariff or price by the volume or quantity or the number of days, in this case, that the patient stays in hospital. This will then give us the total accommodation on the hospital bill. The second important component is the theatre charge. Once again, we have a tariff code at a specific price times quantity or volume, which will be the number of theatre minutes in this case. Thirdly, under fee income, we have equipment. Once again, various tariff codes, various prices, and then the number of times the equipment was used. All of this, accommodation, theatre, and equipment, will add up to the total fee income. The next important component of our hospital account consists of the pharmaceutical items. Pharmaceutical items are divided into two specific categories. We have the ethicals, once again, a tariff code and a price per item times quantity. And then the second important component, surgicals. We there also have tariff codes and prices times quantity or volume. That will give us the total pharmacy component of the bill. If you add up those two main components, the total fee income and the total pharmacy income, you will get the total account, which normally includes value-added tax. If we analyze this into more detail and we look at the composition of the account, it is interesting to note that fee income, in other words, ward theatre and equipment, will make up 73% in the case of Mediclinic of our hospital bill. The pharmacy side makes up 27%. That 27% is divided into two portions. 2/3 of the 27% goes towards surgicals or medical devices, which is then 18% of the total account. And 9% makes up the ethicals and the medicines. The other third of the 27% goes towards ethicals and medicines, which is then 9% of the total account. So fee component 73%, pharmacy 27%. If we analyze the pharmacy component further, we have these two major groupings. On the left-hand side, ethicals and medicines. The prices of these products are regulated by the single exit price dispensation, and at Mediclinic, we don't charge any dispensing fee on these items. On the right-hand side, we have the so-called consumables or surgicals or medical devices. These items are not regulated by single exit price. These items, in the case of Mediclinic, are billed at cost. We call this model the net acquisition price model. Mediclinic introduced this model in 2003, before the SEP was introduced on ethicals or medicine. At that point in time in our industry, pharmacy inflation was running away. Pharmacy inflation was extremely high, and our company was of the view that those price increases would not be sustainable. So we negotiated with the medical schemes that we will move the profit that we made in pharmacy at that point in time towards our fee income. We did that on the ethicals as well as the surgicals. More than a year before the SEP legislation was introduced in 2004. As a consequence, we made less profit in the following years. But our view is that long-term sustainability is much more important to us than maximizing profits in the short term. So we fundamentally believed we needed a tariff structure where increases on tariffs would be closer related to CPI, and that the system will not be able to afford the runaway inflation that we had during those days on the pharmaceutical component. Having covered how we make a living and how we charge for our accommodation, theatre and pharmacy items, we now want to explain how our input costs work. Firstly, it's important to note that hospitals are highly labour and capital-intensive facilities. Capital costs are not directly factored into the tariff escalation calculations. When we negotiate with medical schemes on an annual basis, we motivate our increases by referring to increases in operating costs, not increases in capital cost. But it is important that our tariffs should be sufficient for the replacement of capital items and the opportunity cost of the capital employed. Chair, at this point in time, I'm just explaining the model. I'm not going to spend time in this section on drivers of input cost. We have a separate section where I will deal with that in detail. If we look at the breakdown of our operating costs, on this slide, please take note, input cost as a percentage of operating cost, which excludes the pharmacy component of our business. In our world, pharmacy is a cost center. We make no profit, we get no rebates on pharmacy. So we exclude that. We focus on the tariff component of our business. By far, our most important input cost is nursing salaries. It ranges between 47% and 51% of our total input cost. Then other salaries, that's now for admin, pharmacy and technical staff, makes up between 14% and 18% of our input cost. Repairs and maintenance between 4% and 6%. Electricity and water has been on the increase in recent years. It is now between 2% and 4% of our total costs. Rates and taxes have increased to between 1% and 2%. And then catering, laundry and cleaning is between 7% and 8%. We also have other expenses like information, communication and technology expenses, audit fees, insurance, consultancy fees, legal fees, and all the others that make up between 16 and 20%. Moving over to capital costs, as you know, we develop specialized buildings according to regulations. To develop these buildings are very expensive, and I'll come back to that later on. We also purchase specialized medical equipment, mainly imported and complying with European and American patient safety and quality standards. We don't have a dispensation in South Africa where these pieces of equipment can be accredited. So at Mediclinic, we will not use medical equipment unless it has the European CE quality mark or unless it's been approved by the FDA in the United States. Because in our world, patient safety is our most important value and goal. We do not compromise on patient safety, and we will not use medical equipment unless it meets stringent patient safety and quality standards. Technology innovation plays a role and is normally linked to new types of treatment and to better clinical care that can be provided to patients. Now that I've explained the business model of Mediclinic and how we charge for our services and what our most important cost items are, Chair, with your permission, I would like to continue to the next section where we will now explain how we engage with different stakeholders in our business environment. We will start with patients. As I've mentioned, this is our reason for being, this is our core business, and this is how we make a living, by caring for patients. Our most important strategic objective is to put patients first at Mediclinic. Over time, in our 30-year history, we went through different development phases. And all over the world, reference is often made to so-called putting the patient at the center of what we do and patient centricity. But during a recent visit to the United States, we actually learned that the right thing to do is to put patients first. Otherwise, you may have a situation where patient centricity, patients at the center, but doctors first. Our philosophy is that our doctors must be our partners, and everybody in the care delivery team should put patients first. The way we deliver our service and the way we look at our service offering is by way of this value equation. It has three important components. Firstly, superior clinical quality, then maximizing the patient experience, and thirdly, managing cost efficiencies, or so-called cost per event. Now, in the value equation, you can increase the value proposition to your patient by increasing your clinical quality and your patient satisfaction, or by decreasing your cost per event, or by doing both. And we have various strategies regarding each of these important components of the value equation. Communication with patients, obviously very important. We have a website where patients can access a whole lot of information. We are just mentioning some examples of this slide. Patients can access a pre-admission form, and they can do their admission before they arrive at our hospital. There's a whole explanation of the hospital billing process and how that works. There is a private tariff schedule that is published. Please keep in mind that due to our negotiations with all the individual medical schemes, the tariffs do differ between schemes. So we don't have a tariff list per scheme. That is part of the contract that we negotiate with the scheme, but we have a general private tariff schedule. There's also a function where patients can search for doctors or hospitals within the Mediclinic group. Patients that don't have access to a website can get this information from our hospitals. They can either visit the hospital or they can phone the hospital, but they can also access this information. We also have nurse-driven pre-admission clinics at our hospitals, and we provide information to our patients on the medical scheme's benefits that they will be able to access. We also communicate with medical schemes on behalf of patients. Many times patients need to do pre-authorization, the case needs to be case managed during the patient's stay in hospital. So we act as an agent on behalf of the patient to engage with the specific medical scheme. We also have a patient complaint and complement system in place. There are various ways in which patients can access the system. They can either write to us, they can phone us, they can visit the hospital, they can send an email, or they can use our patient satisfaction system to initiate either a compliment or a complaint. Healthcare is about clinical quality. We have various clinical quality initiatives in place. These are normally organized around three main headings, namely structure, process, and the measurement of outcome. We have a strong focus on all three of these components, and I want to elaborate on what we do regarding each of these. Firstly, our hospitals are accredited by CTICC. CTICC is the only independent accreditation authority in South Africa that has been accredited by ISQA, the Institute for Quality in Healthcare. We also have annual Department of Health inspections where they make sure that our facilities and equipment and all of that are up to standard. We are keenly awaiting the finalization of the national core standards by the Office of the Health Standards Compliance. And in our company, we have a well-functioning integrated clinical department as part of our organizational structure, and we have started with a process now to appoint clinical managers at hospital level. These clinical managers are qualified medical doctors, and their role will be to support our hospital managers, who are normally general managers, and to make sure that patient safety receives the necessary attention, and also to engage with our supporting doctors regarding quality initiatives. So we do a lot to put the necessary structure in place. As far as process is concerned, we have a tool within Mediclinic, the Cura tool. We use this to keep our clinical risk register up to date. Hospital management teams do control self-assessments, and then we have audits that are conducted by our clinical department to make sure the quality at hospital level receives the necessary attention. As other players in the industry, we are also involved in the Best Care Always project, and it's important for us to ensure compliance, and I think our industry, both public and private sector, has actually made good progress due to the Best Care Always initiative. It is one of the success stories in our industry as far as quality improvement is concerned. Our company also, at big cost, implemented the ICNet surveillance program, which is a software program from the United Kingdom that links your hospital directly to pathology groups. All our supporting pathology groups are now on the ICNet software. It tracks infections in your hospital, flags possible risks, and gives you the results immediately. So that is another very important initiative as far as process is concerned. Over time, we've developed many clinical key performance indicators. Way back in 2008, we were the first hospital group to publish our clinical key performance indicators at a group level as part of our integrated annual report. This information is available on our website. As far as outcome databases are concerned, we have implemented quite a number of initiatives. We subscribe to the Vermont-Oxford database, which measures the quality of care in neonatal intensive care units. We also implemented the Apache database, which measures quality in adult ICUs, and we have a cardiothoracic database as well to measure outcomes at our heart units. We also have a hospital events management system where events are reported and graded according to the severity of the event in different levels from 1 to 4. And we use these reports together with legal reports to evaluate trends in our company, to look at problem areas, and to make sure that we initiate quality improvement initiatives to address shortcomings. The next slide is just an example of some of the clinical quality initiatives that we measure and that we publish in the annual report as part of the clinical services report. The top section deals with antimicrobial utilization indicators. This is our information over the 4 years from 2012 to 2015. And on the bottom part of the graph, we have device-associated infections in Mediclinic Southern Africa from 2012 to 2015. We obviously have this information available per hospital, and at the moment we actually have a clinical performance indicator dashboard with 12 important indicators that we measure. This information is shared with our supporting doctors. We have a clinical hospital committee per hospital where this information is discussed per hospital amongst the doctors, and we also share some of this information with medical schemes. Our thinking about the future is to move away from negotiations that only take cost into consideration. If you think back about our value proposition, we think when we negotiate with funders, we should talk about value and not cost only. We should include quality and also patient experience. Moving from clinical quality to the patient experience component, Mediclinic, after many months of research, decided to implement the Press-Ganey patient experience system. Press-Ganey is a US-based company. They are considered to be a world leader in managing patient experience. This system has now been implemented at all Mediclinic's platforms, not only in Southern Africa, but there are many advantages to the Press-Ganey system. They have a very scientific way in which to measure patient satisfaction, and they also make recommendations on how to improve. It was quite an onerous task to roll this out, but since 1 September 2014, we've had 25 patient voices heard at Mediclinic. We don't do a sample. This survey is sent to every Mediclinic patient, either by way of email or by post. Unfortunately, with the strikes in our post office, that component didn't work so well last year in South Africa. But patients who don't have access to email can complete the questionnaire in a paper-based format. The average e-survey response rate is 21%. Remember, all patients receive the survey. And we've identified 10 improvement opportunities for every hospital to make the biggest impact on the patient's experience where it matters most. The big advantage of this Press-Ganey system is that it does not only give you feedback on the patient's experience. Per question, it makes recommendations on where to improve if you are not satisfied with your result. Our results are then benchmarked against more than 1,800 hospitals globally. These hospitals all take part in the Press-Ganey survey and are mainly in the United States and probably deliver the best patient experience because they've been part of this Press-Ganey system for approximately 25 years and we are fairly new. If we look at our actual results, these are our actual results for 2015. On the left-hand side, we have the survey section. Then we have the average mean score for Mediclinic Southern Africa. And then we have the Press-Ganey average mean score, which is the average score for the 1,800 best hospitals in the world. So we compare ourselves to a very high benchmark. We are not satisfied with where we are. We want to improve. We really want to be world-class. But for a company that only started with the survey in 2014, we are satisfied with the performance and the improvement in this short period of time. You can see on many of the items we are close to what we use as a benchmark for ourselves, but on others we have more gaps and more work to do to get to be the best. As a company, we have made an in-principle decision that we want to publish this information. This information at the moment that you see is at group level, but obviously once again we have this information available at hospital level. We just have to finalize the date by when we will publish this, Dr. van Gent.
At the hospital level?
Yes, yes. We believe it's an extremely powerful tool to use, not only to measure where we are, but to help us to improve. The third component, which deals with the third component of the value equation, is the so-called cost per event. Now, this is one example after we implemented an innovative knee replacement product where we work together with our supporting orthopedic surgeons in an integrated manner, which is not the norm in our industry. But here we can see the improvement, the observed over expected bed days, pharmacy prosthesis, and theatre minutes for generic drugs, theatre time, and length of stay. And we can see the reduction in the cost per event after we engaged with our doctors on these issues. In other words, Chairman, focusing on our patients, measuring quality, measuring patient experience, addressing cost efficiency is what our strategy is about. Moving on then to healthcare professionals. Firstly, we want to give some perspective on the shortage of healthcare professionals. If we look at doctors, GPs and specialists per 100,000 people in South Africa, you can see where we rank against other countries in the world. The yellow bar, orange bar in the top section of the slide. We have the same information for the number of total nurses per 100,000 people, and once again we can see where South Africa lies. Now, there is a detailed study that was done by Econics, and it was submitted as part of our comprehensive submission. The important point is to keep in mind that we operate in a context where we have a shortage of healthcare professionals. So how do we develop our relationships with our supporting doctors? Firstly, our doctors have clinical and business independence. The doctors who admit patients to Mediclinic are clinically independent, and they decide why and when to admit a patient, what the treatment should be, and when the patient is ready for discharge. The same applies to the independence of his or her business interests. Each doctor practices for his or her own account and generates his or her own income, as I explained previously. As far as recruitment of doctors are concerned, Mediclinic or a group of doctors already practicing at the hospital may identify practice opportunities based on the needs of the community or the practice requirements of the doctors, where after the recruitment of another doctor will be initiated. It is a complex process. It is not only doctor-driven, it's also not only hospital-driven. It's done in conjunction with our supporting doctors, but the final decision is made by the hospital. Both GPs and specialists may have admission privileges, although it is generally found that in the urban hospitals, we have more specialists and less GPs admitting patients. But at some of our rural hospitals, we have GPs who are in the majority. The privileges are based on the need for the discipline, qualifications and registration at the Health Professions Council, and are subject to the availability of beds, theatre time and the need of the community. The most important aspect that we have to offer a doctor is a viable practice opportunity. We will never recruit a doctor to set a doctor up for failure. If we can't accommodate more volumes, we can't recruit another doctor, and if there's no need in the community or the market that we serve, we will also not recruit an additional doctor. We provide consulting rooms. At most Mediclinic hospitals, there are a number of consulting rooms which are available for rent by doctors and other healthcare professionals. Doctors who do not have consulting rooms may also have admission privileges. At some of our hospitals, we have no consulting rooms, and at other hospitals, there's a shortage of consulting rooms. So it's not a prerequisite for admission privileges to have consulting rooms. Then as far as shareholding is concerned, we have various shareholding models at our hospitals, and the details thereof have been provided to the technical teams. we actually provided detail on our recruitment policy, admission privileges, and consulting rooms as well in our detailed submissions. I just want to elaborate on the shareholding aspect. We inherited various models with historical takeovers, as I showed on the slide that covered our history. We took over many groups since 1986 when we started or when we were listed. And at most of those hospitals, there were different shareholding models in place. But we also initiated a new shareholding model in 2012. And we basically did that because the experience at the other hospitals where we had the shareholding in place was so positive. So the rationale for the new 2012 shareholding model initiative is firstly to establish a partnership with supporting doctors through co-shareholding. Secondly, this ensures formal and structured participation in hospital management. We believe it's very important to increase quality and decrease cost by a closer working relationship between the doctors and our hospitals, and this is a vehicle to facilitate that closer relationship. This leads to joint accountability by hospitals and doctors to manage the value proposition for the patient. In other words, to manage quality and cost efficiency. This supports our ultimate vision to put patients first at Mediclinic. This is one of the offerings used to attract and retain doctors to our hospitals. An individual doctor's shareholding is capped at 2% of the particular hospital, and doctors may hold up to an aggregate of 25% of the total shares in the hospital. The shareholding model is an arm's length transaction. Doctors pay for the shares at market value, and shareholding is not in any way linked to any incentives of increasing patient admissions or turnover. And in setting up this new 2012 Mediclinic shareholding initiative, we ensured compliance with the ethical rules of the Health Professions Council. They have strict rules governing shareholding. Now that we've covered healthcare professionals, we will move over to medical schemes administrators and managed care organizations. Our tariffs are negotiated on a national basis. 90% of our revenue is attributable to patients belonging to medical schemes. The negotiation process is very robust. It is not perfect, but it works. Medical schemes have countervailing power through their size, through their comprehensive access to data, not only about hospitals, but also about doctors and other provider groups and network arrangements. In our tariff negotiations, there is absolutely no distinction between prescribed minimum benefits and non-PMBs. We charge the same tariff irrespective of what type of procedure it is. It's also important to note that we don't only engage with medical schemes to negotiate tariffs. There's a lot of information sharing happening as well. We talk about quality initiatives, we talk about patient experience, we talk about managed care issues. We normally have to get pre-authorization before we admit a patient, and once a patient has been admitted, case management needs to take place, and we support our patients and we act as an agent on their behalf to engage with the medical schemes. Then, moving briefly to suppliers and support services. For us to be able to deliver our service, we procure pharmaceutical and medical equipment supplies, which are mainly imported goods from various suppliers. I explained earlier that most of these items are imported in South Africa. When it comes to catering, laundry, cleaning, security, medical waste management, these services are normally outsourced. The main reason why we outsource is that we are not specialists in running these type of services. We prefer to outsource to specialized companies who have the knowledge, firstly, and secondly, who have economies of scale to do these type of services more efficiently than what we can do. That enables us to focus on the clinical business of treating patients. Chair, we've now briefly covered at a high level our engagement with our most important stakeholders in our business environment, and we would now like to move to the last two sections, which we feel are at the heart of this health market inquiry. In the first section, we will look at expenditure on private hospital services. If we say expenditure on private hospital services, we mean from the point of view of medical schemes and patients who pay for our services. Now, we've identified in our business 3 drivers of expenditure. Firstly, price will obviously play an important role, and in this context, we have to refer to price of the hospital services, the fee component, as well as the price of pharmaceuticals. Secondly, the quantity of medical services or the volume of services that are provided. And thirdly, the intensity or acuity of the medical services used. All 3 of these play an important role in driving total expenditure by medical schemes on private hospitals. So we will deal with each one of these in a little bit more detail during the remaining slides in this section. To start with, we have a breakdown of Mediclinic's increase in revenue by source. This covers the period 2010 to 2013. If you look at the bar chart, you will see the area in green indicates our price increases on an annual basis. This is now revenue per bed day, which includes the fee component as well as the pharmacy component. The quantity is indicated in orange, and the intensity of care is indicated in grey. And on the left-hand axis, you can see the annual percentages. So all 3 play an important role. What are the drivers of expenditure? Price, as you saw on the previous slide, is slightly above CPI, but the volume and the intensity is where the real challenge lies. So if we look at our own Mediclinic data and we look at age band, for a very long period, from 2002 to 2013, we can see the percentage increase in the number of admissions by age band. So it is very clear that neonates, right on the left, the age less than 1 year, increased more. Then during a patient's healthy years, the increase in admissions were a lot less. And then later on in life, the rate of the increases picks up again. So this is the increase in the number of admissions by age band. On the next slide, we have the cost of a Mediclinic inpatient admission by age. Once again, we can see patients younger than 1 year, very high cost, mainly neonatal patients, and then a big dip, and then later on, a big increase again in the cost of the inpatient admission once a patient is older than 50 years, which is still young. If we look at another important factor, burden of disease, this indicates the percentage of inpatient admissions admitted to Mediclinic with diabetes, hypertension, or hyperlipidemia for the period 2010 to 2013. And we can see that the percentage of inpatient admissions grew over time due to the fact that, or the number of patients that we admitted with these comorbidities increased over time from 2010 to 2013, and the trend is obviously continuing. On the next slide, we have the percentage of Mediclinic inpatient admissions with multiple chronic conditions as identified by the chronic disease list. So we can clearly see that the patients that we admit with 4 chronic conditions in 2013 is 5%. In 2010, it was only 3%. Patients with 3 chronic conditions increased from 5 to 6%, and patients with 2 chronic conditions from 7 to 8%. So this clearly illustrates our experience in terms of the burden of disease. On the next slide, slide 44, the cost per inpatient admission by the number of chronic conditions prevalent. It is clear that the more chronic conditions a patient has, the higher the cost of the admission will be. And it is actually significantly higher. If you compare the bar chart on the left, patients with no chronic condition or 1 chronic condition, it's 50% per admission of patients with 4 chronic conditions. This is an interesting example of hip replacements. Once again, Chair, based on our actual Mediclinic information, if we use patient A as a base case, in other words, patient A, a 50-year-old patient, normal body mass index, no underlying chronic conditions. The expected account, excluding the prosthesis for a hip replacement, will be a certain cost. If we do exactly the same procedure on a 72-year-old patient that is severely obese with diabetes, the expected account, once again excluding prosthesis, will be 7,600 Rand more than for patient A. Patient C, in our real-life example, is an 85-year-old patient, morbidly obese with diabetes and hypertension. The expected account will be almost 29,000 Rand more than for patient A. So this illustrates the impact of both age and burden of disease on the cost of treating a patient. So what we are saying, Chair, is that we are admitting more older patients and more sicker patients. That's why price inflation is higher than consumer price inflation in the hospital context. Now that we've looked at drivers of increases in expenditure by medical aid schemes on private hospitals, we want to look at our own in-house Mediclinic situation, and we will deal with price and input cost increases at Mediclinic's hospitals. Our hospital tariff increases are based on our input cost increases. Hospital input cost increases are above CPI. The most important cost item, nursing salaries, this is the largest operating input cost with high inflation due to mainly two reasons: the critical shortage of nurses and the competition for nurses with not only other private groups but also the public sector. And then also electricity and food show increases consistently above CPI. On the right-hand side, we just replicated the earlier slide where we looked at the most important input costs as a percentage of our total operating cost. This slide gives perspective on cost increases and tariff increases compared to CPI. We developed this on an index basis going back to 2006. If you look at the graph, the black dotted line right at the bottom or the lowest graph represents normal CPI over that period from 2006 up to 2013. The blue line represents the increase in food cost. The green one right at the top is electricity, and the purple slide, which is higher than our tariff increase and CPI, represents the weighted nurse basic salary increases. You can see the Mediclinic tariff increase is the orange line, which is higher than CPI, slightly higher than the increase in food cost, but lower than the increase in nurse salaries and also lower than the increase in electricity. Moving over to capital expenditure. This slide shows the growth in the BER, Bureau for Economic Research at the University of Stellenbosch, business building cost index, thank you Bram, and depreciation of the rand against the euro over a 5-year period. You will see that the cumulative impact from 2009 to 2014 for the building cost index is 30% and the rand-euro exchange rate is 32%. We pay for most of our imported equipment in euros and not in dollars. We have to make provision for future capital expenditure. The development cost for a new hospital today, depending on what type of hospital you develop, will be between 2.5 and 3.5 million rand per bed. Our newest hospital that we opened was in March 2015, the new Mediclinic Midstream. It's a 176 bed hospital with a heart unit, 2 cath labs, and the development cost was 3.2 million rand per bed. We also have to make provision for replacement of equipment, which costs us 2.5% of revenue per annum. If we look at the Mediclinic situation and our increases in occupancy rates, on the left-hand axis we have the occupancy rate, and you can see that since 2008 our occupancies increased from 63% to 67% in 2013. Today our occupancy rate is at 73%. The reason why we were able to absorb those above CPI cost increases was because our occupancies increased and it made us more efficient. It's not because our tariffs were adjusted in line with the increase in the input costs. We clearly saw on the index slide that our own tariff increases were less than the increases in many of our input costs, specifically the nursing cost. The black line represents our EBITDA margin, which you can read on the right axis, and you can see we were not able to increase our margin even though we had significant volume increases because of the input cost pressures. Our margin remained stable. So what we actually say with this slide is that fixed cost efficiency was passed on to medical scheme members because we were not able to increase our tariffs in line with the increase of our input costs. Another important component that we have to focus on when we look at factors driving our price increases is the pharmaceutical cost. Just a reminder that in our world, pharmaceutical cost is a cost item. It's not a profit center. So as far as surgicals and medical devices are concerned, those prices are not regulated. We negotiate these prices with suppliers, but we sell these items at the net acquisition price, in other words, at cost. The unique model we introduced way back in 2003. As far as ethicals and medicines are concerned, these items are regulated by the SEP dispensation. There are no negotiations with suppliers, but Chair, SEP does not mean prices in South Africa are sufficiently contained. On the next slide, we have an example of a study that we conducted within the Mediclinic International Group. As I mentioned earlier, Mediclinic has hospitals in Dubai and Switzerland. This has enabled us to do comparative price studies, and we used 76 ethical items that are the 76 items that we use the most in South Africa. It's also the highest cost items. All ethical items regulated by SEP. The study found that on a weighted average basis, the price of key products is between 22 and 92% lower in Dubai and between 27 and 61% lower in Switzerland. One has to be careful not to jump to conclusions because this is not a comprehensive study of all the pharmaceutical items. It's a study conducted by Mediclinic on 76 items that we use in our hospitals, the top value and top volume items, but we have access to information in Dubai and Switzerland, and we were able to compare these prices for these items. In our written submission, Chair, a further interesting comparison between SEP and South African state tender prices has been undertaken based on information that was available in the public domain. An analysis of price differentials on selected antibiotic medicines indicates that private sector acquisition costs, as per SEP, are on average 254% higher than public sector products of identical brand name and active pharmaceutical ingredient. So we want to raise a flag. This raises the concern that the private healthcare market may be cross-subsidizing the pharmaceutical costs of the public healthcare market. A system of cross-subsidy would be a key factor in driving private costs. We also conducted 2 additional exercises to check for the reasonableness of prices in the private sector. This is, as far as we know, the only study that has been done in this regard, and this information was presented at one of our Hospital Association conferences. This is a comparison of average cost per admission for private hospitals and public hospitals. The public sector average cost per admission in this study, also based on information available in the public domain, is R8,775, and the private sector average cost per admission worked out to 9,284. This goes back to 2010, so obviously those numbers are not in today's terms, but the ratio of average cost per admission worked out to 1.058 between the private and the public sector. So what this slide indicates is that based on this study, the cost of admission in private hospitals is only 5.8% higher than the cost in a public hospital. Obviously, during this study, adjustments were made for differences in pharmaceutical cost between state tender price and the private sector, and also the impact of value-added tax was eliminated because in the public sector, no value-added tax is charged on hospital services. But Chair, we did another very interesting exercise, and to me this is the most powerful slide on reasonableness of price. If you look at medical schemes and total benefits that were paid out in 2014, private hospitals received 37.6% of the total expenditure. Other expenditure worked out to 62%. Now, I showed earlier an overview of a typical hospital account of Mediclinic. Our fee income worked out to 73%. Now, if we give on our current tariff component of our bill, remember we don't make profit on pharmacy. If we give a 15% discount, it will reduce our EBITDA margin by 50%. We will go out of business. We will not be able to attract capital. For a 15% discount on price, we will reduce our profits by 50%. This will lead to a 4% once-off reduction in the contribution rate of the typical medical scheme member. According to the Council of Medical Schemes, the average contribution per beneficiary per month worked out to 1,410 rand. In other words, medical aid members per beneficiary will save 60 rand per month, and we will be out of business. This clearly illustrates that the problem with expenditure in our system does not lie with prices at private hospitals. If we want to save money in the system, we must address the quadruple burden of disease that we have in this country. We must keep patients out of hospital. Once they are in hospital, it costs money. The provision of healthcare, unfortunately, in the public sector and in the private sector is expensive. The capital investment is expensive. The pharmaceutical items are expensive. The equipment is expensive. So if we want to save money, and if we want to curtail increases in healthcare expenditure to normal CPI, we have to address the increases in utilization.
If we keep patients out of hospitals, we drive you out of business.
It will, Chair, but we must still find the magic touch to do that. The problem is in South Africa with TB, HIV, violence, lifestyle diseases, unfortunately, we see the impact of the burden of disease, and it's difficult to curtail the admission rate at hospitals.
It becomes a matter of choice whether you are driven out of hospital via the discount or via keeping patient out of hospital.
Chair, we have to find a balance somewhere in between.
I understand, yes.
This is basically the last slide, Chair, before I wrap up with closing remarks. We received a copy of the OECD and World Health Organization report. We've asked economists to study the report on our behalf, specialists to advise us. But we want to make some initial comments, but I don't think it's really appropriate to discuss it in detail because we are not prepared for this at the moment. But we believe the samples that were used are not comparable. The purchasing price parity adjustments are insufficient. The growth and demographic profile of medical scheme beneficiaries was not adequately controlled for in the study. Patient profiles specific to the sample was not controlled for, and conclusions are unsubstantiated due to flawed analysis. These are just some preliminary remarks.
But you still need advice from your analyst.
We got this from them already, but before we go into further detail, we want a full report. These comments, Chair, are based on the initial feedback. Thank you, Chair. I will make concluding remarks, if that is in order. Thank you.
Yes, thank you.
Chair, increases in expenditure by medical schemes on private hospital services cannot be benchmarked with reference to CPI. Our input costs do not track CPI for various reasons. Increases in expenditure are driven by increases in hospital price, but more importantly, by increases in utilization. Increases in hospital prices are marginally above CPI due to above inflationary increases in significant input costs. And due to the the balance of power between the hospitals and the medical aids, we can't pass on the increases in our input cost to our prices. Increases in utilization are driven by, amongst others, the aging patient profile, burden of disease, and anti-selection. On the right-hand side, you will see the total expenditure by medical schemes, which is made up by all three blocks, comprises the CPI plus then the above CPI increase in our tariffs, which is then the hospital price driven by our input cost. But the big component at the top, the utilization, is really the difficult one to address. In terms of recommendations, in order to ensure a sustainable and more efficient private healthcare market, the focus must be on, firstly, regulatory reform aimed at ensuring the stability and viability of the medical scheme risk pool. I referred to this. I referred to the fact that the Risk Equalization Fund and compulsory membership were not introduced. We have to remove barriers to develop integrated delivery models. This relates to global billing, global fees between hospitals and doctors, as well as employment of doctors. We don't believe employment of doctors is a prerequisite for us to work closer together with our doctors. We have to do it in any case. Effective and accessible training facilities for nurses and doctors, we have a problem in that regard. And obviously, a more effective public healthcare sector will also support the bigger healthcare system. Chair, I also want to add that the whole discussion around licensing at provincial level, which we raised under the regulatory context, I think should receive attention going forward as well. Chairman, with that, I want to say thank you very much.
Thank you. we will take a lunch break until 3 o'clock. There doesn't seem to be any consensus here as to how much time. I think I must just make a ruling. I mean, because there is a, I mean,
35 minutes, isn't it?
what's the time now?
It's 5 minutes to 2.
Okay, why don't we take a lunch break until 2:45? Okay, I think we must get ready to start. If we can all get seated, please. Okay, can we start with you, sir? Yeah.
Mr. Pretorius, you know what I will be going to ask you, of course. Again, breaking news. No, serious. Yes, with interest, of course, I listened to your presentation, and it is precisely it met our expectation in the sense you give us an overview of who you are and where you are. And we will be able to meet several times during this inquiry on more specific issues and drilling down on specific topics related to prices and volume, etc., and competition dynamics, profitability. But on the quality thing, which is quite important for us, information, of course, in this system is vital. Particularly in a market-driven system is vital, and I think we must agree that information available to consumers at the moment is not as it should. And you've taken us through a number of initiatives, and both on the clinical side and on the patient reported, the patient experience. Can you answer the same question that I asked your colleague before? And that is, why is it that this information is not yet available to consumers?
Dr. van Gent, I think the reason why hospital groups are hesitant to publish the information is because with regard to the publication of information, we operate in a vacuum. There is no regulatory context. We need a central independent body to determine standards, to develop a methodology according to which we should measure, and then we should have guidance on how to publish. If some group takes the lead now, it will be very difficult for other companies to publish comparable information, because our clinical KPI dashboard with the 12 indicators that we've developed might look different to what the other groups have developed. And I think people are hesitant to publish if information cannot be compared, if apples cannot be compared to apples.
Absolutely.
So I think we really need, and we will definitely support and work together to establish at an industry level a body that can take this whole process forward.
Yeah, I fully understand that. It's the logic of collective action, isn't it? You can't actually, well, you can do it on your own, and you can and you will, you told us this morning, publish on your own maybe what is less sensitive from a competition point of view. So your comparison to the 1,800 hospitals, which is courageous, because I fully agree if you do this as from 2014, you are bound to see results that you wouldn't like to publish. But if you do it anyway with an explanation, I'm sure the public will understand what is happening here. But yeah, the more structural solution is a collective solution on some respects, of course, on standardization, on agreeing on what clinical indicators and what patient-reported methodology to arrive at. And there are different players here that could play a role. It could be HASA, it could be HPCSA, I don't think you're waiting for that. It could be schemes, it could be a collective of schemes, government and hospitals and doctors. I personally led an initiative in the Netherlands for 4 years on that, a collective effort. But it can't be without collective action, isn't it? And my question to you is, my impression is that all parties are waiting for one another at the moment. And you need not necessarily wait for government or a governmental organization to start the initiative. You could, as hospital groups, I mean, it's not price coordination that you're proposing. You're proposing coordination on standards, which is a completely different issue from a competition point of view, as the Senior Council will confirm. So are you waiting for one another, and is there an initiative to be expected from you to cut through the prisoner's dilemma?
Doctor, as a company, we have been discussing this whole issue for many years. And as I mentioned earlier, in 2008, we already published a clinical services report in our annual report. But that is aimed at shareholders. It's not directly aimed at patients. But we took the bold step in the absence of a regulatory context to publish the information. Since then, at a hospital association level, we have a quality subcommittee.
Yes.
This committee has engaged actively over the past 5 years at least with government and the recently established Office of Health Standards Compliance. We really want to compliment government for taking that initiative. That is a step in the right direction, and the fact that they have the vision to say that those standards must apply not only to the private sector but also to the public sector, we think is very positive. And our quality subcommittee at an industry level has been engaging with the Office of Health Standards Compliance for many years to work on detail, to comment on draft standards. Unfortunately, Dr. Carol Marshall, who spearheaded this initiative, retired recently. And I think we lost a bit of momentum, but we know that our National Minister of Health is very passionate about quality healthcare. We share that vision and passion, and we will definitely at an industry level take this further. And from our side, we will initiate further action at an industry level to give this the necessary attention.
Can you let us know what is happening at the industry level before the end of this inquiry? Because we want to and might want to take it on board in our report. It's a very important topic, I think, for South Africa and for the inquiry. And then, of course, thank you very much. And then, of course, there's a topic of cooperation with the doctors, because the doctors have a special position in this. We all acknowledge, I think, and it's a sensitive one, but it's a vital one. So you have to. Hospitals and doctors need to, my question this morning was, you are responsible for what is happening within your four walls. And left or right, that includes also what happens at the doctor's level, isn't it? How do you look at that, the prospects of cooperating with doctors on this, your doctors?
Doctor, I think you raise a very important point because the private sector model in South Africa, as I pointed out, is actually a fragmented model.
Yes.
Fragmented healthcare models do not really support optimal quality and cost efficiency. So we cannot improve the value proposition to our patients without involving the doctors. Healthcare is essentially a team sport, and we all have to work together. And when doctors are trained in the academic sector, they play in a team, and when they move into the private sector, they work in silos in the individual private practices. So we have to change that model. All of us have to work together to put patients first and to support the quality and the cost initiatives in our hospitals. So as a company, we have established clinical hospital committees at all our hospitals, and the sole purpose is to engage with our supporting doctors on issues of quality and patient experience as well as the cost per event. So we have to do it in a cooperative way by sharing the information with the doctors. And we give every doctor a profile of the work that they do at our hospitals, so that they can see, and we benchmark them against their peer group. And obviously, most doctors don't want to be outliers. So if they see where they lie in relation to their peers, they make plans to improve the situation. And the example that I showed on the knee replacement, we didn't force the doctor to do anything. We just showed him that he is an outlier, and he made plans to improve the situation.
There's excellent research in the United Kingdom on this, on if you show doctors their results, they will improve. In the same research, it is shown that it's one thing to show them and to benchmark them. It's another thing to publish. If you publish, the incentive to improve is a multifold of what is happening if you just show them. You see what I'm getting at? I want that breaking news, of course, from your side. But going back to your value proposition, and can I take you a step further? Because these are, with all respect, Mr. Pretorius, nice words. I'm not in your daily practice and how you daily translate that in your practice, but these are nice words, and people will write it down. We saw it, and it makes sense. The clinical quality, the patient-reported quality, and the cost part. And then looking at your admission of the, what is it, 2,500, 2,400 medical specialists in your hospital, and we have talked about shares and the 2% and the 25%, etc., etc. And you assured us there's no incentive in these contracts anymore, or especially not. You talked particularly about the new 2012 rules to either guarantee volume or whatever. But wouldn't it be concrete, to make it concrete for the doctor to adhere to this value proposition, that when he or she is being admitted in one of your excellent hospitals, he or she has to abide by a certain number of rules? For example, make available a number of data points during the treatment process, of which you can derive metrics that would be more meaningful than the metrics that you have at the moment.
Doctor, I agree. I think that is ultimately what we want to achieve, and the metrics that we measure are all influenced not only by what we do at the hospital level, it's obviously also influenced by what the doctors do. So we have to work together as a team. If we want to improve our mortality index, we can't do it in isolation. We have to do it together with the doctors. We have to discuss it at the clinical hospital committees. We need the whole team to be involved.
But these again, Mr. Pretorius, are memorable words, of course. But,
yeah.
But now about practice. Can you, in practice, require from your the doctors that you admit or that you already admitted to make, subscribing to the value chain, i.e. providing clinical information, in cooperation, of course, with you yourselves, maybe scientific organizations that design these metrics for the South African environment, and the doctors' organizations. Could that be a concrete next step in your?
Doctor, it can be a next step. Obviously, to require from doctors where you don't have an employment relationship is difficult. You can't force it onto the doctors, but our experience has been that most doctors, by far the most of them, want to do the right thing. Most specialists are academics. To become a specialist, you have to be interested in academics because you study for many years. And all our engagements on these quality indicators and practice profiles that we've shared with our supporting specialists have been positive. They are really interested in the outcomes and the cost, and they want to improve. So we don't have it as a requirement in our rental agreements, but we think we will be able to convince the doctors that it is the right thing to do. They will share that strategy or that vision, and in time it will become a requirement. But it's a process. Remember, we can't just from tomorrow say it must now be a legal requirement or in a legal contract. We have to convince them, we have to build a relationship, we have to get their support, which we don't think will be a problem to get over time.
Well, if you look at the Health Professions Act and also the Health, what is the Health Act, National Health Act, you see there's requirements in these acts that at a global level refer to the obligation of everybody providing healthcare service to provide the right information to consumers to make a choice. That could include quality information. So there's there's also an obligation, I think, of everybody engaged in the healthcare sector to just do that. So I'm not really fully convinced. I understand and I hear what you say, and I know things can't be changed overnight. But I do think something really needs to change in South Africa, and every player, main player in the market, must make it a sort of personal crusade to do that. Because you shouldn't, I think you shouldn't wait for public organizations or maybe even the other side of the market, the schemes and administrators, to force it upon you.
I think, Doctor, the challenge is that if you want to do all of what you propose, and if you do it where the playing field is not even, it becomes difficult. It should be a requirement nationally that quality and patient experience should be published by all players. In other countries where we operate hospitals, it is a requirement and everybody has to do it. So the sooner you put those type of regulations in place, the quicker providers will get their act together. Yeah. If you do it voluntarily, you rely on people that share the same passion and the same vision, which I think can work, but it will take longer. So we in South Africa need a very strong independent authority that will develop the standards, that will develop the methodology to measure, and we should all be forced to publish.
My experience, and also experience that I saw in Australia and the United States, that if doctors and hospitals take the initiative, the quality of the information is better and it can work faster as well. If people have the commitment to do it instead of are forced to do it, look at your children, then it could work the other way around. So I challenge you to think about it and to take the initiative, also the collective initiative. I think we heard your competitor live actually not being far off from what you just told us. They have the same vision, I think. So I could imagine there's ground to cooperate at this particular point in time.
Yeah, Doctor, we will continue our own efforts within Mediclinic. We will, from our side, and I heard the commitment from Life as well, give this industry initiative more impetus. But I think ultimately we need a changed regulatory environment as well. But I agree with you, we shouldn't wait for that. No. In the meantime, we must do it, and the further we get with our own initiatives, the better the cooperation will be. I fully agree with you.
Now, can we go to the breaking news, Mr. Pretorius? And that is, when will you publish the experience data per hospital on your site? Maybe
Yes, Doctor, our vision is to do that within the next year.
Very good. That's been noted. Can I just briefly take you to another question that I asked already this morning, because I knew that Mediclinic has an active policy. It's about day hospitals. And you told us you just recently opened 2 day hospitals on a sort of co-location basis. I agree, and I think this morning I already alluded to that sort of model without using your word. Can you tell us a bit more about your strategy on really? I read a document that you wrote to your doctors on this particular issue. Tell us a bit more about the initiative. Why do you think it is important, and why maybe you think it is important for South Africa in general?
Yeah, Doctor, we think that the outmigration of care from multidisciplinary acute care hospitals is a reality. It's happening all over the world. Due to technological advancements, advancements in the field of anesthesiology, many day surgery procedures can be done safely in a day clinic environment. The inherent cost structure of a day clinic is a lot cheaper, the development cost as well as the operational cost, because these facilities typically function during working hours from Monday to Friday. So you can do a lot of the work that we currently do in big hospitals, our own type of hospitals.
Yes.
You can do that work very efficiently in a day clinic environment. But the market in South Africa, interestingly enough, has evolved over time. I worked for the Presmed Group, who was the biggest owner of day clinics many, many years ago. The company was taken over by Life, and many of those day clinics don't exist. But I remember in the early 1990s, medical aid schemes did not channel or incentivize day surgery to be done at day clinics. Doctors who have their rooms at the multidisciplinary hospitals were not keen on traveling to these day clinics. It's inconvenient. So during the initial round, day clinics in South Africa were, so to say, ahead of their time. But times have changed. The pressure is on. Costs are increasing. We need cheaper alternatives. So we believe the best strategy is to, where your capacity is under pressure, instead of building traditional wards, traditional theatres, rather do a co-located day clinic on your premises. It's very convenient for the doctors. They don't have to travel. It's very convenient for patients. It's very safe. If something happens to the patient, the big hospital with the ICU is close by, and you can share certain of the costs between the day clinic and the hospital, because you don't need an additional technical team. You can share the administrative functions. That's why we are now busy with this so-called co-location model. There are many advantages, and we have 6 licenses to develop more of these facilities. We already opened 2 during last year, as I mentioned.
I think the document, just to assist you, the document that's being referred to here, it's a document which was issued by Mediclinic on the 20th of May, which says Mediclinic's Day Clinics Doctors Information Sheet. It was distributed, as I understand it, on the 20th of May. It was made available to us by one of the day clinic representative. You may just want to have a look at it.
Chair, I have a copy of the document. Yes, thank you.
Okay.
My last question on this issue, and I'll give the floor to my colleagues, is, so you made a strategic decision to do this and to, as I read, make it a real effort to start, I think, 2 hospitals per year or 2 day clinics per year. So there's some reference to a quantitative goal here as well. Is there anything in the commercial environment, also referring to your negotiations with schemes, that would keep other companies, you yourself or other companies, from this strategy and if I remember well, the organization that gave us this information talked about 7% penetration now, and where it would theoretically be possible to have 75% of procedures whether there is 70, but it's an amazing figure that could be done on a day care basis. Is there anything in the commercial environment, including the demand side, that would keep you from moving fast in that way?
Dr. van Gent, our experience in our own hospitals is that we can do a lot of the surgical cases on a day basis in day clinics. It's not as high as 75%, but it is a big business. It can be viable, definitely. The only possible obstacle is the awarding of licenses. I heard that the Day Clinic Association made a strong case to say licenses should not be issued to the hospital groups if they want to develop day clinics. I actually found the argument very strange because they argued that it's already difficult to compete with the hospitals, and if the hospitals now develop their own day clinics, it will be even tougher to compete. But I suppose that is what competition is about. So we obviously don't support their view that it must be made difficult for hospital groups to develop day clinics. I don't see why. I think hospital groups, if they want to establish a new division or a new department to develop these day clinics, they have the same right as the other players in the market who also want to develop day clinics. So, except for possible licensing issues at provincial level, I'm not aware of other commercial obstacles. Where we have opened these facilities, we were able to negotiate tariffs with the medical aid scheme. So we will get support from doctors, we'll get support from patients, and the medical schemes will pay for our services.
Thank you for your presentation. My first question is around the tariff schedules. In the beginning of your presentation, you showed us how you communicate your tariff schedules to patients. In your written submission, you do raise an issue about the need for medical schemes to contain costs, and how they do that at times is through the use of formularies. You also go on then to explain that that then incurs co-payments on the side of patients, and often decisions on whether one is going to use formularies or not is taken perhaps at times at a time where a patient is not able to give consent to that, and therefore they would not know what they're financially liable after going through a procedure. So I'd like to know first how prevalent is it in your hospitals the use of non-formularies, and why that is the case?
Doctor, thank you. In this area where you talk about formularies and tariff schedules, our expert in the field is Mr. Rowley Buys. He heads up the department that does the negotiations with the medical schemes. So with your permission, I'm going to hand over to him on this question. Thank you.
Good afternoon, Doctor. No, I think to put some perspective to it, I think if you looked at our submission, we gave you an indication of what we also called out-of-pocket expenditure, and you'd have seen it's around about 2 to 3%. That 2 to 3% includes the deductibles, the co-pays, where the funders also want us to collect some money. So specifically on the non-PMB cases, you often find a medical aid says, for a dental procedure, for example, there's a 4,000 Rand deductible. It's their rules, it's their requirement, and so that would be part of the 2 to 3%. So the rest of the 2 to 3% is then these formulary issues. The formularies are developed by the individual administrators or medical aids. We have no input in the design of the formularies. We're not involved in deciding whether it's right or wrong. Clearly what happens then when the patient comes in is that we are not able to decide beforehand exactly what is going to be used every time. And so that's where this dilemma comes in, that the patient may receive the surgical or this particular item while they under anesthetic. And that requires, or that then becomes the dilemma that the patient faces afterwards. I must also clarify, though, that at the time when we did the submission, there were some significant formularies that were quite problematic in terms of this for one or two of the schemes. In the process of last year's tariff negotiations, we engaged quite robustly with that particular administrator, and that formulary has been dramatically reduced from like 7,000 items down to 700 or 800, so significant change. And so to a large degree, the issue that we raised has gone away. The formularies do remain. They are part of the funders' right to manage, but they've become a lot smaller than what we intimated in the submission at the time.
Just for the record, that was Mr. Bays speaking, is that right?
That's right.
Yes.
Okay, thank you for that response. So even though you do mention that it is within the range of 2 to 3%, the reason I was raising it is that it is a co-payment that a person would not be aware of before, and we've had submissions, we've had patients talk about the experiences of not knowing what they're liable for, in particular within a hospital setting. So I'll move on to the my second question, which is also around the issue of negotiating tariffs with administrators. Again, in your submission, you raise an issue that's not only been raised by you. I think NHN yesterday raised the issue, I think as well as Life, that administrators now do negotiate on behalf of several medical schemes, and at times negotiating a similar rate. So what is your issue with this? Do you feel that it is illegal, inappropriate conduct, or?
I don't know there's necessarily inappropriate conduct. I think what we were trying to indicate that there's a variety of negotiating forums. So there are single administrators that talk exclusively on behalf of their medical schemes, and consequently you get the result that there's a single percentage tariff increase that's negotiated. You get the same set of benefits that get given to the schemes, etc., etc. We then have other medical aid administrators that negotiate collectively in a sense, but with some degree of individual discussion with the medical schemes. The problem around some of this is that innovation largely gets stifled when you're in an environment where the single rule gets applied consistently across an administrator. So you would find that we would go to some of the smaller administrators or the smaller schemes and actually find them that they're very open for innovation, and they actually have an interesting view on changes. So we have, for example, small schemes with 2,000 or 3,000 members that have developed alternative reimbursement models, that have put networks in place, and are looking for change, which you find then runs down when you're in the bigger administrator that's very regimented. You find that you have to apply the same rule for all of the schemes. I do believe it's something that needs to be noted from time to time, because I think what's interesting and very important is that we see an incredible amount of amalgamation in the funder market. I think in our submission we show you that the hospitals consolidated up until 1998, but since then we've seen a huge consolidation on the medical schemes and specifically in the administrators. And so suddenly now we find ourselves in a situation where if we were to analyze our hospital market at a hospital level and we decided to ask ourselves, if we took the two biggest schemes, what percentage of the market they take, then you'd find that in 40 or 45 of our hospitals, it's 50%. So clearly there's a huge degree of amalgamation that's happening on their side, and consequently we want to understand that there's a forum for innovation that still exists afterwards.
Thank you. And I think my last question is on the purchasing of equipment. And so I think in your earlier slides, you showed us how you purchase equipment and the standard that you use. it has been argued by several stakeholders that hospitals compete for specialists, and how they do that is through the purchasing of equipment. And so I missed in your presentation how you make decisions about what equipment to purchase, and to what extent do your doctors influence that process?
Thank you, Doctor. Yeah, we have quite a rigorous process in place before we buy equipment, and our philosophy has always been not to necessarily be the leaders when it comes to new technology. We have a philosophy not to buy technology that has not been proved to give the necessary benefits. But Bram Joubert, our Chief Financial Officer, heads up our procurement function, and maybe he can just quickly summarize the process to answer your question.
Thank you, Doctor. I think from our side, we can't just waste capital on things that does not create any return for us. We don't have an unlimited pool of capital that we can spend. So many years ago, our philosophy is centralization and standardization. We believe that worked very well for us. So we've got a centralized capital procurement department. All capital procurement are done centrally. So all motivations coming from hospitals, doctors' motivations goes through hospital managers. Hospital managers motivate to the central procurement department. We've got committees in place discussing it. Now, technical equipment, medical equipment is very technical, so we believe you have to pool that knowledge at a central point. So we've got knowledgeable people in our corporate office. They evaluate new technology with the input of our clinical department to look at clinical reasons. That's one component of evaluating equipment, but we also evaluate the subsequent cost of maintaining equipment. With what partner should we buy this equipment? How does the after-sales service look, etc.? So there's a host of things that needs to be addressed before we introduce a new piece of equipment. Obviously, if we already have gone through that process with another hospital, it's much easier because you already did that homework. Now, from our point of view, there's two reasons why we buy equipment. One is if it's additional work the doctor can do with that equipment that we haven't done in the past. So a new tool for the trade, for him to be able to do a certain procedure. That is one component of it. And then the second way what we do and evaluate equipment on is if it's clinical enhancement of what we've done in the past. So both one, in the past there probably wasn't a piece of equipment that did it. For instance, in the past we washed scopes by hand. Now it's instrument washers. It's clinically proven that it is cleaner and better. It is an advancement you can't ignore for better clinical outcomes. That's only one example of it. So you gradually introduce that for new technology that increases the quality of patient care over a period of time. So on those two bases, we evaluate equipment, new equipment coming into the business.
Thank you very much. I was reflecting on your comment about keeping people out of hospital. And I also noticed a very significant partner of yours is Remgro. Tobacco, wine, spirits, processed foods. Maybe you could influence them to decrease the hospital intake. Yeah. I also see that what I found difficult, and maybe something you can help us with when you come later, is I see that your operating income before interest, taxation, depreciation, and amortization increased by 11% last year. What I can't work out from this webpage is the comparator for your other operations in Abu Dhabi and the UK. And I think the UK one isn't reported yet, but the Switzerland. And I mean, it would be nice to be able to have you're the same group operating in different environments. How does that work? And so if we could ask you for when we do that more focused investigation, if we could have some comparators with your other groups, because here it's presented before and here it's presented after, and so I simply can't compare them. So I think that that would be useful. One of the issues that we are confronted with is these big groups, and these big groups offer economies of scale. And I keep looking in every instance for where these economies of scale are passed on to medical scheme members. So if there are no economies of scale, then you can't be doing your job very well. Or you're not passing them through in your relationships with the schemes or administrators, or they aren't passing them through. And we need to understand that. So I don't know if you have any particular comment on that now, or if you'd like to speak to that later as well, but is there any comment you have on that?
Thank you, Professor. We will definitely come back on the other issues that you've raised during the next rounds on profitability and the increase in our profit and how that compares to the other platforms. But just a few comments on economies of scale. Firstly, it's very important to understand that in the hospital business, there are not a lot of economies of scale because the two biggest cost items are variable cost items, namely nursing cost and pharmacy procurement. In other words, if we don't admit a patient, we save by far the biggest portion of the cost, 49% of total cost in terms of nursing, and then 28% of revenue in terms of pharmacy. So in healthcare, like in other service organizations, you have this Baumol effect where you can only increase productivity up to a point, but you have to make sure that you have enough staff to provide quality care to your patients. So I think that's a very important concept to keep in mind. Where you do get economies of scale is on your back office functions, like centralizing financial services, centralizing administration services, and those efficiencies are in the system. The reality is that if the economies were not there, the price would be even higher than what it is today. The biggest problem that we have with expenditure on healthcare in the South African context, and probably all over the world, is the usage. The usage is driving increases in expenditure at a higher rate than normal inflation. And that is due to lifestyle disease, obesity, burden of disease, all those factors. It is unfortunately the reality. I made a tongue-in-cheek remark earlier about keeping patients out of hospital. But we've seen models in the United States where a fully integrated model that is operated by Kaiser Permanente, they admit 180 patients per 1,000 of their insured population. In South Africa, Rowley, I think we are at 250 admissions per 1,000 of the population. So the admission rate to hospitals in South Africa is very high. And I think that message has been reinforced by various previous stakeholders in the bigger healthcare context who also presented to the panel on that matter.
So let's look then at nursing costs, and then we'll come to the admission rates. you run your own nursing agency. So that's an in-house system. Can't you charge yourself less for that?
I'm not sure I follow your comment.
Well, my understanding about the idea of having an in-house nursing agency so that you don't always know, because your bed occupancy varies, you don't always know who you need when, but if you've got a captive pool of workers, you can distribute them as you need them. And for other hospitals who don't have this kind of benefit, they either can't find them or they pay a premium. So your nursing costs, to some extent, are controllable by yourselves because you do have this facility.
Professor, I understand what you mean. This nursing agency that we have, they don't only provide nurses to Mediclinic. They also provide to other hospital groups and the public sector. It is a wholly owned subsidiary, but it is a standalone business, and they do business at an arm's length, in an arm's length way. So they charge Mediclinic the same that they would charge other hospitals who make use of the services. But that business is not a very profitable business. It washes its own face. The main reason why we started the agency was not to make profit. The main reason was to, as you've described, was to create an in-house company that can assist us with attracting nursing staff from various sources to be placed at our hospitals.
The other, and this is questions I've asked the other people, the other issue around nursing, and you have addressed it to some extent, is the decreasing nursing ratios and patient-to-nurse ratio and the decreasing level of care, and then the apparent preference by doctors to not admit to your general wards because they don't trust the quality of nursing in those wards. And then the same question, does this happen at your institution? And what is the effect on your bottom line?
Professor, we have no evidence that this is a general occurrence at our hospitals. We've heard anecdotal feedback about cases where it happened. We are not aware that it's happening at our hospitals, but we obviously face the same challenges than the other groups. There is a shortage of nurses. The quality of training in the country is of concern to most players in the hospital industry. Nursing ratios in our company have remained fairly stable over a very long period of time. In fact, we actually embarked on a specific project which we call the integrated staffing model, where we, over a period of more than a year, developed a very scientific methodology by which we allocate nurses at ward, ICU and theatre level. This model was developed by specialist nurses in their different fields, theatre, ICU, emergency units. It's actually quite complex and takes a lot of time, but for every patient, they have a questionnaire. I think at the moment there are 25 questions by which they actually evaluate the acuity of every patient, and according to a formula, nursing staff are allocated. Not only the number of staff, but also the mix between professional nurses and the sub-professional categories. So we follow a very, very scientific approach in terms of allocating nursing resources to the different wards. But it can happen at a specific day, on a specific shift, that we battle to find a nurse to work in the ICU. But that is the exception and not the rule. And I think it does happen at all the hospitals in the country, unfortunately.
Anyway, we carry on asking all this question of all the players, but so far everyone tells us there's not enough nurses, and everyone tells us that their nursing ratio to patients have been stable over many years, and these two things this 1 and 1 does not seem to add up to 2. Is it possible for you to tell us the proportion of your discharges from theatre? What proportion of them go to ICU by category of whatever, if it's a hip-hop or a knee-op or a whatever. What percentage of them go to ICU, what percentage of them go to high care, and what percentage go to a general ward? Is it possible to give us that data?
Professor, we have the data. Unfortunately, I don't have it with me today, but we will definitely gather the information and share it with you. What I can mention, in general, 10 to 11% of the bed days that we sell are normally ICU or high care beds. And if you look at that ratio over time, it has remained fairly stable. Sometimes it goes up a little bit, sometimes it goes down a little bit, but there's no strong trend of big increases in the more acute wards, because that would indicate that doctors are now just admitting to high care and ICU, and those beds will be full very quickly and the wards will be empty. So we haven't seen anything like that on a big scale at all.
So given your this very sophisticated and impressive sounding model of how to allocate nurses, you could actually give us a sort of like almost a graph of where your nurses are at any, well, over a period of time.
We can do that. We have that type of information available.
That would be nice to see. Thank you very much. I want to understand something. You said that you work in a highly regulated environment, and you also said that in fact there is a lack of regulation around transparency, particularly in relation to quality, and there might be some issues, maybe it relates more to doctors than to hospitals, around pricing. Do I understand you say that you are not against increasing regulation around at least these areas?
Professor, our view is that increased regulation in terms of quality, sharing of information will actually be good for the industry as a whole. If we do that, we will be following what's happening worldwide. I think today it's accepted that healthcare should be transparent, and having the advantage of operating hospitals in different countries, we get to learn a lot about measuring quality, measuring patient experience, and sharing information. So we would certainly support that, but on certain conditions. We definitely feel that the body that makes those regulations should be independent. It should apply to the public and the private sector. The methodology should be transparent. The methodology should be scientific, and the rules should apply to all players. The playing field must be level. But in principle, we support it. However, we do not think that prices should be regulated. I heard that you specifically talked about prices as well, but that's a different debate for another day.
I want to explore again in a bit more detail the question that Dr. Nkonki asked you in relation to acquisition of technology. So there's certainly across the world, not only in South Africa, been the accusation that technology often drives costs. And my question is, you mentioned a new tool for the trade, and you mentioned evidence-based in your decision-making in deciding on what to do. Currently in South Africa, we do not have any method of saying whether it's a protocol for treatment or whether it's a particular technology guiding us in terms of some normative sense of one, does it really work or not? Does it improve outcomes? Might improve diagnosis, but sometimes that makes no difference to health. and whether, as a country, we should be investing in it. In other words, what the cost effectiveness is and the cost benefit is. Do you do any kind of health technology assessment in-house? Do you make that available to anybody? If you do it, would you be willing to share it? And what is your view on some kind of national body that advises on these kinds of new investments?
Professor, in Switzerland, for instance, highly specialized medicine is regulated because not only the investment in technology is important, but also the fact that to deliver those type of services, you should adhere to specific quality standards. And it has been proven in healthcare that the more volumes you do of specific procedures, normally the better the quality and the outcome. We actually have studies that confirm that. That's why if we develop new types of disciplines at our hospitals, if we establish a new heart unit, even if we think that it can be financially viable, we look at the clinical assessment as well. For instance, in a cardiac unit, it's accepted worldwide that you should do at least 150 open heart cases per year, otherwise you can't deliver acceptable quality. So we take that into consideration. We won't invest in new technology just from a financial perspective. But Bram, health technology assessment, I know, is done to some degree in our procurement world, and our holding company, Mediclinic International, is now establishing a full-time function to perform exactly what you are talking about, not only for South Africa, but for all our operating platforms. I don't know, do you want to add, Bram?
No, I think from our side, it's mainly in-house. We don't publish it outside. It's not clinical trials that we do. We analyze current literature around that's the main source that we use. So it is literature available at other countries, sometimes very limited. So sometimes you access the technology on a very small scale, so only at one hospital, and then you re-evaluate later on to see if it was successful or not, without going in and say this technology needs to be implemented in all the hospitals. So it is not an exact science. We're not purporting to be the expert in deciding if new technology is the right thing or not. We try to use existing literature, read up, talk to doctors, get as much information around that technology as possible. But it's not an exact science.
It can be an exact science. Would you support a body, that was my last question, if we had a national body that did do that, would that be something that, one, you would be in support of? Two, would you be willing to assist funding such a body? And three, would you follow its guidance?
Professor, I think in healthcare we need that type of function to be performed. If we can share it, if once again we can establish an independent body to do this type of assessment and give guidance, I think it will be a positive development for the industry. So in principle, we will certainly be willing to look at that and to support it.
And I wanted to go on to the doctor stories and the utilization. Both in the reports of your results and in everything you've told us, the increase in income comes from increase in utilization. And so that's good for the bottom line, isn't it? I mean, that's where you deriving your growth.
That's correct. It's good for the bottom line, but as I mentioned during my presentation, there's no sense in increasing the bottom line in the short term. For us, we want to be here in 100 years' time, and long-term sustainability is more important than short-term profit. You can see from our own margin that we performed well, but we were not focused on improving the margin only in the short term. We reinvest in technology, we upgrade our hospitals, we make sure we have adequate staffing in our hospitals. So a sustainable long-term business is more important, because from an investment perspective, we also think that that's an attractive case for the suppliers of capital because of the defensive nature of the industry. We sell a service that people need on a daily basis.
And then the other thing that, of course, drives your utilization is doctors' admissions, doctors' behavior. So there seems to be and you know, they might have a short-term or long-term view, we don't know, and I'm sure there's a range among them. But there's a coincident interest in increasing utilization for whatever reasons. So then I find it hard to understand if doctors want to admit more and they want to play with new toys that are there to be played with, and you need to keep your bed occupancy rates up. How then would you, employing doctors, bring down any of these utilization rates?
I think, Professor, we have to realize that in dealing with doctors, we deal with professional people. All our supporting doctors are registered with the Health Professions Council. They have ethical rules in place. And what we have seen in our business over time is that the increase in utilization was driven by, firstly, over time, growth in medical aid scheme membership, especially GEMS during the last few years. We were able to add beds to our hospitals because of the growth in the medical aid scheme membership. And obviously, we were then able to recruit more doctors to service those patients. And then, if you look at the type of patients that we admit, they are more older patients, sicker patients. This technology that we've been discussing makes it possible to do procedures that have not been possible before. So it's a combination of factors that drive this utilization. Very difficult from the provider side to curtail the growth because the funding side of the business is responsible to manage hospitalization of their membership. We need national campaigns to improve healthcare. That's why, as an industry, we want to congratulate our Minister of Health for the role that he played in the introduction of the sugar tax. If we can have less obesity in the country, if we can have people with lower cholesterol, with less diabetes, I'm convinced a healthier population will require less hospitalization. In our country, our national minister often reminds us of the quadruple burden of disease. We have HIV, AIDS, we have TB, we have a very high level of violence. If we look at our ICUs at many of our hospitals, we admit many patients through our emergency units that were injured in accidents or wherever. Our medical discipline is the highest discipline because of the burden of disease that we face in this country. So those are the type of changes that we need to curtail the growth in the burden of disease.
I mean, I suppose I'm sort of lost, because if everything has to do with the burden of disease, then we should just close down the inquiry. Is that your position?
if we look at the information that has been presented to the panel, if we look at the presentation from Discovery Health on where they find the drivers in utilization. Look, we have price increases in line with CPI. Our information confirms that. Many of the other presenters confirmed that tariffs in the private healthcare industry in South Africa is not the issue. The issue is the total increase in expenditure. And there's at least a 4 to 5%, I think according to Discovery's information, a 4.5% increase above CPI in terms of their expenditure. And that 4.5% is due to utilization. There are demand side factors, there are so-called supply-induced factors, but over a 5-year period, a 4% increase in utilization annually will give you 20% more expenditure on healthcare costs. That, to our mind, is definitely the biggest challenge. I'm not saying it's the only challenge. We have many other challenges like you've pointed out. We have a fragmented model in the private sector. We need to cooperate closer with our doctors to address issues of quality, of patient experience, of cost per event, and all of those will contribute to more efficient and more effective healthcare delivery. But purely from a volume perspective, the demand and supply side factors driving utilization, I think, are the biggest issues that we face.
And I suppose that's it, is how much of that utilization is supplier-induced demand. In one part of your presentation, you said you act as the agent of the patient in facilitating their access to their benefits so that you can so they can have their care covered in your hospital. And I'm sure they appreciate it because it's very hard when you're in hospital to be doing those things on your own behalf. Do you agree that it also serves your own interests?
I think it serves the interest of the patient primarily because we don't just phone the managed care company or the medical aid and they give us permission to keep the patient a day longer. There must be a very good clinical indication before extended length of stay will be approved. Before a patient is admitted in the first place, we have to get permission, or the patient actually has to get permission. Many medical schemes don't accept, or managed care companies, Rowley, don't accept if the hospital phones on their behalf. The patient has to get the initial permission. But obviously, while the patient is in hospital, the patient cannot always engage the medical scheme or the managed care company, and then we do it on their behalf. But they have very strict protocols. They have very good data. They will not give you permission to keep patients longer unless there are very good clinical reasons to do so.
I've got two other questions, just so you know I'm getting to the end. You said that you were speaking about your relationship with doctors, and you said something that you had a very positive experience of your shareholding arrangements, and then you extended it. And again, this makes me wonder to myself about the notion of supplier-induced demand, whether it is overt or simply a background factor. Can you tell us more about this very positive relationship and what you think it is that's so positive from your point of view and the doctor's point of view?
Professor, I'll answer your question. I just want to quickly refer to the supply-induced demand. From Mediclinic's perspective, it's very difficult to quantify. We only deal with information that we get once we've admitted a patient. We can see the drivers, the aging patients, the burden of disease, but we don't manage a fixed population or a membership group like a medical scheme would do. So they have more information available to distinguish. When it comes to utilization, they are able to distinguish between so-called demand side and supply side. And Discovery is probably the scheme with the most information in this regard. And if I understand the information correctly, the demand side plays by far the biggest role. The supply side is not the major driver of the utilization. So I just wanted to make that comment. In terms of doctors' shareholding, what we find the biggest challenge to improve our so-called value proposition to the patient is that you need teamwork and you need alignment of interests between hospitals and doctors. The best way to get that partnership going is co-shareholding, because then you have a trust relationship between the hospital and the supporting doctors. Let me give you an example. We moved to the net acquisition price model way back in 2003. We don't make profit on any pharmaceutical item. We've told that to the whole world, including our supporting doctors. We still have doctors who don't believe us. But if a doctor is a shareholder, if a doctor serves on a board of directors at a specific hospital, he gets hard information, he gets financial statements, he understands the business. So the participation in management is at a different level because of that trust relationship. Because now the hospital and the supporting doctors have the same interest. That's why we found the development of relationships to be a lot stronger. The understanding of the hospital business is a lot better. The alignment of interests happens a lot better when you have these models in place. But normally for most of our doctors, if not all of them who are shareholders, the shareholding and the income from the shareholding is a lot less than what they will ever make from their own practice income. We specifically cap it to be in line with the HPC rules in terms of what is acceptable for shareholding schemes.
They might have a touch of brand loyalty. The last thing is around this international patient experience survey, which, if I look at your indicators, are patient satisfaction indicators. Did you like the food? Was the nurse nice to you? Did you like your doctor? And so on. So are you aware of the sort of state of knowledge around patient satisfaction surveys?
Professor, if you say state of knowledge around patient satisfaction surveys, do you mean different type of models?
Well, the degree to which, let me put it to you this way. There's been a lot of research on this issue, and patient satisfaction surveys, particularly exit surveys, are notoriously poor in actually telling you very much about quality. Even when we do patient satisfaction surveys out of our public hospitals, we probably get really good rating. And so they are pretty poor. And so as much as I agree that this is a really good step in the right direction, I would suggest that even if this is internationally benchmarked and everyone's doing it, everyone is then relying on pretty poor quality data. And what has been postulated as something a little bit more objective and more reliable is health outcome data. Would you be similarly willing to get involved in a process that rather measures some hard outcome data rather than things like satisfaction surveys?
I think you should deal with the first question, with the first proposition that was put here. That is, patient satisfaction survey are generally poor. What do you say to that?
Thank you, Chair. I'll respond to that first. I agree. Generally, Professor, they are poor. We had an in-house Mediclinic patient satisfaction survey system when I joined the group 17 years ago. The questionnaires were handed out by our own staff while patients were in hospital, and all our hospitals scored between 95 and 99%. Then we decided that's not a realistic feedback mechanism. So we outsourced it to a local company. We still performed well. And then when we expanded internationally, we decided Mediclinic International now has to look for a truly scientific tool on which you can rely. According to our research, there are only 2 companies in the world currently that can provide that. The one company is Press Ganey, which is a US-based company. If you tour hospitals in the US, I think, Biren, more than 50%, 60% of the hospitals use Press Ganey. The other company is Picker. They do the patient satisfaction research for the NHS in the UK. After a very long request for proposal process, we decided to go for Press Ganey. This survey is only done after patients have been discharged, because generally patients don't want to complain while they are in hospital because they are concerned that they might be victimized. So we never give these questionnaires while patients are in hospital. We do it after discharge. Press Ganey has a very scientific methodology. Under each of those components that we showed on the slide, there are various questions. I think our questionnaire, Biren, has about 80 questions. You can drill down in each area to each question to really understand what the problem is, and then they also make a recommendation as to steps that you can take to improve your situation. So from all the research that we did, it sounds as if I'm now promoting Press Ganey, but really at the moment in the hospital industry, we believe it is the most scientific tool. Coming back to your comment about rather using clinical outcomes, we fully agree with that. The clinical outcomes is about our core business. That's how we make a living. That's our reason for being. And our research, once again, has indicated that only a weight of 30% in a value equation is normally allocated to the patient experience part. 70% of the value equation should be based on the clinical outcomes. So we would be very supportive, as I mentioned previously, to work together with the authorities through our hospital association to establish a nationally independent body to measure the clinical outcomes. That is by far the most important, but patient experience cannot be ignored according to our view.
Thank you.
Thank you, Mr. Pretorius, and the rest of the Mediclinic team. My questions almost all have to do with hospital-doctor relationship, specifically barriers to entry. Yeah. Now, regarding your process to award practice rights, whether it's admissions, treatment, or even allocating rooms, how transparent is this process? Is it well known to your internal partners or anyone who wants to come into the hospital?
Thank you, Doctor. Our process that we follow is known at hospital level to management and to our supporting doctors. And normally when we want to recruit a doctor, we follow a specific approach. Firstly, we must have capacity in the hospital, because the most attractive proposition that we can offer a doctor is a viable practice opportunity. We can't recruit doctors if they will not be able to admit their patients due to a lack of beds, or we can't recruit doctors if there's no theatre time available. So we have to have capacity in the hospital. That's the first point. Secondly, we look at the mix of specialities at the hospital as well as the number of doctors per discipline. If we already have 4 gynecologists at Mediclinic Stellenbosch and they all make a good living and they deliver a good service, we will not endeavor to recruit a 5th gynecologist. Sometimes, without us proactively recruiting an additional doctor, we are approached by doctors who qualify newly, and then, if we believe we have an opportunity, there is a need, the current doctors cannot meet the demand, we have capacity, then we will first discuss this new possible doctor with the specific discipline group to get their guidance. And then we will refer it to the clinical hospital committee, who will do reference checks, who will make sure the doctor is registered at the Health Professions Council. So we have a fairly robust process in place, and it involves consultation with the existing doctors.
But just to be sure, a question Judge asked the other group is that the final decision, though, rests with the hospital. It's
the final
not,
decision
it's not
rests,
other specialists deciding who they're bringing in or who doesn't come in.
That's correct, Doctor, yes.
Now, still along those lines, would you say there is a hierarchy of preferred disciplines? What do I mean? I mean, if there is just one more vacancy, everything being equal, would an orthopedic surgeon have an advantage over a dermatologist? My question basically says, I understand that you have a business model to follow, but that needs to be balanced, of course, with the desire to have as broad a spectrum of services available. So my question is there a hierarchy of disciplines that you work along?
Doctor, there's not an official hierarchy. It is a reality that doctors who admit patients obviously will make a bigger contribution to any hospital than doctors that don't admit patients. But our first and most important objective is to have a full scope of services available. Because we understand that doctors need colleagues to refer patients to. And if you have a gap in your profile of the disciplines that you offer, it becomes problematic for the specialist's colleagues.
Yes.
So we try to offer the full scope. Our 4 main disciplines are general surgery, orthopedic surgery, gynecology, internal medicine, and pediatrics. Those are the 5 disciplines that we basically have at all our hospitals, except the very small rural ones. At our 20-bed hospital in Otjiwarongo, we only have 7 general practitioners. But we try and aim for the full spread, and then we are very careful when it comes to highly specialized medicine. We don't establish neurosurgery or heart units at every hospital. There are very strict criteria before we will recruit those type of disciplines.
Okay. In your presentation, you made reference to general practitioners aggregating towards rural hospitals as opposed to... Is this really just a function of maybe there being more available in rural areas, or there's if there is a general practitioner who's experienced and in surgical discipline within appropriate scope of practice, with a portfolio to show, would that general practitioner have a chance, as fair a chance as anyone, to get into your hospital?
In general, I definitely think so, Doctor. We do find, however, that in the urban areas, general practitioners seldom admit patients. They prefer to refer patients, and they are normally very busy in their own practices. So they don't always have time to do the surgery themselves, even if they can, or to treat medical patients. They do, however, often support and assist the surgeons in our theatres, But we don't have a policy to say that they are not allowed. And in many of the rural towns and bigger rural towns, general practitioners do admit patients, they do certain surgical procedures, they give anesthetics to patients. So there's not a policy to say they're not allowed to do it.
Yeah, I suppose some of the issues that we come across is whether they don't admit much because it's a question of them not being welcome, or as you say, it's because they have no interest. I asked this question to one of the general practitioner leaders earlier as to whether the reducing share in the RAND, is it because they're just no longer interested in doing procedures that they're qualified for? So I'm noting your question here. But the next question, I would like you to listen to me carefully, because it's very easy to sensationalize it, but it's a genuine question. Then what I want to know is this. When we talk of barriers to entry, is there a race consideration from Mediclinic side in awarding rights to establish rooms within a hospital?
Dr. Bengu, there's definitely no race consideration. We don't look at race at all when it comes to appointing people or allowing doctors at admission rights. Definitely not.
But Mr. Pretorius, isn't that the problem, that there is no race consideration? Isn't that the problem? I'm saying just before lunch, I just went into your website. I went to 3 hospitals. Morningside Mediclinic, of the 141 doctors that are here, I found 7 African ones. We can argue that, how do I know? But by and large, the surname, I'm talking here, Mpofu, Dube, Makosi, Mahlang, so it's quite clear, but give or take 2. And out of the 7, some of them are actually in sessional rooms, which is really not a proper appointment, you know. Now, the question here, why I'm saying I don't want this to seem like a negative question when it actually is a positive one. Because what do I mean? I mean, I do not, or rather I would hope it's not a question that if you're black, you may not get in, but by not considering race, isn't that the issue that Mediclinic, one of our best exports, is missing a chance to contribute towards transformation? Because Sentin Clinic is the same thing. Out of 124, I found 4 Africans. In Constantia Kloof, Constantia Berg, what is it? Yeah. Out of 98 possibilities, I'm finding 1. And this one is a pathologist, which very likely came in as part of a group practice. So my question is, isn't that the problem, that you do not take race into account when awarding rights?
Dr. Bengu, when I said we don't take race into consideration, I mean there is no discrimination against any person or doctor based on race. I can refer you to Mediclinic Limpopo, where you will probably find 100 doctors and more than 50% will be black doctors. I can refer you to Mediclinic Legai, where I think you will battle to find a white doctor amongst the supporting doctors. I can refer you to the Mediclinic Heart Hospital, where we might have 2 or 3 white doctors. I can refer you to Mediclinic Med Forum, where there are hardly white doctors. I can refer you to
Mr. Pretorius, I think that
Mediclinic Muelmet, where you will hardly find a white doctor.
Yeah,
So
I
we have
think
many hospitals that are dominated by
Mr.
black
Pretorius,
doctors.
I was hoping you wouldn't use those examples. There's a reason that there's 100% of black doctors in Limpopo. And there's a reason I asked in the center of Sentin. I asked in the center of Morningside. Now, as I said to you, I'm not honestly believing that people are necessarily prejudiced because they are black in getting rights. I'm just asking if Mediclinic is aware that, like all of us, in terms of positive discrimination, we have an obligation to drive transformation in all our corners, and Mediclinic is a big player. That's the context in which I'm asking. It's not that I'm saying you don't want black doctors in yours. You've given me examples, but I can say that the reason, because in Limpopo, however you look at it, it's entirely black. But as I say, the issue is just to raise and sort of saying it's a question that I couldn't escape when I'm finding not 15 African doctors in 3 hospitals. But it's fine. We can move. I get the point, and it's just one that meant to be raised in the context that, in terms of barriers to entry, we need to be sure there aren't different levels of barriers. Okay.
Doctor, I want to assure you that from our company's perspective, we don't have any policies that would determine black doctors are more welcome than at other hospitals. The examples that you mentioned, we'll have to understand what's happening there, what are the dynamics. Sure. Are there black doctors who've approached us who have been turned away, or are there not black doctors available who want to set up practice there? But I understand your comment in a positive light.
I appreciate it.
The reason why I mentioned those other examples was just to make the point very clearly, that we don't have a view or a policy that black doctors are not welcome at Mediclinic hospitals, because that is not the case at all.
I wouldn't have expected differently. Thank you very much, sir, for answering. Now, in your submission, you didn't necessarily refer to it here. You made reference to the Dubai hybrid model, where about 70% of the doctors you work with are employed. Are the lessons for the South African market here? Because what I would like to know is, for example, where you have employed doctors, which departments are likely to be staffed by employed doctors? Are you seeing differences in clinical outcomes between employed and independent doctors? Are you seeing differences in profits from Mediclinic side, from the group that's employed, from the group that's not employed? Is there anything you can share with us?
Dr. Bengu, that's a very interesting question. The model in Dubai is completely different to the model in South Africa, because if you want to stay in Dubai, you must have a sponsor. In other words, you must be able to prove that you have a job, you are employed. Otherwise, you can only remain for 60 days as a tourist. So we are basically forced to employ doctors. There is a model where they allow some independent doctors, but generally we have to employ the doctors. There are many advantages. The one positive aspect is that it is easy to develop protocols for the clinicians to follow. All those hospitals that we have so-called medical directors that are in charge of the doctors, and the medical doctors report to the medical director. I mentioned earlier that we now also want to appoint medical directors, and we started the process at our hospitals in South Africa. We don't employ the other doctors, so they won't report directly, but this medical director will fulfill the same function. So that's one example of what we learned from the model in Dubai. It is easier, for obvious reasons, in an employment model to get compliance to protocols, to develop those protocols, and I don't want to use the word enforce, but to get compliance from your workforce. On the income or profit side, their tariff structure is totally different, because once you employ the doctor, you now also bill for the services of the doctor. The hospital tariffs and the professional fees are put together into one pool of money, and then you pay the doctors a salary. But employment has advantages as well as disadvantages from a clinical and from a business perspective. But we believe there are more advantages that we've seen, and we actually feel quite positive about the model in Dubai.
Yeah, no, thanks. This one is really about the question in your business units, whether currently or in the past, where Mediclinic has worked and provided a service of assisting specialists with billing in terms of claims. Is this a business that's still part of Mediclinic or not? If not, what lessons, what drove that? What was the thinking behind it? Any lessons there?
Yes, Doctor, you referred to a business that we started a couple of years ago to assist doctors with the administrative function. We believe we have a lot of expertise in back office functions, billing, etc. And that business actually requires unique skills that we don't really have in terms of doctors billing, because that's quite different to hospital billing. But Bram was very involved in the company, and maybe he can share some of the learnings.
Thank you.
Yeah, in conclusion, we don't have that business anymore. We actually closed it down. The reason, it's quite complex. The billing rules around the different disciplines is quite complex. If you only focus on a specific discipline, you can learn all the individual nuances in that discipline, how to bill. But as soon as you do it for all disciplines, it becomes very cumbersome. So there's a lot of challenge, a lot of low value, high volume items that you need to collect, which makes it very difficult to do it. There is other businesses in the market who helps doctors in billing. Probably successful businesses, some probably less successful. I don't know how the business model for those worked. For us, it wasn't really our core business. When we embarked on it, there wasn't to our knowledge, really people in the market who focused and helped doctors with that. Subsequently, there's been new businesses that came up to do that for doctors. So doctors had more choice in the market if they felt they couldn't do it themselves. So from our point of view, we actually exited out of the market. It was never from a making money point of view. It was always for helping doctors, collecting money, try to be more efficient.
Sure. No, we certainly with more, one can understand that it's more a service to the doctors, but from our perspective as well, one has to say, even though this wasn't the intention, is there a likelihood that there might be concerns arising purely from I'll give you an example. One of the easiest ways to see if there is a degree of claims fraud out of theatre would be to see what the anesthesiologist claims as theatre time. The relevance is where that doesn't tally with what the hospital claims as theatre time. So the concern would be, without knowing from outside, is this where there is synchronization of that type of information for a submission to a claim? But I accept that that's not intention, it's a service issue, and it's a question that's relevant only if it's provided by a hospital for its specialists. Thank you very much for responding. Thanks for your presentation. Thanks, Judge.
Get a second chance because I was first in the line. I left a lot of question that I didn't ask and then waited for. Mr. Pretorius, I want to take you back to what you said, that you said if we want to cut back costs, we must keep people out of the hospital. And I want to allude to the fact that in South Africa, the OECD study showed that, but before that has been shown several times, that we have, internationally speaking, quite short lengths of stays, although they are getting a bit longer, and internationally speaking, quite high admission rates. Can you tell us what, to your appreciation, is the connection between the two, and what the background is of these two?
Dr. van Gent, I don't think there is a connection. From our perspective, and I've been in the industry now for 25 years, the length of stay came down over time, I think mainly due to two reasons. Firstly, the introduction of new technology over time. I mean, anesthesiology today doesn't have nearly the same impact on the patient than 25 years ago. So patients recover quicker. Medical technology made it possible.
And quicker than in the US and in Europe.
No, but I don't think we are in front of the US. In the US, they do much more advanced procedures in day clinics today than what we do in South Africa.
But your length of stay is much shorter internationally.
The first reason was the introduction of medical technology, and then when managed care was introduced into our market, the medical schemes with the managed care rules also managed the length of stay down. But I don't think there's a specific correlation between the lower length of stay and the high admission rate. I think the high admission rate is driven by the other factors that we've discussed earlier today. But I would like Roly Buys also to respond, Doctor, if you don't mind, because he was involved in all of this over many years.
Yes, it's actually a very interesting question, and it's not something which is unique, and it's not the first time it's come up. In fact, we've known about this phenomena for quite a few years. Possibly about 8 or 9 years ago, we had a chap called Van Eck and a lady called Bessasar that did an evaluation for the first time between South Africa and the United States to try and understand this phenomena, what's actually happening. So the first thing I think is important to understand is, how do we count? And so, for example, in South Africa, we count maternity cases as, if a woman and a little baby that's born, we count as 1. In America, they count as 2. The only time we count the baby as a separate patient is if there's a complication. So first of all, you have to make an adjustment for that type of counting. The second thing, in America, when they talk about an admit ratio of 150 per 1,000, you have to take out the age group. So all the over 65s are part of a different pool, all the underinsured are part of another pool. So you need to look only at the insured people, a specific age group of people. Clearly within that, there's another counting error that you have to take into account. Not error, but a factor you have to take in. The Americans take all cases under 23 hours. Whether it comes in this morning, goes out tomorrow as a single day case, they're called ambulatory. In South Africa, when we developed the hospital billing system, we created a day case rate within the hospital rate. So we have a rate for a normal general ward, but we also have a rate for a day case, which is why we didn't have the development of the day case industry, the day clinic industry per se. But if you take out the admissions that are day case admissions, you'll drop our admission rate by 30%. So you need to make these counting adjustments, first of all. Secondly, if you want to make the comparison about the length of stay between South Africa and the OECD countries, you need to take the demographics of the South African medical aid population. You can't compare the total population with the total population in Finland or in England. You need to compare the population group that we have with those people so that you can understand the differences. So, for example, if you look at the age, just purely age, you'll find that we have a high children component. In other words, young people under 18, very much higher than the OECD countries. If you come to the older population, you'll find it's much lower. So the length of stay is when you get older. If you have children going into hospital, have short length of stay. So we actually can explain all of this, and we actually have 2 papers, the one by Van Eck and Bessasar, and the one by Insights Actuarial Organization was done for HASA about 2 years ago. I'm pretty sure that both of them were actually submitted as part of our submission, but if they're not, we're more than happy to send them to you.
Very interesting. Thank you very much. I'll look into it again because I read a lot, and I remember I read Insight's your submission on Insight. But I do think in the international, the OECD and the WHO studies, this is a consistent pattern. This is a consistent image that is painted of what is happening in South Africa. And I'll have a look in it because I think it's important for our inquiry to get to get the truth here and what is actually happening. One explanation that has been given consistently also to us is that it is connected to the hospital-centric character of the PMB system in South Africa. So that people get into hospitals in South Africa that actually shouldn't be in, but should be treated in primary care. So that could explain also the connection between the two, Mr. Pretorius. People get in too healthy and get out earlier. But we'll have to, yes.
Yeah, if we can respond to that, I think Mr. Pretorius has been at odds today to actually explain that we think the admission rate is probably too high. There's adequate research to show that if you monitor a diabetic patient properly through primary health care, that the admission rate will be lower. So we expect that to happen. That's exactly what Mr. Pretorius has been trying to say the whole day. So we expect that the current 250 or 260 per thousand, which it is at the moment, would come down if that kind of management system, the integrated system, was in place. However, what we suggest to you is there's these further counting adjustments that need to be made if you want to make these comparisons.
We're fully on the same sheet. Thank you very much. Now, can we maybe get on the same sheet on the next topic, Mr. Buys, because on the issue of collective bargaining of a number of administrators, in contrast to other administrators that do not bargain collectively but assist individual schemes to bargain with you, and your preference to deal with individual schemes for the reasons that you gave, innovation, but I think there must be more reasons that you. Then on the question whether this would constitute a competition issue, you said, I'm not sure. Can I, of course I'm not dealing with your delegation, but I think we have Mr. Berger on the table, who's an expert. And Mr. Berger, would this be an issue that constitutes or that affects competition?
Well, there's always the possibility of an exemption being granted, as we've
right.
already seen that in the industry. But as I understand my client, we're satisfied with the system as it is now. It needs tweaks from time to time, but the post-2004 system is preferable to the pre-2004 system.
Yes. But do you agree that negotiating for a collective of schemes is a matter that should be tested under the competition?
It's problematical. Without an exemption, it'll probably be problematical.
And there is no exemption at the moment, if I'm well informed.
No,
that brings me to the second question on this, Mr. Pretorius. Maybe after being here for 2 years and listening to the hearings at the moment, I find the atmosphere between the hospital groups and particularly the larger administrators quite agreeable. It sort of, I mean, it must have been a subject of your executive talking about this practice of some of the larger, particularly Discovery does this. It negotiates on behalf of its schemes, isn't it? The impression I have is that there's a live and let live type of relationship between the hospitals and the larger schemes, particularly Discovery. Can you comment on that?
Doctor, I'll comment, but Rowley is responsible for those negotiations. But I can assure you that those negotiations are extremely robust. We are often not satisfied with the outcome. We lost a contract recently from a medical scheme who moved their membership over to Discovery, and they immediately demanded a lower rate from us because when we negotiated individually with the scheme, we had a specific tariff in place. Now that Discovery took over the administration, they immediately demanded the lower tariff for their new client, and we said we're not going to give the lower tariff. We have reason to believe that the current tariff is actually appropriate. So what we have a workable relationship, which I think is rather positive, because in our country we firmly believe we have to move the debate from cost only to value. Discovery shares that same vision. We want to contract on value. We have to look at clinical quality, patient experience, and cost. We can't keep on focusing on cost only. And then it is good to have a good working relationship. But we have many robust negotiations, and settlements sometimes happen very late in the year. In our country, the practice developed over many years for tariffs to be increased on the 1st of January every year. And Rowley can never go on leave before Christmas because he's still battling to finalize the negotiations. So the negotiations are very robust, but we still have a workable relationship. Would you like to add, Rowley?
Yes, I think it's not just about the negotiation platform that you have. You must understand we live within a framework where we have to look at the benefit designs as well. And so I would suggest to you that the negotiation framework is equally difficult for us with a small scheme, especially if I say to you that they want to put in a network and we will not be that network. So we have a tiny little scheme up in Mpumalanga where we were arbitrarily told that we are not the network. And consequently, that business is lost to us. So in the hospital business, as Mr. Pretoria has explained, the focus for us has to be volume first rather than price. And so we have to keep that delicate balance. So we are looking at every single medical scheme to see how we can fit the needs and how we can measure. The circumstances are also complicated by the fact that a hospital cannot go into a tariff negotiation arbitrarily just thinking about themselves. At the end of the day, we also have doctors that work with us. And so you can imagine for a moment if we decided that, you know, we didn't like this particular medical aid, we didn't like their offer at all, and we wanted to tell them to go and play in the sandpit next year. That's possible for us to do. But what would happen to the doctor? Because the doctor would see that patient, and now suddenly that patient's in our hospital, and we tell him, well, we're not. You understand? There's this intricate relationship that we have to keep in mind. So it's more than just that. So it's about the benefits, about the doctor, about where do we want to go. And I think our colleague Adam Powell expressed it. We have a long-term relationship. At the end of the day, hospitals get built. They get built with a 30, 40, 50-year-old lifespan. They are not in the business just for next year. So you're actually thinking towards a longer-term deal, a 2, 3, 4-year plan ahead of you. It's not just about a chessboard right now.
Thank you very much for your answer. Thank you. It's clear.
We were told by the South African SAMED, South African Medical, anyway, the suppliers, medical devices, that both you and another big hospital group have an inventory system, and they have to be paid to be part of that system, and that the amount that you are required to pay depends on the volume that you purchase from them. Now, I suspect there's nothing particularly illegal about this, but it might be an expression of market power because they have to sell to someone and they want to sell to big players. So do you have any comments on this?
Professor, I'll ask Bram to comment.
Professor, yes. The pharmacy world have thousands and thousands of items. All of those items are built through NAPI codes. All NAPI codes needs to be vetted from, is it a valid medicine? The prices are attached to that, etc. So all our hospitals procure on a daily basis medicines. We use a switch, which we call, it's a third-party product. We decided we can't do all that interaction and buying, etc., with a manual paper-based system. We have to have a computer system that can track the prices, that can track the orders, the volumes we receive. So if we have contracted with this third party called OrderWise, it's basically a switch. Our system talk to that switch, and all the suppliers' systems then need to talk to that switch. Otherwise, we have to integrate our system to all the different pharmaceutical companies. So this switch do different things. It makes that our system talk to the pharmaceutical supplier. It vets the prices. So when we contract with the suppliers, the system check that the supplier charge us the contracted price. So there's a lot of functionality in this so-called switch. We pay also for that switch. And we expect that if a supplier do business with us, they work through the switch for efficiencies. We get efficiencies, the supplier gets efficiencies. The supplier do not pay us. The pricing structure is such that the smaller player with lesser volumes pay less, and the player with higher volumes that do more business pay more to make the switch more affordable.
They do experience that, particularly for new and local companies, as a barrier to entry.
There is a system where they teach you how to make it. The small companies pay 400 Rand.
Maybe they're very small. The other question, I'm sorry, I forgot to ask, was the same question that I'd asked the other company, and that is the shortage of doctors and the fact that the private sector, as much as all of us, have a responsibility to for people to realise their right to healthcare. And in that regard, we are aware that doctors who are in full-time, sometimes part-time, but it's the full-time doctors in particular, employ of the public sector, in some cases have agreed agreements to work in the private sector, and that many of them might do this exactly correctly, but some of them might in fact be working in the private sector when they should be working in the public sector. And I know different provinces have different rules, but there are provinces that only allow this out of working hours. And if I'm correct, that is the Western Cape, but I've been out of those discussions for a while, so I'm not sure. So in terms of your own operations, if you are operating in a province where it's only out of normal working hours, and they're going to operate in your hospitals, it means your hospitals have to run your theatres, for example, either very early or very late or on weekends for them. Otherwise, by definition, they are defrauding their employer. So are you aware of this? Do you monitor it? Do you consider it your responsibility to monitor it? And is it included in any of your discussions around licensing or your licensing agreements with the provinces?
Professor, we are aware of the whole RWAP's dispensation and all the problems around this whole concept. And we have been approached by various provinces to assist them to monitor the hours that RWAP's doctors work at the private hospitals. It's not discussed as part of the licensing regime, but what makes it very difficult for us in the private sector is that we don't have the information of what is allowed for the specific doctor. We can also only monitor work that is being done at the Mediclinic hospital. So if a specific academic doctor is allowed 20 hours work in the private sector and the doctor works 15 hours with Mediclinic and 15 hours at Netcare and 15 hours at Life Healthcare, we won't know. So generally, we don't have the correct information. We firstly don't know what is permissible. Secondly, we can't monitor the total work in the private sector. And thirdly, we don't have any legal right to intervene or to monitor, because there's a very specific employment relationship between the government or the province and this specific doctor. So strictly speaking, the responsibility to monitor the hours of which the doctor should work at the state hospital is the employer's responsibility.
I agree it's the employer's responsibility, and I'm not asking you if you monitor what the doctors do outside of Mediclinic. All I'm asking is, do you ever ask for proof of their RWAP agreement, and do you monitor the hours, and would you be willing, if requested, to provide that information?
I'll have to check at the different hospitals, but my perception is that we don't ask for that information and we don't monitor it. But if we are asked to assist with the part that we can, we will be willing to do so.
Maybe, Mr. Berger, you can just help me. If I'm committing this fraud, I think it's fraud, and I'm committing it on somebody else's premises, does the person who allows me, is it only my responsibility, or is it a legal issue for the person who allows it to happen? Are they complicit?
Well, not if they're not aware of what's happening. In a constitutional setting, I think because we're dealing with health rights, that's a right affecting both private citizens and the state. Socioeconomic rights, so we've got certain responsibilities as a private citizen. And if we willfully take part in that, we might well be guilty of negatively infringing the citizens' right to health services, because they take out of the public centre a utility which should be in the public centre. But this is typically a private employment contract, and personally I would think it's maybe awkward for Mediclinic to ask a specialist for his employment contract with a province to monitor whether he's not stepping out of line. I'll take umbrage at that if I were to be the specialist, but then I may be oversensitive.
It's been a very long afternoon indeed, Mr. Chuper. It is an afternoon, though, which is about to come to an end, subject to this one or two questions, and depending on the answers one gets. As is always the case in matters of this nature. But let me, first of all, assure you that the stakeholders' views on what drives the cost is not going to end this inquiry. Our task goes far beyond just determining what drives the cost. We have a far more important task than that. I thought I should make sure that you understand that. But let me pick up on this last point. Does it happen that these doctors or specialists would work at a state facility during the day, and then in the evening they come and work for you?
Chair, that can happen, yes.
Yeah. So that individual, that doctor, would have been working more hours than one would have expected of a doctor, would he?
I think that will depend on the situation, because the way I understand RWAPs is that even during normal working hours, the doctors are allowed
leave aside
to spend a certain percentage of time on private.
No, leave aside Arwood. I'm just talking about this individual doctor who would have been working at a state facility during the day, and then in the evening goes to Mediclinic facility to work a couple of hours. He would be tired, wouldn't he?
It could be, Chair.
I mean,
yes.
does that not put the lives of patients at risk, though? Doesn't?
Chair, that will depend on the situation. We have doctors in the private sector that work long hours. Most of the doctors don't only work from 8 to 5, and I think the ability of doctors to work long hours also differ between individuals.
Mm-hmm.
And it's very difficult for us to monitor that for our own private doctors as well as the ones who work in the public sector.
I understand that. I do understand that doctors might be held up in some complicated operation for hours. But I'm just talking about this doctor who has 2 jobs, one at a public facility, who works during the day, and then in the evening goes to Mediclinic, start another job, where he has to keep a couple of hours. So what I'm asking you is, in those circumstances, if you have a doctor who works those long hours, does that not put the life of patient in danger, though?
The way you describe it, Chair, it could definitely happen.
But unfortunately, you have no mechanism for monitoring what the doctor has been doing during the day. You don't look at their conduct from what you said. But are there any mechanisms that you've put in place just to make sure that that doesn't happen?
Chair, we don't have a mechanism in place at the moment because we don't have that information and we don't know how many hours the doctor has worked already during the day.
Yeah. But to the extent that it is a possibility, don't you think you should perhaps put some measures in place?
I think we should.
Yes. I understand. Yeah. Now, you mentioned that you engage with medical schemes on behalf of patient. I mean, that's laudable conduct on your part. And that you, in actual fact, you act as their agent, right? Now, we've been told, for example, that I think it was yesterday or the day before yesterday, I've just lost count of the days, but what we were told, for example, is that there were members with severe injuries and who required some medical attention, who had been pleading with a medical scheme for over 2 to 3 years, getting them to pay. How successful are you in getting the medical schemes to pay?
Chair, I think we deal with those type of cases from time to time, and Rowley is sometimes personally involved to get accounts paid. So with your permission, may I ask Rowley to respond?
Yes, certainly.
I think we just have to put context to it. I think if I listen to that interview, I think that many of those accounts that were paid were from private practitioners, physiotherapists, and the like. They were individual practices that submitted accounts. Very different from...
No, let me refresh your memory of the facts. The claim was lodged with the medical scheme in September of 2012. Nothing happened. They didn't pay. On the 13th of September, in September 2013, the matter was reported to the Council for Medical Schemes. It took 11 months for the Council of the Medical Scheme to resolve the matter. There was an appeal after that, which was withdrawn in July of 2014 or 15, I think it was.
Let me start again.
Yeah.
With respect to hospital accounts, we have a very fast and efficient system between some of the administrators, less efficient between others. We call it business to business and client. So with the biggest administrator, we have the business to business, which is an automatic system. We will update it in terms of pre-authorization, in terms of length of stay, level of care. We have criteria for ICU, which we agree with them and which we send the messages. The moment the patient is discharged in our system, we will final bill and send that account to the administrator. In this particular case, I have seen accounts that within 4 or 5 seconds and possibly even a minute come back to us and give us a clear indication whether there are any items on that account that they don't like. In other words, we have an adjudicated account. So if I look at my account,
I understand. I mean, all I want to find out is how successful are you in acting as an agent for your patient to get medical aid to pay? Because I want to, so that we can see whether whatever tactic do you use can be used by the members as well.
Okay, I think I've suggested...
We're not suggesting that you should do that for everyone else. We just want to make use of your expertise.
Sure, I understand.
Yes.
I think the tactic is what I've described. The result of that is that our debtors get paid almost within 2-3 days with many of the medical aids. We get paid at least twice a week. We manage our debtors' days constructively in the company, and we look to have our debtors' days somewhere between 16 and 25. So we're very efficient. As I explained to your panelist on your right-hand side, that the amounts of money that we have in dispute are about 2 to 3% at the maximum, and normally those are deductible. So we do not have the same kind of problem that you speak of. We have our accounts paid, and we certainly don't have a waiting period of 2 years.
I have no doubt you don't have that problem, but all I was trying to find out is what are the tactics. But anyway, let's leave that aside. Does an issue such as this come up in the negotiations?
Yes, it does. It's very much part of the negotiations. In medical aids that are that efficient with us, we're prepared to look at the relative value of tariff. We also have settlement discounts in place with medical aids to ensure that they pay promptly and fast. We have penalties if they don't. So it's a very important part of our process of negotiation.
And what's the attitude of the schemes?
With the settlement discount and the penalty. Most of the medical schemes like it. They use it as a mechanism to manage their administrator, because they want to see the discount come into their books. They don't like to see a penalty come into their books. And so when they see that change in their financial statements, they're very quick to manage their administrator.
The penalty, is it something that's built into the agreement?
That's correct.
Yeah, okay. Now, if I can just draw your attention to slide 25 and 26. I think this is where you talk about clinical quality information, I think it is.
That's correct, Chair. I'm not sure whether I can go back on the presentation.
It may be complicated. Well, let me tell you what these slides are about.
I've got it in front of me.
Yeah, okay, very well. Yes. It's about clinical quality initiatives.
That's correct, Chair.
Now, you told us that the result of these initiatives are shared with the doctors. Is that right?
That's correct.
And then you then went on to say some of the results are shared with the scheme, not all the results.
I actually meant that the results are shared with some of the schemes.
I see. Oh, I understand. Yes. I understand. So you would share those results with the schemes that you have an agreement with. I understand. Okay. Now, but this is not what you would share with the patient.
At the moment, we share these results at an aggregate level for the group in our annual report, which is also available on the website. But that's the discussion we had about making this more patient-friendly for patients to understand and making it available to the patients.
And then it was only in 2014 that you started conducting surveys on patients. Is that right?
Chairman, we started conducting surveys many years ago.
Many years.
Yeah, we first did it in-house, then we outsourced it to a local South African company, And then our international group took the decision to move to Presgani. So Presgani was only implemented in 2014. But we always had systems before Presgani.
And then the results of those surveys are not shared with the patients.
It's not shared at the moment, but that's where I also referred to the fact that our executive in Mediclinic Southern Africa has already made an in-principle decision that we are going to share it, and I gave a commitment within the next year.
Sure. Now, when was that in-principle decision made?
Probably 4 or 5 months ago at one of our executive committee meetings.
And what was the reason for the change in attitude?
We believe that it is the right thing to do. We've always felt that the information should be available to patients. But as we discussed earlier, the context must be so that everybody feels safe about sharing information, that it is comparable. But we decided even if there is not this safe context from a regulatory perspective, it is the right thing to do, and we want to do it, and we are going to do it in future.
Now, you see, I want to understand whether, firstly, what were the obstacles that prevented you from sharing this information with patients? You're saying that you've always believed that this is the kind of information that should be shared, but nevertheless, you didn't do that. So what I want to find out is, what was the motivation for the change in attitude, which occurred about a couple of months ago? What made it to change?
Our strategy about putting patients first.
Right.
Because fundamentally, we believe it's the right thing to do.
I understand.
And we believe healthcare must be more transparent.
Yeah.
And patients must have access to information.
Yeah.
And we believe if we can share this type of information, it will show that we are serious about our strategy, and it will enhance our relationships not only with patients, but also with the supporting doctors and the medical schemes who will hopefully acknowledge our improvement in quality and patient experience when it comes to tariff negotiations.
Were there any factors that operated to influence you not to share this with patient previously?
Chair, there were no specific factors, no.
So we can only attribute it to a change in strategy.
It's just, from Mediclinic's perspective, we refocused our strategy on patients first, and one of the building blocks to support patients first is to provide patients with information. Yeah. So it was an internal decision that we took in terms of the strategy.
Yeah. And now you're now going to make this available, but of course you're still reflecting on this. Yeah. Other specialists are consulted, are they not, when a decision is made whether or not to grant another specialist admitting rights?
That's correct, Chair.
You were present when I drew attention to the experience of that psychiatrist who was initially granted rights by the facility, but when a colleague objected, the manager withdrew those rights. You are aware of that. Isn't it, how do you feel about that? Isn't it too much to expect of specialists to say that they must decide whether or not to allow more competition?
I think, Chair, as I explained earlier, the final decision is the decision of the hospital. Mm-hmm. But we believe that the specialists in the discipline must be consulted. Yeah. It is responsible to get their views and input because they are the experts in the field. I think in the example that you mentioned, it was not handled correctly because you cannot allow admission rights and then take it away after other specialists object afterwards. The consultation process in this specific example was probably not followed correctly. The consultation must first take place, and then a well-informed decision has to be taken before the new specialist is informed.
So you make a decision after consulting the other expert. You do not make a decision in consultation with. I think Mr. Becker will explain that to you.
Yeah, we go through the process of the consultation and the referral to the hospital committee to check the credentials as well, and then we make a final decision.
Yeah, and then in relation to information on private healthcare services, you mentioned that what is required is an independent body that will be responsible for regulating the collection and the dissemination of this information. Now, are you aware that the National Health Act make provision for collection of information, as well as and what needs to be done? The first provision that deals with the matter is Section 74 of the Act, which says the national department must facilitate and coordinate the establishment, implementation, and maintenance by provincial department, district health council, and private healthcare sector of health information system at national, provincial, and local level. And then it goes on to say, the minister may, for the purposes of creating, maintaining, and adapting database within the National Health Information System contemplated, prescribe categories, the kind of data for submission and collection, and the manner and format in which and by whom the data must be compiled or collated and must be submitted to the National Department. You aware of that provision?
Chair, I wasn't personally aware of the provision, but I'm sure my colleagues who deal with the legal matters are aware.
Yeah. Okay. And then of course, this Section 74 must be read with Section 90, subsection 1U, which now empower the minister to make regulations which will deal with the collection of this information in terms of the format. Would that be satisfactory for you?
Chair, is this actually part of the scope of the Office of Health Standards Compliance?
No, it's a provision in the National Health Act.
I think we'll have to study those
Indeed,
requirements because our view on the collection of data for purposes of reporting publicly is that it should be done independently, independent of the minister and independent of the private sector. In other countries, these bodies who ensure quality are often totally independent. They don't fall within the jurisdiction of the Ministry of Health or the Department of Health. Yeah. So I'm not sure in terms of the Health Act what the purpose for the collection of the information is that you are referring to. If it is for us all to report on the same methodology with the view of publishing, I think the best option would be to have a totally independent body to develop the standards, to do the inspections and the accreditation, to develop the methodology for reporting, and also then to govern the way in which the information is then reported.
And what this provision also contemplates is that the information so collected will be published in the public interest. So it contemplates that the information or some of the information will be published, in the public interest. And presumably that's so that the public as well as the consumers might have access to that information. But you haven't applied your mind to those provisions.
Chair, we'll go back and we will apply our mind, but the one aspect that we have applied our mind to is the fact of independence. Because if the scope of the Act is covering public and private sector, but the authority to collect the information and to publish the information is within the public sector, it might create a conflict of interest.
Well, I think it does contemplate that there will be a particular format that's being used, and presumably there will be draft regulations which will be published, which will describe how the information will be collected. And then, of course, that will be the opportunity, as I understand it, for the stakeholders to comment on the methodology and whether or not they consider that methodology to be the kind that is acceptable to them. So perhaps you may want to apply your mind to that particular provision.
We will do so. Thank you, Chair.
Yeah. The other matter that I wanted to raise with you, it really relates to the licensing. I mean, at the moment, we know that each province, considers whether or not to grant a license. And you've mentioned the different criteria applied by some provinces. I mean, to what extent does that impact on your ability to expand?
Chair, it does impact. We looked at our license applications in one province over the last 5 years. We had 24 applications, and I think 5 or 7 applications were approved unconditionally. Another 11 were approved conditionally, and the others that we took on appeal, I think 2 or 3 were approved. So we have a situation where some license applications are not approved. Having said that, if you look at the healthcare market at the moment in the South African context, there are not many new hospitals that are being developed. The market is mature, the economy is not growing, the medical scheme population is not growing. But at the moment where we have more problems is where we want to change existing hospitals or where we want to expand existing hospitals. We don't have plans in the immediate future to develop many brand new hospitals because the market simply is not there at the moment. But I think the system has to be corrected so that there is consistency in the application of the criteria and the interpretation of this question of whether there is a need for the license, for the additional beds or not.
We had conflicting views from the provinces, in particular on the issue whether or not they have the power to amend Regulation 158. Other provinces took the view that they have the power to do so, while others took the view that they don't have the power to do so. So I think it's one of the issues that perhaps might require your attention.
Chair, at the moment, 8 of the provinces still apply Regulation 158, but the Western Cape developed their own regulations, R187. So I'm not sure whether they have the power or not. I don't know. We'll have to ask our legal experts.
It's a very complex question, Mr. Skarpberger, isn't it? Because these are powers that were assigned to the provinces under the interim constitution. And I can't recall whether or not once those legislation have been assigned, they have the power, to amend those laws. But KwaZulu-Natal, for example, told us that they don't think that they have the power to amend those regulations, whereas the Western Cape took a different view. And
There
then
may,
another,
also be there may also be an attitude that R158 has been repealed in 1977.
yeah,
So you don't have to amend it. There's nothing to amend.
yeah. When was it? Well, but
I think it was repealed with the Act in 1977.
no, but it is the regulation that is currently in force, which is applied by the provinces in deciding on the licenses. So that's the position as it stands at the moment. I think the last time it was amendment. It would have been sometime in March 1993. I think it was just before the advent of the new constitution.
Yes, but that regulation was promulgated under the 1977 Act, which was replaced by the National Health Act.
But it was assigned under the interim constitution for administration by the provinces. And from that date until 2003, when the National Act was promulgated, there were no regulation, and therefore it continued to apply. And then, which is why at the sections 36 through 40 of the National Health Act were brought into operation on the 1st of April 2014 in circumstances where there were no regulatory framework. As a result, the Constitutional Court struck the bringing of that into operation invalid, reverting the situation back to the regulations. So that's why I believe they are adhering to those regulations with these conflicting results. Yeah. I think it's a matter that you would have to look into. Now, is there any other matter that you had set out to draw to our attention which perhaps you have not had the opportunity to do so?
Chair, there are no further matters that we wanted to discuss during this round.
Yeah.
With your permission, I just want to use the opportunity to thank the panel for allowing Mediclinic the opportunity to do the presentation. We experience the engagement as positive. I think the bigger healthcare industry in South Africa needs this type of dialogue. There are many issues, and I think Dr. van Gent highlighted the fact that as a collective, we'll get more done than individually. These issues of making information available, publishing quality and patient experience results, I really think requires a collective effort from the whole industry, because the whole industry, not only providers, the funders, everybody, the doctors should think about putting patients first. And if that is the mindset with which we approach these discussions, I think we will be able to find solutions. So thank you very much for affording us the opportunity to be here.
We're also grateful that you were able to come here and share with us, how Mediclinics operates and some of the challenges that you face in the course of interacting with other stakeholders. Thank you very much indeed. Thank you. I think we will meet tomorrow at the same time at 8:30 in the morning.